Good morning, everyone. Please take your seats. We're going to begin momentarily. Thank you. Please take your seats. Thank you. You can keep talking. Just take your seats. Thank you.
Hello, everyone. If you can get seated, we're going to get started in about about 30 seconds. Hi, everyone. Please take your seats. We're excited to get the program started. We have our secretaries and our speakers here. Okay. Okay. Aloha and good morning, everyone. My name is Crystal Ka'ai, and as the Executive Director of both the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders, or what we call WHIAANHPI, as well as the President's Advisory Commission on Asian Americans, Native Hawaiians, and Pacific Islanders, it is my honor to welcome you to today's AA and NHPI Mental Health Summit. Thank you. Both the White House Initiative and the President's Advisory Commission on AA and NHPIs are housed here within the U.S. Department of Health and Human Services and co-chaired by HHS Secretary Javier Becerra and U.S. Trade Representative Ambassador Catherine Tai. We also have sister White House initiatives for the Black, Hispanic, and Native American communities that we work closely with, which are housed at the U.S. Department of Education and chaired by Education Secretary Miguel Cardona. We are extremely honored to have both Secretary Becerra and Secretary Cardona here with us this morning, and I want to thank them both for their tremendous leadership. Today's event is being hosted in collaboration with the U.S. Department of Health and Human Services Substance Abuse and Mental Health Services Administration, or SAMHSA. And we want to thank Assistant Secretary Miriam Dolphin-Rittman and her incredible team at SAMHSA for their invaluable support to make this event a reality. I also want to extend my gratitude to our WHIAANHPI team who have been working tirelessly behind the scenes, as well as to our partners in the National Science Foundation who have made it possible to provide refreshments as well as this event's lunch later today. Our summit is focused on improving equity and access to behavioral health care for our diverse Asian American, Native Hawaiian, and Pacific Islander communities. And it stems from a recommendation made by President Biden's Advisory Commission on AA and NHPIs to ensure that the mental and behavioral health needs of our communities are elevated at the highest levels. We have a few of our commissioners in the audience today. In particular, I want to recognize Commissioner Mia Eves Rubley and Commissioner Grace Huang, if you could both raise your hands or wave. And so I want to thank them both for being here on behalf of the Commission. Everyone in this room knows how important and essential mental health is to our overall health and well-being. And as we observe National Minority Mental Health Awareness Month, it is critical to remember that stigma and barriers to accessing care continue to exist for far too many communities, including AA and NHPIs. In addition to facing the disproportionate health and educational and economic impacts of the COVID-19 pandemic, which took a particularly devastating toll on Native Hawaiian and Pacific Islander communities, many Asian Americans also faced a pandemic of hate. These dual crises had a significant impact on the mental health and well-being of our communities, and they underscored how critical it is to provide access to culturally and linguistically appropriate, community-based behavioral health care. But these challenges did not begin with COVID. In fact, many of you in this room have been working to address these long-standing barriers for decades. So we hope that today's summit will be a turning point as we work together to address the mental and behavioral health needs of our AA and NHPI communities. So thank you again for joining us today. It is now my honor to introduce our WHIAANHPI co-chair, Secretary Javier Becerra. Secretary Becerra was appointed by President Biden as the 25th Secretary of the U.S. Department of Health and Human Services and is the first Latino in history to hold this office. Throughout his distinguished career, including serving as the Attorney General of California and over 2 decades in the U.S. House of Representatives, Secretary Becerra has consistently broken down barriers and championed policies that center underserved communities. So without further ado, I'd like to welcome Secretary Becerra to the stage.
Crystal, thank you. Actually, the introduction almost gets better every time I hear it, so it's pretty good. How's everyone doing? Have you had your coffee? How many of you, by chance, just got into town? How many of you are coming from west of the Mississippi? Yeah. How many of you are coming from my beautiful state of California? There, okay. Every state's beautiful, but I had to mention California. I want to say thank you to you, especially for those of you who've traveled. How many of you have traveled from outside of the U.S. to be here? We need to thank them for making the effort. Thank you very much. Crystal, thank you very much, especially not just for helping pull this together, but for being the real driver of our commission that helps us address the issues for Asian American, Pacific Islanders, and for Native Hawaiians. Because if it weren't for the advisory commission that the president set up, we wouldn't be doing this. Well, maybe we would, but it was because the commission said, when will the federal government, when will the Department of Health and Human Services do a session that focuses on AA and NHPI communities when it comes to mental health? We've been doing a lot on mental health, and I want to give a big shout out to our Assistant Secretary, Miriam Delphin-Rittman, who runs our SAMHSA program, because we have been doing, yes, tremendous things. But it wasn't until the commission put it on us directly and said, you've been going around the country, and I have, talking about mental health, and I have. When are you going to do it as the co-chair of this advisory commission, using your position as secretary of HHS specifically for AA and NHPI communities? That's why you're here. And so, Crystal, I hope we will say thank you to Crystal Kai for everything she's doing to make sure that all communities are represented in these efforts. I know I'm going to get shoved off stage briefly because, shortly, because you've got the Secretary of the Department of Education, Mr. Miguel Cardona, who's going to be coming up to speak, and so I don't want to get in his way. He's a good friend, and he's got some great things to talk about how the Department of Education is dealing with mental health. And you know what? That's absolutely the way a Secretary for Education should be working, is to deal with not just the 3 R's, but with things like mental health as well. And the good thing is that his great agency is partnering with HHS in so many ways to address healthcare in our schools, including with mental health. So I'm going to be moving over in just a second for him to say some remarks. But I do have a couple of things I want to say, but more importantly than say, I ask you to listen. Because quite honestly, that's what so many Americans are asking you to do, is just listen. If you listen to the silence, sometimes you'll see that I'm hurting. If you listen closer to the way I just said something, you'll understand that I'm hiding the pain that I'm suffering inside. If you listen closely, you'll see that because of stigma, I'm afraid to tell you more. So I hope you're listening, because about 9 of every 10 Americans right now are shouting to the world that America is facing a mental health crisis. If you listen closely, you'll hear the final shout of that one person who committed suicide in this country, where about every 11 minutes, an American is committing suicide in this country. You'll hear the final shout of the more than 100,000 Americans who committed suicide last year. Just listen. They're talking to us. But are we listening? I hope today you're here to listen and learn. And we're very fortunate. We're joined by a couple of leaders who, for their age, have many decades still to do a lot of great work. Jessica Louie and Wesley Chen, who, by the way, just by chance are from California, are going to be speaking today. They are advocacy interns at the Prevention Institute in Oakland, California. And proudly I say to you that they are on their way to being leaders who listen. And so if you're listening, you'll hear that more than 5,000 times in the past year, Americans called us, reached out to us through 988, and I'm sure you all have heard of 988, 5 million times. People reached out and connected with us by reaching out by 988. Not just by phone, text, chat. 5 million times. That's 2 million times more than the previous year. before 9/88. Here's a good thing. They heard us. They listened, and they called. They texted. Now we have to make sure we follow up, right? We're there for them because they took the moment in that fork in the road when they were about to say, why? Why go another day? They took a moment, and instead of taking that fork in the road to say, not another day, they said 9/88. Fortunately, someone listened on the other end of the line. We're saving lives. You're saving lives. And so I hope you understand how important this is. And I hope you've understood, if you've listened, that I didn't say 988 is helping AANHPI, that every 11 minutes someone in the AANHPI committees. Depression doesn't discriminate. Anxiety hits everyone. The stresses of life, the conditions that require mental health care hit us all. But too often we haven't listened to those who are hurting in the AANHPI community. And so that's why you are here. But we're here to help Americans. It's just that we want everyone to know that among those Americans are folks from our communities. And so it is a treat to see all of you here, even if you're not from California. And we're going to treat you to some good information. So please, listen. And then let's teach, and then let's help. There are a lot of folks who just want to know that we listened. I hope you'll next listen to a great leader of this country who has been working with children most of his working career and is now, fortunately for us, someone who champions the cause of education for all kids in America. And I have a special relationship with him because he's a little bit better than me at dancing, I think, at salsa, and I could probably beat him in some eating of hot foods, even though he's Latino. He's Puerto Rican, so they don't eat the stuff with the hot food. But we have a good relationship because I think we understand what our backgrounds have taught us, and that is, even though we're Latinos, but we come from different communities within the Latino community, we have many of the same experiences. And so when he speaks, I listen because I know I'm going to learn. Even though I feel like he's my brother, I know I'm going to learn, so I listen. And fortunately, the U.S. is blessed to have a secretary of the U.S. Department of Education who knows what he's talking about. So please, when he comes up, listen closely. Let me introduce to you now a great friend, but more importantly, one of the greatest leaders that this country has had a chance to see leading our education efforts. It's el secretario Miguel Cardona. By the way, I could be wrong. Maybe he does like hot salsa and all the rest. I don't know.
Thank you. Thank you. Thank you, Secretario. Yeah, I'm more of a Tabasco guy, you know. He likes the mole, I like the adobo. But the reality is, look, we're in this together. And Javier, Secretary Becerra, has been a great friend and someone that I have had the privilege of working closely with. Health and Human Services and education, they go hand in hand when we're talking about our kids, right? And I'm fortunate to have a partner in Javier, and someone that knows DC pretty well. He's had over 2 decades of service here, and I'm the new kid on the block here in DC. So it's helpful to have a mentor like him showing me the ropes in DC so we could get the job done for our students. So thank you, Secretary Becerra, for the kind introduction. And I also want to thank the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders for organizing this important conversation around mental health. I know we said thank you before, but she deserves it again. Crystal Ka'ai, let's give her a round of applause. Thank you. And I also want to shout out a good friend of mine from Connecticut, Dr. Miriam Delphin-Rittman, who you'll hear from a little bit later. Miriam and I were commissioners in Connecticut when the pandemic hit, and daily we were on phone calls trying to make sense of what's happening and helping Connecticut rebound. And without question, her leadership and her passion for addressing mental health needs in Connecticut is part of the reason why the president recognized her and asked her to come to DC. So great to see my good friend, Dr. Miriam Delphin-Rittman also. You're all here today because you recognize the mental health crisis facing our nation, and particularly our youth. You know that it's urgent. And through your lived experience in your work, you know that our approach to supporting mental health of Asian Americans, Native Hawaiians, and Pacific Islanders is grounded in each of the community's needs. While our AANHPI people are beautifully diverse, and the community is not a monolith, there are unique experiences that contribute to the community's health. For example, during the pandemic, we saw a horrific rise in anti-Asian sentiment, including increases in verbal and physical assaults against AANHPI community. As an educator, I think about how this impacted young people in particular. Not only were our AANHPI young people battling the daily uncertainty of the pandemic itself, but many were also living in fear. That's heartbreaking, and that's unacceptable. It's no wonder there were steep declines in mental health across our Asian American, Native Hawaiian, and Pacific Islander population, with so many people feeling anxious and depressed. But as is often the case, I found inspiration and hope in our youth. And let me tell you, there's no movement in this country that's not led by our youth. Oftentimes when we're feeling down or we're feeling overwhelmed with what we're seeing, turn to our youth. They'll lift us up. They always do. They always do. It was great to meet the two that came from California. There's one there. Where's the other? There you are. Came from California. You don't realize this. You know, you see a bunch of people in suits doing different things. You inspire us to do what we do. You're the reason why we do what we do. Let's give our youth a round of applause here. AANHPI students across the country began organizing and raising their voices about what they needed to support their health, their safety, and their well-being. And a coast-to-coast movement was born. Student activists of all ages rallied their communities. Together, they envisioned a future that includes strong and supportive systems, particularly in schools, that uplift, that empower, and that build real connections for AANHPI young people. A future where they could see their experiences, their culture, and themselves in what they're learning in school. And opportunities that go beyond a month-long heritage celebration. It has to go past that. A future where they had safe spaces in their classrooms and in their communities to heal and to grow. A future where they can access mental health supports in school and where their states and districts would be equipped with the resources to make it possible on a much larger scale. AANHPI students raised their voices, and the Biden-Harris team heard them loud and clear. As Secretary Becerra said, it's really important as leaders that sometimes we just stop talking and start listening. And we heard our students. We know that access to proactive mental health supports can be a game changer for students. That means we must work together to build capacity, to grow the mental health profession, and to focus on sustainability. And so those are our focus areas at the Department of Education. We're working to increase the number of school-based mental health providers by 14,000. We're supporting states and districts to use unprecedented federal pandemic relief funds to ensure students learn in a safe and healthy school. There was $130 billion for the American Rescue Plan that was passed within months of the president taking office. And we encourage strongly that those dollars be used to support the mental health needs of our students and our adults. And we're making it easier for health and mental health services to be delivered at school and to connect students and their families to care in their communities. The full-service community schools, which are often connected to school-based health centers from the community, the funding went from $75 million to $150 million in just 2 years because we recognize how important that is. We worked really closely with Secretary Becerra's team to try to make Medicaid reimbursement a simpler process so when students have behavioral health needs, They're going to get, the districts are going to get reimbursed to make sure the students get the support that they need. That's long term. That's for multiple generations. And that's not to mention the $2 billion in the bipartisan Safer Communities Act that provides mental health supports for students. As I said before, it's going to increase by 14,000 the number of school social workers, school counselors. That's what our kids need. We need to do better. We need to do better. If we reopen our schools and go back to the systems that we had in 2019 before the pandemic, we're failing our kids. They deserve better, and we're fighting to get them more. We're listening and we're learning. We're co-creating a future where all school communities are welcoming and affirming places where students feel safe, accepted, and empowered. A future where students receive the services they need and parents are enlisted as full partners in their child's education. A future where every student is supported and cared for. In 2021, Mina Fedor, just 14 years old, rallied against the rise of xenophobia and racial discrimination alongside her organization, AAPI Youth Rising. In an interview, Mina gave a piece of advice that I want to leave you with here today. Don't feel like any action is insignificant. Being here is significant. Being you is significant. Your work is significant. I always say, no matter where you are, never change your stripes. Be who you are. That's empowering. There are youth that are watching you, seeing what you're doing for your community. And while it might seem tough sometimes, just know that an impressionable youth is watching you to see the leadership you take and the pride you take in your culture and being unapologetic about that. That's what makes this country special. You are leaders. You're helping to repair the cracks in our system of care in this country. But importantly, you're also building foundations stronger than ever before. Foundations of safety, acceptance, and understanding, of love, engagement, and support. Foundations that uplift AANHPI, students, and all of us. I'm proud to stand with you, and I want to thank you for joining today, and I hope you enjoy the rest of the summit. Thank you. Thank you.
Thank you so much for those inspiring words, Secretary Cardona and Secretary Becerra. Now it is my pleasure to introduce someone you've heard a lot about already, Dr. Miriam Delphin-Rittman, who is the Assistant Secretary for Mental Health and Substance Use in the U.S. Department of Health and Human Services and the Administrator at the Substance Abuse and Mental Health Services Administration, or SAMHSA. Dr. Delphin-Rittman has extensive experience in the behavioral health field, including serving as Commissioner of the Connecticut Department of Mental Health and Addiction Services, and as an adjunct associate professor at Yale University for over 20 years. At SAMHSA, she has worked on a range of policy initiatives addressing behavioral health equity, workforce development, and healthcare reform. Please welcome to the stage Dr. Delphin-Rittman.
Good morning, everyone. You know, I just have to say it is so wonderful to see everyone here. I want to thank you all for traveling in and for being with us today for this mental health summit. We are thrilled. We are thrilled. There are a lot of meetings and conversations and just a lot of excitement that's gone into today. So we are just so thrilled that you're here with us to be able to share and really hold this space for the day. You know, this summit, it's our first summit of its kind. And so we're really thrilled about that. And the timing is important, being that July is Minority Mental Health Month. But as you heard, you know, Secretary Cardona mention, it is important that we address these issues all year round. And one thing I can say that I'm really thrilled about as Assistant Secretary is that this administration has a commitment to advancing and promoting and addressing equity. And so that includes for AA and HPI populations and across the diversity spectrum. So I'm thrilled about that. Director Kai, I want to thank you for co-hosting this summit with us. We so appreciate the partnership and also want to thank you for leading the White House strategy to promote safety and equity for Asian Americans, Native Hawaiians, and Pacific Islanders. So appreciate your leadership there and that important work. The partnership we have with the White House Initiative on AANHPI is remarkable. It's remarkable. Our teams are often in connection and working with each other, probably as much as they're working internally with some of their own teams. But we're continuing to make meaningful health promoting and progress every day. So I'm pleased also to be joined, and it was wonderful to have Secretary Becerra here. His leadership around advancing and promoting equity and behavioral health is just, it is something to witness. It has been an honor to be part of his team. And of course, it's wonderful to see my friend, Secretary Cardona. He is doing just amazing work for the administration across the Department of Education. His leadership there is strong. And so it has been wonderful to be able to partner with him in this work as well. So I'd like to start by noting a couple of things. So, one thing, we know when we use the term AANHPI, we use that broadly. We use it broadly, but we know within that there is tremendous diversity and beauty and depth, and many cultures are represented there. And so I just wanted to note that. We know that, that is not a monolithic, it's not a monolithic whole there. And the diversity across the AANHPI populations is just so rich and so something to be celebrated. Unfortunately, we also recognize that AANHPI populations have been historically underserved, underserved, undernoticed populations relative to mental health support. We also know that drivers and risks for one Asian American group can be very different from those drivers that may be the case for Native Hawaiians or Pacific Islanders. So it's important that we pay attention to that nuance. Culture matters. Culture matters, and it's important that we pay attention to the within group differences and within group nuances as well. Each culture we know faces unique challenges, unique challenges. Systemic racism, barriers to care, disparities in insurance coverage, just to name a few. And we know many of these were exacerbated as a function of the pandemic. So across today, you will find sessions during this mental health summit that are focused on incredibly complex themes. Our goal is to go deeper with this summit and to unpack and to look at some of those complex areas and to really plan and think together how we can make meaningful progress and meaningful impacts. Discussions will include sensitive and difficult topics like hate crimes and stigma, but then also opportunistic comments and topics such as collaborations and innovation. And we know that is so important, the collaboration and innovation. And so another reason why we're so thrilled to have so many folks here, because I think it's just a real opportunity to be able to share innovations and ideas and best practices. Certainly I remember in my work as commissioner, I would love to bootleg a good program. There's nothing like sort of taking a good program and then tweaking it for your context and making it work, and so across today, there is the opportunity to do that, to hear from each other around programs and approaches and strategies that are making a difference. And we know we can spend days, on any one of the topics that we're here to talk about. But I do have to say, I think it is possible that if we leverage the collective wisdom and the cultural strengths in this room and the diversity within the communities here that we're here to serve, that we can achieve momentous and positive outcomes. I'm convinced of that. When you bring us all together and think strategically and in a collective way, we can come up with innovations. And we're here because we have a great need to invest in these communities. We know that there are needs there. There are high and significant needs. According to our 2021 National Survey on Drug Use and Health, so that is our large national survey that we do across the country, individuals within these communities are less likely to be users of mental health services. Yet the NSDA data, so that's again that survey, the NSDA data shows that the percentage of Asian American, Native Hawaiian, and Pacific Islanders who have reported any mental illness in 2021 was about 16%. and 18% respectively. And sadly, we know that suicide was the leading cause of death among Asian American and Pacific Islanders aged 10 to 19. So this is a critical time. That data is a call to action. It is a call to action, and it is a critical time to improve and refine our engagement with these populations and with each other. We're working hard to do this at SAMHSA. We've established the first NHPI Behavioral Health Center of Excellence. We're thrilled about that center. And I believe actually the leadership, the director of that center is here with us today. So just want to thank them for being here. Yeah, thank individuals from the center for being here and for just their partnership on this really, really important work. And in addition to that, we also have been hosting just ongoing trainings, listening sessions, learning sessions through our NED, our National Network to Eliminate Disparities. And I think those are such a gift. It's such a gift when we're able to create space and really have listening sessions to be able to hear from each other, to hear what's working, what's not working, recommendations. And we have the team from the NED and leadership of the NED here as well, who have been longtime SAMHSA partners. So Rachel Espiritu is here, and really appreciate your leadership and all that you've done through the NED and the NED team. We also have our Pacific Southwest Prevention Addiction Technology Center. So our ATTC is here as well, and also members from our Office of Behavioral Health Equity. And so really thrilled to have just that wonderful leadership there. And here with us today. Little known fact, I can say I'm also thrilled, as part of my current role, to be back at SAMHSA, because when I was at SAMHSA before 2012 to 2014, I got to work with the current director of OBI, the Office of Behavioral Health Equity, Dr. Lark Wong, and it's just been a pleasure and such a thrill to be able to work with Lark again and to be able to be back at SAMHSA as well. So I do have to say, we have embedded equity also within our technical assistance. Equity is one of our cross-cutting principles at SAMHSA. So even within our notice of funding opportunities, we have embedded language around really encouraging grantees and requiring grantees to look at and address equity. And so this is only the beginning. I'm hopeful that the outcomes of this summit will help to accelerate mental health and well-being for Asian American, Native Hawaiian, and Pacific Islanders. And I look forward to our continued work in supporting all individuals at every step in their recovery journey, so that they can have full, whole, meaningful lives. We know that that's what our work is about, and ultimately that's what recovery is about, helping people to achieve and access health, home, community, and purpose. And so again, thank you for being here. Thank you for the White House initiative on NHPI, also to the SAMHSA team at OBI, and the Center for Mental Health Services, who have collaborated to design this summit. Again, thank you everyone for being here and for traveling in, and I hope you have a successful day and enjoy the summit, and thank you. Also, I'll be in and out today, and really look forward to continuing to connect with many of you. I really enjoyed doing that at the top before we started, so looking forward to meeting more of you as well. So thank you.
Thank you again to Dr. Delphin Rittman for your tremendous leadership, and to your entire team at SAMHSA, without whom this event would not be possible. I am pleased now to introduce Dr. Lark Huang, who has been instrumental in the organization of today's Mental Health Summit. Dr. Huang is the director of the Office of Behavioral Health Equity, or OBI, and is a senior advisor in the Office of the Assistant Secretary for Mental Health and Substance Use at SAMHSA. In her role as director of OBI, Dr. Huang provides leadership to advance equity and eliminate disparities in behavioral health for underserved communities, and also ensures an equity agenda is embedded in SAMHSA's programs and policies. So again, this event would not be possible without the tremendous support of SAMHSA. We really want to thank them for their leadership. And without further ado, I'm going to turn it over to Dr. Huang.
Good morning, everyone. I want to give a warm and grateful welcome to all of you. I'm so glad we filled the seats, so thank you very much for coming as far as you did. I also, before I start my remarks, I want to thank my boss, Dr. Miriam Delphin-Rittman, who I've known for many years, and we've been colleagues and friends, and now she's my boss, so I have to thank her today. But I've been in federal government now for about 16 years through 4 administrations, and I have to say that she has been a tremendous leader for us at SAMHSA. She cares and supports her staff, as the staff here know, and she is an incredible champion for underserved communities. And I think we have an opportune moment in this Biden-Harris administration to make a difference, and she is really pushing us to really do that. So I want to give a shout out again to Miriam for all she does. Okay, so as we are putting this summit together, we were feeling there was so much to cover. There's so many people we wanted to invite, so many issues to really dive into, many strategies to identify, and good programs to scale. We felt just overwhelmed, and we started this, Vivian, we started this probably in the winter, in January maybe. But every day we felt bombarded by new issues arising that impacted the mental health of our communities. So then, Everything, Everywhere, All at Once won the Academy Award for Best Picture. Now you should clap for that. Okay. Yes, yes. And we thought aptly that title captures our summit. Everything, Everywhere, All at Once, we're going to try to do in one day. While we realized that as federal agencies, we couldn't plagiarize the title of that Academy Award movie for our summit. And as much as Sunny, where's Sunny? As much as Sunny Patel said, could we get Michelle Yeoh as a keynoter? We could aspire to the superlatives describing that movie. It was most often reviewed as heartfelt, imaginative, bold, and hilarious. Now, we dropped the hilarious because you can't have a hilarious federal meeting. But I think we can give you today an agenda that is really deeply heartfelt, innovative, and that will hopefully generate bold steps. And we really have a window of opportunity, I believe, in this administration to take bold steps. And that's what we want you to help us do, and collaboratively today. We have designed a working summit that is grounded in science and the wisdom of communities and people with lived experience, anchored in social justice and driven by an obligation to act. And I think our previous 3 speakers, the leaders, our incredible leaders that you just heard from, really impressed upon the need to act and take action. All of us are here in positions to act. That's why you were invited. We are all deeply concerned and troubled by the challenges to the mental health and well-being of the overlooked and frequently neglected Asian American, Native Hawaiian, and Pacific Islander populations. We are concerned, as was mentioned in the previous comments, about the increasing incidence of violence and hate crimes, about the suicide rate of our young people, the #1 cause of death for young AAPI people. We know many of all generations in our communities have experienced trauma associated with racism, daily microaggressions, colonization for some, traumatic migrations for others. We are also aware of the historic divisions, as well as within our populations, as well as the compatibilities. So at times we do wonder how we all got clumped together. But we also know we have tremendous cultural strengths and traditions to build upon. Our communities have relied on their cultural heritage to show relentless resiliency in the face of adversity. So we, the planners of this summit, are very excited about today, and even more so excited that you came here on blind faith, that you were going to get something worthwhile. And so we do want to make it incredibly worthwhile for you. And we know many of you traveled, as we heard earlier, far and wide to get here. So as we begin this summit, I want to tell you what the summit is not. It is not hours of talking heads, although we've kind of all gone over our time limit today already. So sorry about that. But it's not going to be talking heads. And we heard from our WHIAANHPI commissioners that they did not want that. They wanted to see action. It's not a relaxing meeting where you can sit back and multitask on your phone, Jeff. Actually, I know you well. So actually, you will be using your phone, but in a collective exercise, which Rochelle, who's our facilitator for the day, will share with you. And it is not a showcase. We have designed this as a working summit. You are specifically invited because we want to hear from you, and our facilitators will call upon you sometimes with no warning. We have worked hard to invite a very diverse group of people with the talent, expertise, and experience that we hope will translate into bold initiatives and actions. So who is here with you? We have invited researchers, people with significant lived experience, different types of practitioners, funders who want to make a wise investment that will accelerate the positive for these populations, activists who are eager to change the landscape. And most importantly, we have invited community members and leaders, community leaders who have built community-based organizations, such as our good friend Vatana, who have been remarkably innovative in building really cultural gems with little funding and who have taken on the immense challenges of mental health and sometimes co-occurring substance use disorders in populations that are often too afraid to be treated, in families that struggle to navigate very complex, fragmented mental health maze and constantly hit barriers to access. Earlier this week, I participated in a National Academy of Science briefing on federal policies to promote equity and reduce health disparities. Their key recommendations underscored the need to listen, align with, and be directed by community voice. So today we've posed 4 major challenges for the summit to focus on. The plan is to stimulate thinking around these challenges with invited very briefer than what I've just done and what the secretaries just did and my boss did, brief 5-minute talks. We are calling them Wiki TED Talks. And like Wikipedia, Wiki is a Hawaiian word that means quick, like quick, finish up, Lark. We want to engage you in a facilitated discussion, not lengthy, but pithy. Then move to generating your best thoughts regarding actions that can be taken. We hope the layering on of thoughts will promote forced listening and responsive thinking, and will yield doable, practical action steps. So finally, what do we mean by action steps? It could be as big as partnering with our colleagues at HRSA, some of whom are here today, to focus their new maternal health initiative on Pacific Islander women who have high rates of birth complications and perinatal depression. Or it could be a plan that our community-based organizations who are here today organized to propose field-generated grants and speak about that with the federal staff at your table. We've been very strategic in trying to make sure that you can talk to different people. We didn't let you sit with your teams, but you have different people from different kind of areas of work to really generate ideas with. Or maybe our attendees with lived experience who are building networks of people with lived experience propose to do a series of community listening sessions with resources from SAMHSA's 988 crisis office, which is here today as well, to make these newly established crisis delivery system more accessible to Asian American, Native Hawaiian, and Pacific Islander populations. Or perhaps a collaborative to identify best technology-based language interpretation strategies. So there's a wide range. We want you to think broadly and boldly, and we want to come up with doable, feasible actions, policies, and programs that we can take away from this summit and that we continue to work on. So it's not just a one-day summit. It's going to be more than one day getting together. We will be continuing to call upon you to figure out how you can participate in some of the actions that you generate from this summit. So this summit represents a mutual investment in each other as we share the desire to improve and strengthen the mental health and well-being of these populations. So I want to thank you again very much. I want to very much thank my staff who've worked tirelessly for days and days, and collaborating with the WHIAANHPI staff, who also, I will miss the 2 a.m. emails from Vivian Chow and the one I got last night at 3 a.m. from Crystal. So I thank you all very much, and I'm going to turn it over now to Rochelle Espiritu, who has the really daunting task of leading through this day with us. So thank you very much for your participation here. Thank you.
All right, good morning, everyone. I am your meeting facilitator for today, but most likely really the timekeeper, I think, and we're a good 30 minutes behind already, so my job is really cut out for me. So I'm going to call on all of you to help me with this process. So, magandang umaga, or good morning. My name again is Rochelle Espiritu. I'm the founding partner of Change Matrix. I'm also the project director for the National Network to Eliminate Disparities in Behavioral Health. And I'm so pleased to be here with you for this very historic moment. My role is also going to be somewhat to help us stay engaged and excited and keep the energy up in this room, because I want to celebrate the amazing diversity that is represented in this room today. So, I am going to have us get a better understanding after Secretary Becerra had you raise hands. I'm going to do a similar activity for you all so you can see who's in the room with you today. And so if you want to raise your hand, you can. If you want to stand up, we're going to be sitting a while, so I'm going to do these stand up, sit down little exercises if you would like to, or you can raise your hand, whatever you feel most comfortable for doing. So if you have been at a SAMHSA meeting before, please stand up or raise your hand. Stand up, go ahead. All right, so we got a good number of folks, and if you're a federal staff with SAMHSA, you cannot stand up because we know you've been at these meetings before. All right, if you have been at a White House initiative for Asian American, Native Hawaiian, Pacific Islander meeting, please stand up. All right, good representation. Thank you, you may sit down. All right. I gave a subtle instruction to you all that you could dress attire was business casual, but there was also one word, cultural. I don't know how many of you caught that. If you are wearing something that represents the NHPI cultural identity of yourself, please stand up so we can see what you are wearing. Yay, thank you. Thank you. I am wearing a barong Tagalog, which is a traditional Filipino outfit, the national outfit, and it's made from pineapple fiber. Very delicate. All right. Secretary Becerra took this one from me, but it was, how far have you traveled to get here? So if you think you have traveled the farthest, please stand up. And I'm going to call on my Pacific Island folks, friends. James. All right, I want to recognize these folks because they are most likely in the opposite time zone of us and are awake. So congratulations on being here. All right, you wanted to know, Lark mentioned all the different roles that we have represented here, and it's so exciting that we got to bring so many different perspectives and lived experiences into this room together. So I'm going to ask you to stand up or raise your hand if you are a person with lived experience or is with an advocacy organization or identifies as an advocate. So please stand up. Wow. All right, you may sit. Thank you so much. Your voices are incredibly important to us today. If you are a community leader or a leader of a community-based organization, please stand up or raise your hand. Great. And look around at your table, because as we said, we want you to engage with each other. Find somebody across the room to talk to. If you are a mental health practitioner or provider, please stand up or raise your hand. Thank you. Thank you for being here. If you are a researcher, and I know we have a clique of researchers here, please stand up. Thank you to our researchers. You provide important information for us to be grounded in what we know to be often, but you give us the numbers and the stories to tell our story. All right, if you are with a national organization or a funder, please stand up. Some people are just standing up all the time. You very much have multiple roles. All right, look at these people. Make sure you connect with them throughout the day. And if you are a federal or state leader or staff, please stand up. So our federal folks, thank you very much for your service and for being here today. All right, well, you all received a thought exchange. I don't know how many of you all have participated in the thought exchange or know what I'm even talking about. All right, see, you're my good Asian people. You follow the directions. Thank you so much. Corey, we are gonna now put up the first question that we asked you. We asked you a question: what would make this 2023 White House initiative on AA and NHPI mental health a success? And so what you can see up here are your answers. And the beauty about Thought Exchange is that everyone has a voice. All of you can participate in this Thought Exchange, say what you think would make this a success and why. And then you had the opportunity to see the other thoughts that other people put in and rate how much you agreed with that statement. And so it's not that we'll just have a count of how many people said, oh, we want diverse perspectives. We also got that most people rated that as the most important thing that would make this summit a success. So we have that we wanted full representation of and participation of diverse communities. Why? Because these are the communities that have been underrepresented and under-resourced. So that was the top-rated topic that would make this a success. And I think we've achieved that just by seeing all the different ways you all stood up. The second thought was that we wanted to make sure we were building meaningful and sustained relationships that will last beyond this summit. This is not a one-day opportunity for you to meet new people. We want to make connections that are going to last, because that is vital for us to have big impact. So that was the second thought that was rated the next highest. The third one that we'll highlight for you, and Corey can scroll down a tad, is that we want to prioritize culturally competent approaches to mental health care. This includes recognizing the cultural nuances and language barriers. And why? Because we need to think about the impact of historical trauma, immigration experiences, and I'll add colonialization is also something that we have heard a lot of. So interesting, these thoughts are gonna move around. Actually, when I looked at the results this morning, the second highest thought was that we wanted to make sure we identify 3 actions to improve conditions for the community as it relates to mental health. And so as you go in and rate thoughts, this is gonna move up and down, and we're gonna get to see what you as a collective are finding most important for this summit. And I hope that you can see that we've already designed this summit experience to be responsive to some of your thoughts. All right, so now we are gonna move right into our first session of the day, which is on the impact of hate crimes, violence, racism, and microaggressions. And so I'm gonna go ahead and call up our session 1 folks. And while they're coming up, I wanted to remind you that you all have the bios of the speakers in your packet. Hopefully you pick that up so you can read a little bit about each of the speakers that will be up here. And going to move, whoops, it already got moved. All right, so I'm going to invite you all to take a seat. We're going to go in order. Our facilitator is Nellie Tran, and she will be facilitating, and she's actually in charge of timekeeping, not me. Thank you. We do have a bell chime that we will be ringing at the end of your 5-minute mark, so just as a reminder, if you hear that bell chime, that means to please to finish your sentence or your thought, and then we'll move on to the next speaker. So I'll turn it over to you, Nellie. Thank you so much.
Thank you so much. So I am Dr. Nellie Tran. I'm a professor in counseling and school psychology at San Diego State University and a researcher. And I'm really excited because, as folks have mentioned, this is an unprecedented conversation. And the work that I do is in subtle forms of discrimination in schools and workplaces. And I'm reminded here of the environmental microaggressions as we are looked down upon by our leaders who do not represent us. So I'm really excited to be here and to have our leaders share their thoughts. And we'll start with our first speaker, Jessica Louie.
Okay. Hello, everyone. My name is Jessica Louie. I recently graduated high school from Oakland, California, and and I'll be attending UC San Diego this fall. I'm currently an advocacy intern for the Public Health Institute's Lotus Project in Oakland. My work consists of raising awareness about Asian American and Asian immigrant mental health issues and advocating for policies to improve the wellness of AAI communities. My main goal is to spread awareness about mental health among youth and amplify youth voices regarding their experiences with racism, microaggressions, and mental health. Keep quiet and don't cause any trouble is a message that's been passed down through my family for generations. My immigrant parents lived by that phrase in order to give me and my brothers a better life than theirs. So that's exactly what I did for the longest time. Even though I eventually realized that nothing would ever come out of keeping quiet, I never imagined I would be here with you all, 3 years after the start of my advocacy journey, and truly speaking up about the microaggressions and racism I've experienced. As a first-generation Chinese American, I've experienced microaggressions and racism since I was young. Throughout elementary and middle school, I grew used to hearing insults from my peers like dog eater, small eyes, as well as expressions of disgust about the Asian foods I've grown up eating when I brought them to school. Friends would even pull their eyes back at me, and I would laugh it off, but their words always made me feel like there was something inherently wrong with me. To this day, I still feel insecure about my appearance, especially my eyes, which has led to my low self-esteem and anxiety in social situations, as I always try my best to fit in with the crowd. Throughout high school, I couldn't go a day without hearing a racial slur directed at my classmates. I grew used to feeling disrespected at school by both peers and staff. During Lunar New Year, staff decorated the school with couplets and gave out red envelopes filled with chocolates. Some couplets were hung upside down, and some were even left to lay on the floor. After red envelopes were passed out, students ripped them up and littered them around campus. Seeing students trample all over the shreds of red envelopes and the couplets on the floor broke my heart. My friends felt the same, and a happy day meant to celebrate our culture quickly turned into a depressing one. After the COVID-19 pandemic, things got a lot worse. My peers would go around asking Asian students if they had COVID or if they ate bats. My friends told stories of being yelled at on the streets to go back to their country and blaming them for bringing the virus to the United States. My friends and I were even followed and taunted when we were walking down the street, leaving us stressed and traumatized. Since the pandemic, I feel terrified for the safety of me and my Asian peers. It feels dangerous to even be Asian in public, especially as a teenager who might be more susceptible to attack. Experiencing discrimination and racism at a young age has affected the mental health of Asian youth across the country. However, Asian youth aren't very likely to reach out for support due to the stigma surrounding mental health in the Asian community, familial pressure for academic success, and pressure to adhere to the model minority stereotype. While all Asian people can be affected, I believe that our youth are highly impacted on a greater scale because they're more vulnerable and easily influenced than adults. Addressing these issues at a young age is important to making sure that our youth don't carry these issues into adulthood, breaking the cycle of intergenerational trauma. During my internship, I've been able to work with other youth on mental health and AAPI hate-related projects. We shared similar stories and experiences that made me feel less alone and allowed me to learn more about my mental health. Witnessing their passion for advocacy and change makes me very hopeful for our country's future. I'm very thankful for this opportunity to speak here today. It's honestly very surreal. I'm also thankful for the White House and federal staff for actively working to tackle Asian American and Native Hawaiian Pacific Islander issues with the community. During the summit, I hope for the adults, service providers, leaders, and change makers in the room and across the country to please listen to youth voices and collaborate with us to implement change to improve the mental health outcomes of Asian youth. Thank you.
Thank you so much, Jessica. Thank you so much for sharing about your experiences. It's heartbreaking to hear that you're going through that, but also really validating for me because you're sharing so much of what I experienced when I was young as well. So I really appreciate it. Thank you. Next, we have Manju Kulkarni.
Hi, good morning, everyone. Before I begin, I wanted to thank Secretaries Becerra and Cardona. I want to thank Crystal, Lark, and Rachel, and all of the WHIAANHPI and SAMHSA staff for their leadership in bringing us together today. And I wanted to share that it's really an honor to be here with my esteemed co-panelists. Again, my name is Manju Kulkarni. I am Executive Director of AAPI Equity Alliance, located in Los Angeles, California. We co-founded Stop AAPI Hate in 2020 alongside Chinese for Affirmative Action and San Francisco State University when we began to see the emergence of anti-Asian hate across our country. And we do this work through data and research, policy and advocacy, community collaboration, and narrative change. And so when we started Stop AAPI Hate, within just a few weeks of creating our reporting center, we had a few hundred incident reports from across the country. That number now has grown to over 11,000 from all 50 states. That includes verbal harassment, physical assaults, and civil rights violations. One very important point that I try to make when I do these presentations is that the vast majority of these are not crimes, and so they're not hate crimes. That doesn't mean they're not important, it doesn't mean they're not traumatic, but it means that we need comprehensive solutions. We know that all of our community members are impacted. We've received significant reports from East Asians, Southeast Asians, South Asians, and even from Pacific Islanders. But these are the tip of the iceberg. 11,000, while it's a high number, doesn't represent the full extent of the hate. We know that AAPI data found that it's between 23 and 29%. For Pacific Islanders, 23, 29 for Asian Americans. Pew Research Center found over 40%. And recently, Stop AAPI Hate, in doing a survey with NORC out of University of Chicago, found that that number is 50%. So roughly 8 to 10 million individuals across our country have experienced some form of violence, some form of microaggressions, or discrimination. And I want to say that, much of this is not limited to interpersonal attacks, but actually institutional racism. And we're seeing that with the passage of alien land laws across our country. Florida has enacted a law that prevents Chinese immigrants from purchasing property. Louisiana is on the verge of passing a law that prevents Chinese immigrants from even renting property in their state. 33 states have proposals like this. So it's no surprise that Taft's status index found that only 22% of Asian Americans feel like they truly belonged in the United States. So what is the impact? Hate causes significant mental health impacts, as we know that racism is a chronic stressor resulting in PTSD, racial trauma, increased hypertension, maternal mortality, and what's called weathering, which is the early health deterioration of our communities. We know this from a 2021 study that was spearheaded by Annie Saw that showed that among those who've experienced racism in our community, 20% said they displayed racial trauma, 72% said this was the greatest stressor on them, even at the height of COVID-19. But 28% said that they reported a reduction in racial trauma just by virtue of reporting to Stop AAPI Hate. So what we need moving forward is what African American leaders and researchers have called radical healing, which is identifying the sources of trauma, promoting ideas that change is necessary, and focusing on the relationship between justice and wellness. And that's what we want to talk about going forward today and act on that. And so I'm happy to pass this along to Dr. Saw, who will talk about some of our work in collaboration to address the mental health needs of our communities.
Thank you so much. My name is Dr. Annie Saw. I'm an associate professor of clinical and community psychology at DePaul University in Chicago, and collaborate with Manju Kulkarni on several projects focused on anti-Asian racism and healing. I was also on the board of directors and former vice president of the Asian American Psychological Association, or AAPA. In 2021, through AAPA, I had the privilege of leading a large needs assessment project, which was requested by the Tri-Congressional Caucus to better understand how the pandemic was influencing different communities of color, including AA and NHPI communities. In 12 different Asian and Pacific Islander languages, we surveyed a total of 5,000 Asian Americans and Pacific Islanders. And weighting the data to the US population, we found that 1 in 3 Asian Americans were experiencing psychological distress. And of those, 42% had unmet mental health needs, which meant that they needed help accessing mental health services. Moreover, we found that discrimination during the pandemic was related to psychological distress and also poor physical health and coping through substance use. In other words, our communities were really suffering during the pandemic, and poor mental health was linked to discrimination experiences. In sharing these findings and listening to our communities across the country, I've been struck by how much racism has impacted our communities and their well-being. Not just racism related to the pandemic, but interpersonal, structural, systemic racism that our communities have long faced. And although there are many similarities of experiences of racism across diverse Asian American communities, there are also critical differences that need to be acknowledged. I've also seen and heard how racial trauma layers upon and interacts with other forms of trauma, historical and intergenerational trauma of Chinese American incarceration during World War II, the trauma Cambodian Americans have faced during the Khmer Rouge, current traumas of poverty and community disinvestment, and the troubling ways in which Asian Americans have often been pitted against other communities and communities of color, and gun violence, and how that has impacted our communities in Monterey Park, California, and beyond. As important as it has been for us to document these traumas through the work that Manju and her group are doing through Stop AAPI Hate, and researchers like Nellie and I are doing, we believe that it's critical to find ways to empower community healing through innovative, evidence-based, and culturally grounded practices. And so with a grant from the state of California that Manju's organization, AAPI Equity Alliance, received, we're now working on a community-based intervention to facilitate healing from racial trauma. This intervention, which is currently being developed, focuses on promoting well-being and healing through uplifting our community's strengths and uplifting existing culturally grounded ways of healing. This includes instilling cultural pride and sharing cultural and community histories across generations, giving people the language and the tools to understand race, racism, and their civil rights, and the tools to stand up for themselves authentically. Normalizing experiences of racism and contextualizing these experiences within the histories of Asian Americans in the US. Building critical connections both within and also outside Asian American communities, as many have talked about how racial solidarity and cross-cultural relationships are a key to combat racism. And above all, this intervention focuses on radical hope. We know that racism likely will not go away in our lifetime, yet we want to find ways to heal and build community in spite of racism. So our plan is to test this intervention with several communities in the LA area, and then to disseminate widely so that Asian American communities throughout the country can use them to promote well-being and healing from racism too. Thank you.
Hi, good morning, everyone. It is such an honor and privilege, and I'm so grateful for this opportunity, and thank you so much for the secretaries, as well as Assistant Secretary Delphine Rittman, as well as the organizers, Chris Kai, and also Dr. Huang, and the whole team. I think it really does take a village, and I think it's so incredible to be here amongst all of you, to be able to share in this collective experience. I wanted to center my comments specifically as an Asian American immigrant and how I experienced sort of my experiences in coming to the work that I do. And so I think one of the things that I sort of growing up as an Asian American immigrant, I experienced my emotions and my feelings also through my body. So a lot of the healing and my understanding of the experience was really somatic, which led me to think about becoming a doctor. And so I became a family doctor because collectively I saw myself in the context of my family system. I didn't necessarily see myself as just one person, and that's part of our cultural richness. But I realized that having a heart attack and having a broken heart, although equally painful, were really different in terms of their healing. So I became a psychiatrist, and I also became a child and adolescent psychiatrist because once again, I wanted to see the whole family system, and I wanted to treat and be able to acknowledge the needs of all of ourselves. And I really want to center some of our comments related to how we experience mental health issues, and it's really through our whole sense of self, as well as not only within our bodies and minds and spirits, but also within our families and communities. So we share our pain, much like lots of faith is really in the context of others. And so I think I really want to honor that experience. What we've heard and from the secretaries and assistant secretary is that the prevalence for mental health issues among our communities is very high. And it could be estimated at 16 or 18%, which is lower than other Americans and other racial and ethnic groups, but there are issues related to underreporting and or just really expressing these experiences. And I'm also mindful of the fact that we heard that suicide is the first leading cause of death for young people aged 10 to 14 and second for 15 to 24. And also acknowledging, Jessica, your courage and your bravery, as well as Wesley and our youth advocates and our youth voice, is really incredibly powerful and really instilling the hope that we all need in terms of thinking about it. You know, one of the really tragedies of the sort of AAPI hate movement and the hate rhetoric, as well as the hate speech, and I'm so grateful for my colleagues' incredible work in raising that alarm. I myself actually reported myself because I was being threatened and attacked on a New York City subway going to work during the pandemic. But I think just finding that voice and finding a place to express it was incredibly powerful. I also wanted to acknowledge the fact that mental health services and seeking those services is vastly underrepresented within our NHPI communities. And there are many determinants and reasons why that might be the case, but the important thing is that how are services being presented? How are they community-centered? How are they really listening, as we heard from Secretary Becerra, to really the needs of the people that we're intending to serve? And I think when we look at the NSDA data and really looking at healthier utilization among NHPI communities and individuals, as well as our young people, it's less than half of those individuals who are compared to other racial and ethnic groups. So I think really trying to bridge that gap and asking ourselves that question and really inviting ourselves to listen to some of the answers. And I'm really excited that we're able to be here today to do that. So thank you.
Good morning, everyone. Thanks so much for being here. How amazing to be on this panel. Thank you all for your work and all of you. And asking, how did I get on this panel? A lot of it is, I think I'm the in-between person. And so you can look at my roles, being on the JED Foundation Advisory Board, Asian American Psychological Association. I am a clinician who is the president of the Society for Research on Race, Culture, and Ethnicity. It's the in-between spaces about how do we work together between the silos within our communities, and within our professions, and even the labels we give each other. As I often give lectures and I talk and say, well, am I an educator at Stanford? Am I a clinician? Are you a loved one, a family member, a caregiver, someone with lived experience? Aren't we, most of us, all of these? And how often do we talk about that? And how important that is, that I don't just do work. We don't just work like combating stigma and all this, like we have to live it. Right, and so having the courage to come out as our youth speaker and others, like how do we actually make those connections? Some of the comments already that we'd made on the talk was definitely, a lot of you have talked about we need something applied when we leave here today. We need to talk about planning, we need to talk about systems. I'm trained as a clinician, one-on-one, but it became very clear very soon that what we need to do has to be systemic, and what we are healing is cultural and generational. How do we actually do that? That doesn't come from clinical psychology. However, look at all the wisdom that our people of the global majority cultures have always known and how that's been appropriated into things like ACT modules and what have you, and how do we empower ourselves and take those back in a systemic way that is healing for our communities. And why history and education matters so much and that coalition building. Sitting with students, my students are about 18 to 45, we have quite a range at Stanford, and the grief and the pain and the fear of these last few years, just the long-lasting trauma, the exhaustion, that weathering. We see it and we live it. And I know many of you have held those spaces, right? We have held healing spaces for our community while we ourselves are traumatized and suffering and afraid for our loved ones or ourselves. But that the solution for that is a multi-stage thing, that clinical one-on-one work is not sufficient, right? So during the worst of anti-Asian hate violence, we really talked about what is it you need right now? Is it the immediate? You need grounding skills. You need to be safe right now. But then what's the medium? The coping skills, the therapy. But what's the long term if we're really going to address this? It's community action. It's community circles, it's fighting for funding, it's advocacy, it's policy. I want to shout out a lot of people who are doing the work, like Dr. Gordon Hall, who's really been fighting and advocating for the fact that why is it that we are about almost, 6% of the population? And the NIH funding for all health conditions, all, not just mental health, was 0.17%. This is an equity and a justice factor, and it actually costs lives when that data is not there about our communities. But also within our communities, are we addressing like our NHPI community members, our South Asians, our youth, our elders, and how are we doing that? So actual coalition building. The Lotus Project, which I believe is SAMHSA funded, that Rams had, was kind enough to invite me to talk about coalition building, and that is a skill set that I often say everything important I learned in my career did not come from my doctorate. It came from Asian American studies and 20 years in community-based mental health in Oakland primarily. That's where the work really is and the skills that we really need. And a lot of my students now who are grieving, I'm like, you have to understand that as a community, it seems like almost every 20 years we have a call and a reckoning. But there's resilience in that too, that how many of them never learned about the Third World Coalition and ethnic studies and what happened at Berkeley and San Francisco State and how we came together with our allied communities to make change happen. How in the 80s with the murder of Vincent Chin, Pan-Asians realized we've got to work together to make things happen, that we have to find ways to like get over our differences and our needs and align. And I think right now the crisis we're facing is also how do we align across our professional boundaries, and actually align to get the funding we need, to get the research we need, and how do we do that? As much as we fight for our own communities, we do need our allied communities. I've said the best thing that ever happened to me when I was president of the Asian American Psych Association was getting to really know and work with the Latinx psychologists, the Black psychologists, the Native Indigenous psychologists, and learning how we can support each other and push back against the splitting and all that. And there are just things about the work that I'll just shout out quickly. I will stop now, but Dr. Doris Chang is here. They have a project on resiliency, COVID, and allyship, being an accomplice. So talk more to them about that. Thank you.
Thank you so much to our speakers. I'm really reminded of my heritage as a daughter of Vietnamese refugee boat people, and I really appreciate the extent to which you all have made the issues more complex by thinking about not just cultural and ethnic heritage, but also about our socialization as racial entities here in the US. And so with that, we are going to begin a conversation with you all, and we've got 3 discussion questions that will be up on the screen. So if you all would join us in thinking about, from your perspectives, given the rise in anti-Asian hate and violence, what can be done to better support the mental health and well-being of these individuals and communities? What is the connection between the rise in domestic violent extremism in this country and violence towards AA and NHPI communities, and how can policymakers and legal practitioners collaborate to address extremism? And how can allies and advocates promote systemic change to promote the mental health needs of AA and NHPI communities facing racism and xenophobia? There's a lot of us in the room here, and so I want to remind us that we want to make sure that we make space for those who may not always have space to voice their experiences and their expertise. And we have a hand first already.
All right, so Nellie's going to be down. If you have a question or a comment that you would like to make, please either raise your hand, or we have a couple of people with microphones somewhere. Can you raise your hands if you have a microphone there? So we have a person over there if you would like to make a comment or have a question. Go ahead.
Hello, hi, good morning everyone. I want to first thank the Secretary Becerra, Secretary Cardona for their nice inspiration speech. Also talking about the hate crimes, you know, the Asian Americans since 3 years since pandemic, although they have been on the rise, but particularly for the Sikh community, the hate crimes we are the second largest targeted after Jewish Americans. And in addition, I would say that 67% of the kids, Sikh kids in schools are bullied. These are not numbers, these are the FPI numbers. From 20 to 21, the hate crimes against Sikhs were increased almost 140%. And when we say 140%, that is the numbers that are in books. The unreported, we don't know how many are unreported. And I can vouch that, especially Sikhs after 9/11, out of we are 1.5 million in US, I can say everybody, 99% of the Sikhs with turban are from India. We have been correlated with the incidents within all parts of the world. And I can vouch and say confidently that Sikhs, every Sikh in this country has been once in their lifetime have been saying, told things to go back or all these kind of items. Just wanted to add this comment. Thank you.
Thank you so much for reminding us that this is not new just because the media finally has videos of it and are reporting on it. I actually want to invite Dr. Doris Chang, because I know you happen to have some new data that would speak to some of what you're talking about, if that's okay.
Yeah, sure. Thank you. Hi, everyone. Good morning. I'm Doris Chang. I'm a professor at NYU, and I'm also a clinical psychologist. And so as I listen to these incredible comments, I'm finding myself moving from different roles and identities that I occupy as a child of immigrants, clinician who sits with lots of patients and who has worked with Asian Americans who are really struggling and have been struggling for a long time. But I recently completed a large-scale survey of Asian Americans. Specifically, we were looking at Chinese Americans, Filipino Americans, and South Asian, specifically Indian Americans, just a year ago. And just as we thought, you know, okay, the pandemic is waning, surely we're not as distressed as we were. We actually find that that's not the case, and we found a lot of within-group differences. And I'm so glad you brought up the importance of disaggregating the stories, disaggregating the data. We did find that in our own data that Indian Americans had the highest level of exposure to discrimination. We thought it would be East Asians, but that wasn't the case. I also just want to point out, we looked at LGBTQ populations within our Asian American sample and found extraordinarily high rates of exposure to discrimination and also really high rates of suicidality. So just 1 year ago, the rate of suicidal ideation in the previous year was 30% in our entire sample. But that figure was over 50%, actually close to 60% for our LGBTQ members of our sample. So we do want to acknowledge the incredible diversity and heterogeneity in our experiences. On the plus side, I'm really happy the panel is talking about cultural strengths, because this moment has also been a really incredible moment of awakening for so many of us. I mean, I like to think about silver linings and strengths, and some of us who are the most traumatized are also the ones who are the most vocal in leading us towards positive change. So in our sample, the LGBTQ individuals were also more likely to be engaging in collective action, both on behalf of the Asian American community, but also in solidarity with Black and Brown communities as well. So we have a lot to offer, and I'm really pleased to be here at this meeting.
Thank you, Dr.
All right, I see some questions in the back. Somebody is making their way over to you. Thank you.
Oh, can I go now?
Yes, please go ahead and go first.
Hi, everyone. Karthik Ramakrishnan. Speaking both perspective from API data, working with community orgs, but also as, I guess, in the policy world and as someone in philanthropy, thinking about radical healing, but also like non-Western practices, and just wondering, at least in the agenda, and I'll have to catch a train midday today, so maybe this is going to be covered, but thinking especially in terms of solutions that scale, what does that look like? What are the rules of the federal government and the agencies that are barriers that need to be lifted and that could be done hopefully in this administration. These are some, and one of the things in California, on the California Commission on API Affairs, as well as work that we do with UCLA and the California Health Interview Survey, seems like supply and pipeline and workforce are like major challenges, so that even when the federal government or state government is willing to spend, there just isn't enough supply to do it. So I don't know if that's going to be part of the agenda here. It's one thing to talk about innovative solutions, but what does it take to actually scale it up and to solve this problem expeditiously? I don't know if any of the speakers on the panel have perspective on that.
Could I respond? Thanks, Karthik, for your points. I actually wanted to point to another person in group in the room. Myron Deaton Kwan is with PACS, which is one of the member organizations of AAPI Equity Alliance, and they have been doing, using non-Western practices for a long time. Because, one thing we need to talk about is, anti-Asian hate, is not new, right? It's been with us really since the founding of the United States. But that also, many of our immigrant communities come with trauma, which then displays as intergenerational trauma. And I know that specifically PACS has done work incorporating those non-Western traditions, including, gardening, sewing, blessing ceremonies. They have a significant Khmer population that they serve, and so using Buddhist blessing ceremonies as part of their practice, right? Because that can provide the same, if not more, healing to community members than traditional cognitive behavioral therapy, right? Which is not something our community members, I can tell you, even from my time at South Asian Network, are not used to sitting on a couch and spilling their guts, right, to a therapist. That's just not something that's done. And so we have to use practices like these, like yoga, like Tai Chi and others, to really produce the healing that we're seeking.
I just wanted to add to what Manju has said, and PACS has helped connect us with a lot of Khmer community members, and hearing from them, hearing from members of other Asian American ethnic communities, and then, of course, Manju in all of her wisdom. From the get-go in this intervention that we're developing, we recognize that the pipeline issue, the workforce issue, is often the bottleneck in helping our communities heal. There aren't enough professionals to help support healing in our communities. And so we need to look to our communities and what they're currently doing to heal, but also how can we enlist lay health workers, how can we enlist community members that may not have mental health professional training to facilitate healing. So this intervention that we're developing with Manju is meant to train community members who are not mental health professionals to help support other community members. And we think that that is how we can scale up and disseminate widely, because we recognize that in places like LA, there might be the good fortune of bicultural, bilingual, multicultural mental health professionals to help support community members, but that is not the case across the country. And so we need to equip our communities to be able to support their own healing, and to do so in culturally grounded ways.
Thank you.
Can I add to that comment? I love the conversation. I wanted to also add a word, and, because I think that it's and community support as well. It's really rethinking how we think about treatment and healing. But I also want to offer that many Asian American NHPI folks who are seeking care currently are actually seeking care later in terms of their disease progression and or severity or intensity. So I'm mindful of how can we best utilize our existing healthcare platform and network, and I think SAMHSA's Minority Fellowship Program and really creating pipeline programs, supporting specific loan repayment and or other initiatives so that we can actually do both, because we definitely need to have that representation within our current healthcare system so that we can bridge that cultural divide so that we can link to these community-based services from the lived experience. Because I think that when you know it, like when I know when I take a sort of a collateral history in terms of what else are you taking to help yourself at home, I'm more likely to get more of the herbal treatments and or the more holistic and or even the clergy in terms of the other kinds of healing that we have to incorporate within our healthcare network. But I do want to be mindful of that, as well as the former comment on specifically an intersectionality, particularly as a gay Asian person myself. I think that the intersectionalities are not synergistic, they're actually more difficult. So I face, or any person may face, homophobia within the NHPI community and or racism within the LGBTQ plus community. So thinking specifically of those cracks and people who fall through those cracks, and particularly our young people, are particularly vocal and really effective at raising that alarm. Thank you.
All right, we're going to go to the back.
Oops. Hi, my name is Apurva Shrivastava. I'm a health policy consultant, and I also do pro bono breathwork and meditation sessions in communities as a way of bringing mental well-being. So it's a question, but also a solution that I want to bring here that we're not talking about. You know, one is to frame, to take away mental health as a phrase that comes up only when people are getting sick, and really start talking about mental well-being that way. It's a proactive approach. It's applicable to everybody, and we all experience it. We've all had experiences, you know. And one of the solutions that we haven't talked about in the public health and healthcare sectors, it's the power of arts, music, and dance. There is so much literature in that domain, so much research that says music and dance have the healing capacity, not just when people come together of a certain culture together, but when people come together from different cultures, races, ethnicities, nationalities. It has a powerful healing effect on people. There is also a theory that when people see each other in these contexts, they're able to see beyond their differences and really be in the shared experience of humanity. You know, and cultural expression has been such an important part of like storytelling, sharing our experiences, and people connect with that, you know? And to that end, the mayor of DC has seen that as an incredible way of bringing social belongingness and unity in this like really, you know, polarized world where we can just see people on social media as stereotypes, right? Or just reading the news, which creates such a negative bias. So there is a World Culture Festival happening on the National Mall this September, and I encourage you to look at it as not just an event, but a catalytic moment and something to learn from. How can we take this and have music and culture be a part of our everyday? And how can science, how can peer-reviewed journals in the space of health and mental health incorporate this kind of programming, this kind of language? How can we incorporate metrics that measure these events or these spaces of community belongingness where people from their different isolated communities actually come together in one space to feel that we are one? I think that that will be an incredible, incredible addition to what we're facing in the world today.
Thank you so much for bringing that up. And in case folks don't know, the American Psychological Association recently apologized for racist theories, practices that they have themselves as an organization historically promoted. And that includes one-on-one talk therapy as the only solution to mental health. So I really appreciate the comment that if we draw upon some of our practices and we think about cultural practices and how to bring that into wellness, that in and of itself will help us to promote mental health, right? And we've got a couple other hands. Yes, right.
Is this on?
Hi, Julia Choi with the Asian and Pacific Islander American Health Forum. Wonderful to be here.
I wanted to follow up with Karthik's comments and questions. Whether it's today or knowing that this is the start of a conversation and the dialogue will continue, I do think trying to identify scalable solutions that we can put into practice immediately is going to be very critical, especially with the leadership of the Biden-Harris administration. That's what I'm keenly interested in trying to dig into. I would also highlight, I think going forward, it would be really wonderful, again, thank you to the leadership here at HHS, is figuring out how some of these immediate solutions can be also covered through Medicaid or Medicare. That, to me, I think would be very, very practical. There are some states that are innovative where they do try to cover, I think, some of these more cultural relevant services through Medicaid. The last component I want to highlight, I don't know if we'll get a chance to cover it later on today. We need a village. We need to expand the network, and I also want to underscore the import of our partners from the faith-based community. I think we have several leaders here. I think it would be wonderful to provide a bigger platform for our faith-based leaders. In the back of the room, I have a really good friend, Deborah Boudreau from the Suchi Buddhist Medical Foundation. I know there are several more in the room. Thank you.
Thank you for your comment. We have about 5 minutes left for this conversation, so if you feel like your comments could be held off for our next sessions on interventions, that'd be wonderful to make space for folks who have not gotten a chance to speak. Yeah, we've got a couple hands. Can we, our runners? Microphone's right in the, yeah, right next to you, I think was a hand.
Well, first of all, thank you for your leadership of bringing this summit together. We desperately need that, so thank you very much. The reason I was going to put my hands down, but I thought I can do it later, but I just want to flow the continuity of the summit itself. You know what, I'm actually so grateful that, 3 secretaries were here earlier and with us. So I appreciate that effort, number one. I just want to kind of echo is that addressing mental health, it's a very difficult challenge for our communities. But yeah, there's a different way to look at mental wellness and so forth. So from there, I would just jump into, if we look at mental health as a public mental health approach, and which really include, the Department of Education, not only SAMHSA, but also other, secretariats. That might be a way of addressing these very complex issues in our communities. So I just want to highlight that aspect of it. And I hope all the staffers will bring it back to the secretary and saying, hey, this is one of the action plan that we end up, which will be an interagency collaborations under the multiple secretariats. And I have seen that work in the past with previous administration. And I think we just need to kind of keep going and be sustainable in terms of that kind of a perspective. So again, thank you so much. And I just have to do a shout out for Obi. I will use that as a quick name because under Lark leadership, I think second time around now, has made a big difference, within the House of SAMHSA. And I know that she was involved in interagency collaboration, including CDC. So I think which is another player that we need to look at what they are doing, with our population.
Could we get a microphone over here? I really hear you saying that mental wellness and mental health should be a public good and not a private commercial activity, which for the most part it is right now. So it isn't accessible to many of our community. Thank you. Oh, we're gonna go here.
Thank you. My name is Norman Chen. I'm the CEO of the Asian American Foundation. I figure I'd stand here so I can see everybody. I'm from California, so thank you for the shout out to Californians here. A couple comments I wanted to make. First of all, I want to thank everybody for organizing this event and inviting us here, but I really want to thank Jessica for her comments and heartfelt words. I have 2 kids who have just gone through the teenage years. They themselves and their friends have gone through tremendous mental health challenges, and so it touches me deeply to hear your story. I do want to thank also Manju for quoting our statistic from our status index, which looks at American attitudes towards Asian Americans in partnership with AAPI data. We've looked at 13,000 people around the country, And we talked about how belonging, AAPI is the lowest in terms of lack of belonging, true belonging in this country, very closely tied to the Black community and Latino community. The number one cause for lack of belonging is the racism and discrimination they face every day in their lives. And so it ties very closely to this panel. The number two reason is the lack of representation. And so the things we work on to increase representation across organizations is very, very important. I also want to touch upon the gentleman's comment from the Sikh community. We have a national consortium of anti-hate experts, and we've been indebted to the Sikh community for their leadership in sharing their experiences over the past 20 plus years to share with the broader AAPI community of the lessons learned, and it's been so valuable, so thank you, as well as the Jewish community that also provides great insight to our community. Lastly, I want to talk about some work that we want to work in collaboration with others, and I welcome people who want to talk further about this, which is given the crisis in mental health for AAPI youth, we are keen to support more research, comprehensive research to understand where are we today in terms of status of AAPI youth mental health, what are the factors contributing to AAPI youth mental health, and what are potential solutions, many of which you're already working on. Delighted to have the opportunity, hopefully, to work with DJ Ida on this. The goal here is to really understand this terrible crisis affecting our youth, and where one child per day is taking their life, essentially. It's just such a tragedy. And to really try to find upstream factors to reduce this crisis from happening. It's like the war on drugs. We have to deal with the causes here, the underlying causes, both within the family and within society, and we want to work with experts here to try to understand that better. So if you're interested, please come up to me and we can talk further. Thank you.
Do you want to take the last one? Got one more. Last one? Yes. Do we have a microphone close?
Hello. Hi. Thank you very much. I'm honored to be here, and thank you for the panel. My name is Kenneth Thong, and I'm representing the FCMS, Federation of Chinese American and Chinese Canadian Medical Society. Also a past president of Society for the Study of Psychiatry and Culture. I'm a cultural psychiatrist. I think that this is such an important moment for us to really look critically at the issue of stigma and racism and how it impacts on the Asian community. I think I'll just keep my remarks brief, but number one is I think that we've been given a chance to finally have our voice heard, because up until now, for many years, I've been asked to talk about culture, but very, very rarely to talk about racism. And I think that the racism, as now we can capture both the most extreme violent ones, but also the systemic, but also even the subtle racism that people grow up with at school, that they are not given a voice, they're not felt to be legitimate. We know that psychologically, these subtle racism damages us psychologically just as bad as really overt, because people are not given a chance to feel like what you're feeling is legitimate. They're feeling like you're just too sensitive. Others have it worse than you. So I think this is a huge problem. Secondly, the problem of intersectionality. There are definitely subgroups within the Asian community that are having multiple factors for which they are discriminated against, including having mental illness, LGBTQ community, HIV community, and other stigmatizing communities, how they intersect. I think number three, in terms of intervention, we need to look at internalized stigma, internalized racism as part of the healing, and also community capacity building. I want to share just briefly that perhaps the most radical point, though, is that as we're tapping into what can be helpful, we look at what's anti-racism is anti, is against, but what are we for? So from traditional Asian concept, from Buddhist concept, from socially engaged Buddhism, for example, like Thich Nhat Hanh, we look at building interconnectedness. How do we build bridges? And if we look at the modern acceptance and commitment therapy model, mindfulness approaches, our project actually starts with the premise of this, that in some ways, we are all racist. How does that as a start? Because sometimes when we are fighting racism, the problem I find is that it starts to cause us versus the other. And when we ask in the room who's racist, surprisingly, no one raised their hand. It doesn't matter how many times we do it. So when we built a module on how do we combat racism, we actually start with social distance as a concept. Do we feel different from another person? Because we know that even among Asian communities, there are racial tension, this group against that group. So how do we start from the premise of we are all having these concepts of social distance from one another? Maybe use, as we're combating racism, we have to be careful of not making the other like the devil, because nobody wants to be in that shoes. Yet at the same time, we really need to proactively address it as a community and build towards interconnectedness. Thank you.
Thank you for your comments. For our colleagues who are looking for measures and a directory, the Asian American Psychological Association has an academic journal called the Asian American Journal of Psychology, where these tools have recently been published over the last 5 years. So for internalized model minority myth, internalized racism, Asian American racial identity development, measures for Asian American microaggressions all exist. And if you can't get past the paywall, I'm happy to send it to you.
Great. Thank you so much, Nellie. Thank you so much to our speakers. We really appreciated the insights that you shared and your ideas. So I'm going to invite you to go ahead and return to your tables. And we're going to have the opportunity now. It's impossible to hear from everyone, and I apologize for that. We have so many amazing people in the room that bring such a wide diversity of experience and thoughts to the space. And so we're going to offer you this opportunity next to provide your own ideas. We want to hear from each and every one of you. How many of you have a smartphone on you? What? All right, you're all looking for your smartphone right now. Okay, got it. All right, so this is called Thought Exchange. This is our opportunity for us, for the government, for you all to hear about what you all think are the most important or most impactful actions that we should take in the next year to address the topic that we just talked about here in session 1. So what you will do is you will scan that QR code, or you can go to tejoin.com and type in that number. And on that site, you will be asked a few questions to identify your role. And if you are here in person, you're all here in person, so make sure you answer that way. We do have this event being live streamed, so we want to know that you're here with us today. And then you'll be asked this question, and you have the opportunity to share one idea per entry. So you can share as many ideas as you want, but don't put them all into one entry, because that will be hard. So what is one idea that you have around an action? We heard many of them today. We heard that we need to be able to scale up these good programs that we already have. We heard that we need to address supply. So how would we do that? What are specific actions or ideas that you have either for the federal government, for funders, for a particular program, for your own self? What are some of those actions? So we are going to play a little music for you right now while you are adding your thoughts. And when you add your idea, also share why. Why do you think that action should happen? Why is that important? If you are having a hard time with the technology, I also have note cards on the table. If you want to fill it out on a note card, we have pink cards that will be for session 1. But I see you all busily on your phone, so I'm going to stop talking so you can think. that, oh. All right, so hopefully some of you have offered in at least one idea. I hope you have put in one idea that you think is important. Then you can move on to rating the thoughts of others. So once you are done offering your ideas, you can move on to start rating. Here's my suggestion for you. You will probably see a lot of good ideas. But what do you think is the most important one to work on in the next year? So rate that a 5. Rate things that you agree are the most important to work on as 5s. If maybe you think it might wait, or it's not as urgent or important right now, rate that a lower than a 5. The point is not to have everyone rate every idea as a 5, because that won't help us prioritize. So kind of think about the thoughts that you're seeing. You're gonna get to see the thoughts of others in this room that might be similar to your idea or very different from your idea. So give them a rating from 1 to 5, 5 being the highest, you strongly agree, 1 being lowest. And we'll give you a couple more minutes to do that, and then we'll look at the results. All right. If I could draw your attention up to the screen. I mean, that was good. I looked out at the audience, you were all on your phones. It's the only time that we will tell you, be on your phones. We want your thoughts. We want your bold ideas. And so 93 participants in this thought exchange. We got 78 thoughts. We got 1,038 ratings already. And the average that we like to get is for you to rate at least 20 or so thoughts. So you can continue on rating thoughts as you'd like. But how many of you saw thoughts that were really different from the one that you put in? Okay, you guys can use your arms. Okay, good. That's the purpose of this platform, is so that you might have particular ideas, but you get to see the other thoughts of others, and then you get to rate how important those thoughts are for you. So what we can see here is the top rated thoughts so far, and it's been going up and down, is to fund a pipeline of Asian mental health professionals to increase supply of culturally responsive practitioners. Why? Because they are the best place to offer treatment and care that is culturally aware and grounded and has a greater likelihood of success. So this is the top thought so far. And then the second one is to propose a coverage of, and this is where it changes because you're all rating. And so this is gonna be a dynamic process here where we will close this particular thought exchange at the end of today, just so that people don't get confused about which thought exchange they're in. But we will reopen this by the end of today so that you can share this link with your networks. We want to hear from everyone. What do they think are the most important actions that we can take? And again, be as specific in your action as you can, because that helps us. So I hope you'll find this platform really useful as we move on throughout the day. We'll be doing this for every session. So we are now getting back on schedule. I'm so happy, panelist number 1, that no one had to use the bell. but we will use it at some point because I bought it for this meeting, so I want to hear it at some point. All right, I am going to invite up the panelists for session 2 and our facilitator, Dr. DJ Ida. So I'm going to invite them to come up, but while they're coming up, let's see. Let's do some stand up, sit down. Or actually, everyone stand up if you can, and just move oh, this is what I was going to do. This is called the WYT stretch. All right, everyone, make a W. Yeah, really bring those shoulder blades back because we're always hunched over. Make a Y. Oh, can someone take a picture of this? Hold on. I'm going to take a picture of you all with your Y. All right, and the next letter is T. All right, and then T. All right, again, W, Y, T. You guys are awesome. You may sit down, and panel number 2 can come up. Yep, you've got your mic there. I suggest.
Okay, I think, is this microphone on? I can never tell. Okay, great. First of all, I would like to thank SAMHSA and WHIAANHPI for this really amazing opportunity for us to come together. And as you can see as the panels go on from session to session, they really are integrated. What may appear to be different topics, there's a lot of overlap. And I was just taking notes like crazy on the first session there. Racism is such an important topic that really is getting, hopefully, the attention that it needs. But there are things they're looking at integrated care, or looking at public health changes, all these other issues that will bring us to, I think, having radical hope. What this session is going to be is we're going to be looking at integrated care. All the major policies say that in order to really reduce disparities in care, access is really important, but for so many of our communities, there's very little for them to access. We have a panel today of really, really amazing folks who are going to share with you their wisdom, things that they have done, and look at the kinds of things to really look at what does integrated care mean, what are some of the solutions, and what are we seeing on the ground. And so with that, I'm just going to be starting, and we're going to be doing this in order. And Wesley Chen, if you could start, just repeat your name and give the title, and then take it away.
Hello, everyone. My name is Wesley Chen, and for the past few years, I've been an advocacy intern at the Public Health Institute's Lotus Project. I've just graduated from a public high school in California and will be a freshman at Northwestern University this fall. What I want to share with everyone here today are my personal experiences and perspectives on mental health as an Asian American youth that has just gone through the K-12 education system here in the United States. Throughout high school, there have always been 3 questions that I ask myself on a daily basis. Why do I find it so difficult to access mental health care in school? Why do I always hesitate to speak out about my mental health to friends and family? Why am I always so afraid to reach out to my teachers and counselors for help? In front of everyone here today, I hope to share my answers to these questions. Imagine you're an Asian high school student. You've just had racist remarks thrown at you in school, and you've been bullied both verbally and physically for many weeks. You've been called a dog eater, a bat eater, a chong, yellow, and more. You're mentally exhausted and suffering. Who do you ask for help? Your classmates? Just like you, the vast majority of them have never taken a mental health course. Furthermore, openly discussing mental health is not normalized in your culture, nor is it at school. Your parents? The generational gap between you and your parents is hard to overcome. They just aren't on the same page with you on the significance of mental health. What about your teachers? You think about it, but then you remember that your teachers are not only overworked and underpaid, but also don't have the professional training to help you with your mental health struggles. Lastly, you think about your counselors. While they may have the professional experience to help you with your mental health struggles, they are also overworked and underpaid. More alarming, they're basically strangers to you. At best, you have met them once or twice a year for very brief conversations. Are you really comfortable sharing your mental health struggles with someone who is essentially a stranger to you? Unfortunately, what you've just imagined is reality for many Asian high school students. I know this because I've personally experienced it myself in school. The fact is that neither our classmates, parents, teachers, or counselors feel accessible to us, even though they should be our strongest support group. That's why I believe an effective mental health care system in school is one that incorporates and tackles the issue at all levels, from students to parents to teachers to counselors and more. To accomplish this, I think what's most important is having comprehensive and mandatory mental health classes. I believe this will help normalize discussions on mental health across all levels of the school system, especially amongst students themselves. In addition, we need to figure out a way to better integrate parents into mental health care in schools, especially for the AA and NHPI community. There are so many instances I've seen where the recommendation of teachers and counselors come into conflict with that of parents, such as parents not letting their children use excused absences for their mental health illnesses. I believe this is both a result of those in the school system not being culturally informed, as well as parents not being on the same page with them with regards to mental health. Last but not least, I believe that teachers need to play a larger role in mental health care for their students. Teachers are among those who students interact with the most. This puts them in a unique position to be able to identify early signs of mental health problems, whether that's grade drops, attendance, or classroom behavior. They just need the training and resources to do so. This will also help reduce the burden on counselors. My school has a population of over 2,500 students, but only 5 to 6 school counselors. This means each counselor has a caseload of around 400 to 500 students. As a result, this makes it difficult for students to access counselors in a timely manner. In addition, the vast majority of communication is also forced to be done through emails, which makes it hard to build any strong personal connection sufficient enough for us students to feel comfortable sharing our mental health struggles and not treat our counselors as strangers. Up until now, I've discussed many issues and solutions within the school system. But as I wrap up my speech, I also wanted to take a moment and highlight the importance of nonprofits and other community-based organizations in tackling mental health care in schools. Because many schools lack the funding and experience to implement effective mental health care, I think there's a strong need for community-based organizations to be proactive by not only reaching out to schools to offer them aid, but also directly to the youth themselves, whether that is through internship programs or actually providing counseling to students in need. My point is that tackling mental health requires the collaborative effort of all of us, from educators to professionals to the government and the students themselves. Seeing everyone here today has given me hope, and I truly believe that together we can do it. So thank you.
I think once again we hear the wisdom of the young voices, and oftentimes we think about integrated care, we think about the integration between physical health and mental health. And I think you're raising a really, really important way of looking at integration is how do we integrate mental health into the school systems to really, I think, address the issues among the youth. So again, thank you very much. Really, really, I think it was very, very important comments that you're making. Our next speaker is Julie Liu.
Hi, good morning, everyone. What a pleasure and honor to be here, and I feel particularly honored to be sitting next to a youth advocate. I don't think at this age I was like this, so really, I'm very impressed. And he's also in Oakland. I'm with Asian Health Services, and we're a federally qualified health center. We're going to be turning 50 next year. So I think we'll be able to join ARP. I'm seeing Daphne somewhere. I was reflecting back, and we have actually started our integrated behavioral health services 20 years ago. And we were talking about these issues, about stigma, about low utilization of mental health services. So it's really what a moment in time when we can come together where actually the White House is actually elevating minority mental health. So really excited to be here. So just to say, we've actually been doing behavioral health services, again, for a couple of decades. And just about in 2016, we added specialty mental health services. Our theme is really around integration. We actually co-locate our mental health services and our primary care. So that when a patient comes, and I see nodding heads, when our patient comes, it's not about coming for mental health counseling, mental health services. They walk into our medical clinic. So in that sense, we're able to reduce stigma. The other thing that we've actually done is we've actually co-located our dental and mental health. So how many of you have actually seen a dentist lately? Okay, many. So recently we were covered a while ago about if you are anxious or depressed, you can go see your dentist. So what we've done actually is we do depression screenings in our dental office, at our primary care, so that we're capturing everybody from the beginning. And so we can actually do a warm handoff to a counselor on site if needed. So I think that integration piece is really critical. We saw that during COVID, as many of you, we've talked about this, that the needs and the services increased multifold. And the issue for us was there were so many needs, but we just simply did not have the capacity to actually address those needs. And I think Kartik brought this up earlier around a workforce. We had to be very creative. We had, again, just long waiting lists. And so we created a mental health academy. And what we did was we actually are taking our MSWs, our MFTs, and we are training them to get clinical experience, be exposed, and we want them to come back and work in the community. So I think what's really key here when we talk about investments is really looking at our licensed track professionals, giving them opportunities and actually incentivizing them to actually work into the community. I think, Juliet, you brought up about Medicaid, Medicare. They should absolutely be reimbursing our providers. And we're looking at, we are in need of bilingual providers. We need those higher reimbursement rates. We need those incentives. We need to really focus in on really, again, developing the pipeline. So when anti-Asian hate hit, and then in terms of COVID and together, we actually created a community healing unit. And thank you to TAF for helping to support that. And part of that was really looking at how do we bring trauma-informed care to our folks. And I remember who was it said, who actually will, our community does not go and sit on a couch and talk to a counselor. It's about having that relationship of trust. And so we've actually also created lay mental health counselors, similar to what was talked about earlier on the panel before. And really it's about how do we create trainings and curriculum for folks that aren't necessarily licensed, because I think Secretary Becerra said this, it's about deep listening. It's about how do we build these spheres of empathy. So we now have lay mental health counselors that are able to provide support, care, and comfort at the initial beginning. If someone has been attacked or assaulted, that's that first point of contact. It's about building that trust. And then from that trust and providing navigation of resources, whether it's food, it's transportation, whether it's stipends, to be able to build that so that they can actually start getting some access to, again, healing and support. So it's not in the form of mental health, but eventually on that continuum, how do we build up to that? So I just want to say a few, sort of things and to be thinking about, again, is I think we need to have coordinated and agenda really around incentivizing bilingual mental health providers, incentivizing our licensed track students to work in the community, and then also be thinking about addressing our mental health crisis with this lens of equity and really making sure that language access and that cultural competence is absolutely paramount.
Thank you. And I think there were a number of comments that you were talking about, and part of it is just really recognizing that you can enter the mental health services through any door. And it's one of the strange things is historically in this country we separate the mind and the body, which I think all of us do. They kind of come connected. And for them to be able to do that not only gets rid of the stigma, but the other thing you talked about, which I think is really, really important, and I think many of the panels are doing that, is that you bring in community members, the paraprofessionals. We cannot wait for our folks to get their PhDs, their MDs, the MSWs, which in of itself does not really guarantee that they're going to be culturally competent, proficient. But it's also providing the training and the support of that, so I really appreciate your comments. And I think we're looking forward to hearing more from all of you on the panel. The next speaker is Laura Swartzenduber, and she is with the Director of Medical Outpatient Services at My Health, My Resources in Tarrant County, Texas.
Thank you. Good morning, everyone. My name is Laura Swartzen-Druber. I am a director over the Medical Outpatient Services for Adult Behavioral Health in Tarrant County, which is in Fort Worth, Texas, if you know where that is. I'm very happy to be here and very honored for the opportunity to speak with you all today. Part of what we're working on at MHMR of Tarrant County is that we have an integrated health clinic or clinics located within our behavioral health clinics. So opposite of my partner here. And so it's been a very rewarding opportunity to be able to have that access to primary health care within our behavioral health clinics. My background is nursing. As a nurse in a clinic, I saw a lot of people come in that, were taking okay care of their behavioral health, but beyond that, there was no real way to ensure that they were following up with primary care providers. So with the opportunity of having this integrated healthcare system, we were able to ensure that we could do that warm handoff over to a primary care provider. Within Tarrant County, 6% of our population is actually NHPI, and of that, we serve 1.4%. While that might seem like a low number, I am very encouraged by the fact that we are continuing to see more and more NHPI individuals there. And part of our agency, we actually have staff, 20% of our staff are of that population as well. So this has helped tremendously for our patients because they respond better to these providers. It's shown them that they have someone that looks familiar to them, that they have that cultural acceptance there, and they understand some of the stigmas that come behind that. Additionally, over the past 5 years with this grant, we were able to also receive our certification as a CCBHC, so a Certified Community Behavioral Health Clinic. And with that, we opened initially our first clinic, which was our homeless clinic. And this was funded and sourced by SAMHSA. And then my senior director, Brian Villegas, was able to start that, and he did a great job there. And so with that, we were able to expand access to 3 adult behavioral health clinics, our street medicine team. So these are people who are actually going out into the street, addressing people that are homeless in camps, things like that, and then our jail diversion program. By bringing together mental health, physical health, and substance use disorder services, this ensured our patients received holistic and coordinated care. Each week, our disciplinary teams meet together, and this does include our primary care providers, where we're able to discuss any challenges or things that are faced for these patients. And it's been very helpful because a lot of the providers that we have that belong to the NHPI community, they're able to provide that insight that we may not otherwise notice. And so with that, that gives cultural perspective and in turn increases understanding of barriers. As we acknowledge and respect unique cultural backgrounds of NHPI individuals, our healthcare providers establish trust and strengthen relationships. Because of this, we've seen greater adherence to treatment plans, medication adherence, and overall better health and mental well-being. I look forward to learning more today and applying this to our practice with our NHPI individuals. Thank you.
Thank you. And I think what's really nice is what you and Julie were talking about is, excuse me, is getting into the integrated field from 2 different perspectives, but integrated care occurs in both places. So whether you're in the health clinic and you need to recognize the underlying mental health issues, that's the whole health approach. Or in your case, you're going in a behavioral health setting, and that maybe sometimes the issues that they're looking at may have underlying physical. And so I think it's really sharing this kind of information about how we look at integrated care, regardless what door you're going through. It really is looking at a whole health approach. So thank you very much for that. The next speaker is Alyssa Vang, and she's a clinical director of the Vanguard Mental Health and Wellness Clinic at Woodbury, Minnesota. So, Alyssa.
Good morning. It is truly an honor and a privilege to be here today. My name is Alyssa Kayeng Vang, and I am a daughter of Hmong refugees. The Hmong are an ethnic minority group that came to the United States from a war-torn Laos after the Vietnam War ended. I'm also a licensed psychologist practicing out in Minnesota, where it's home to a large concentration of Hmong, about over 103,000, which makes up a big town. And so I'm privileged to be here today. Our clinic started out as a solo practitioner, and it expanded because of the demand for culturally responsive and linguistically competent services, as well as increasing referrals because of word of mouth. And so now we have 6 clinicians, and we are onboarding a 7th one next month. What's unique about our clinic is that all of our clinicians are Hmong, and we are all bilingual, and including our support staff. And so that means that 72% of our clientele are Hmong, and about 11% are other Asian Americans, including Southeast Asians, other Southeast Asians, and East Asians, South Asians, and other BIPOC communities. And then 17% of our clientele are white. We know that mental health is stigmatizing and access is a barrier for our community. And past research, in fact, the most recent one from 2007 shows that Southeast Asians, especially the Hmong, experience an alarmingly high rate of mental health disorders. The Hmong people, in fact, about 40 to 85% of the Hmong experience a mental health disorder compared to 22.8% of the general population. And 15 to 35% of the Hmong experience post-traumatic stress disorder compared to about 4 to 8% in the general population. Now, as a Hmong person with my own lived experience as a refugee and as a clinician treating my community, this data is very heartbreaking, but is not shocking, given the Hmong's migration history and their historical trauma history. I'm troubled, though, that the US Census Bureau has misclassified the Hmong as East Asians instead of Southeast Asians because our migration pattern is not similar to East Asians. This misclassification only further disenfranchises and harms us, an already invisible community, because of the different migration patterns. And so I urge all of you to help us in lobbying that the Census Bureau corrects this issue, and I urge us to do our part to help minimize access barriers and the stigma in my community. Thank you for that. Now, what we are doing differently at Vanguard to help with access is, of course, obviously, that all of our clinicians and staff look like the many clients who are coming in to see us. And so they note that we are relatable to them. We also speak their native language. And as a historically oppressed group, our team feels like we must also prove ourselves and our competency. So it is quite the compliment that we are equally sought out for our services by educated, middle-class, suburban white families. I know that there's also a session later on language, but I just want to say, because we provide our services directly in our native language, that there are cultural idioms of distress and linguistic nuances within a cultural framework that taps into the deep emotional distress that our communities experience. And so, as an example, suffer and endure is very much a part of something that we embrace, which is very different to the Western grin and bear it. And so I'm not going to go into details about that, but you can see that the sentiment that's different in both of them. And we also know that the mental health aspects or conceptualization for our Hmong is embedded in a holistic framework that is comprised of the body and the spirit and less of the mind. As a clinician, I just want to tell you, I love what I do, and the work is rewarding. Anecdotally, many of our clients do get better with treatment, and they do continue to refer their friends and their family to us. But the work is hard, and unfortunately, as a small clinic that's minority run, our revenue is based on fee-for-service and health insurance reimbursement. And so a lot of our work is just on our own free time. And so I'm a full-time clinician, and I'm doing all this administrative work and community work outside of that. Unfortunately, as a minority-run clinic, we don't have the leverage or the additional network or the relationships with funders. And so a lot of the funders that has been established that are bigger tend to get the resources, but ironically, they are contracting us to do the culturally responsive work. And so I just want to let you guys know that it's not about capacity or capability, but it's about the network that we lack. And so Sorry, I'm out of time, but I do want to share this really quickly. What we're doing outside of this is also we've launched a podcast on Hmong mental health so that those who are stigmatized or are embarrassed to seek services can still get the services. And we've also connected with primary care physicians. And yesterday we had a trainee from shamans to come and so that we can collectively do the work around health and healing. And so after the training, the shaman said that he was ecstatic that now he has a pipeline by which to also refer clients to us. And so thank you for this opportunity, and I feel hopeful that by sharing this with a greater audience that you can understand a little bit about the mental health in my community.
Thank you so much, Kaying. And I know we heard the bell ring, but I think your comments were so important, and there's so many issues you talked about. We know that the historical trauma for the Southeast Asian communities were profound, and as we're looking at it, that it's not to say foreign-born, it's understanding the difference between an immigrant and those who came as refugees, and that trauma there, and the profound physical impact that mental health trauma had on the bodies of Southeast Asians. So thank you very much. And one last plug is, when you're talking about small community-based organizations, they are struggling to survive. And if you and your organizations and others like you around the country disappear, there's huge vulnerable populations that are without services, and we cannot afford to let that happen. So thank you very much for the work that you're doing. The next speaker is Sherry Daniels, and she's the Executive Director of Papa'olakahi in Honolulu, Hawaii. And so Sherry, I'll turn it over to you.
Well, Velina mai kako, o Sherry Daniels ko uinoa no maui maio. Aloha. I want to aloha my other Kanaka in the room and our other Pacific Islander cousins. Mahalo for everyone joining us. I think for me, I want to set the stage and the intention that I want to aloha my kupuna, those that came before me, that set the path for where I'm at, and the generations in front of me, those that I've yet to see or I will see. So again, Velina mai kako. I think this is kind of an interesting segue to what I want to talk about when we talk about access and integration, and that is the role that cultural practices have in the work that we do. And so I want to lay the foundation that and I'm speaking for Native Hawaiians. Even though we're combined with our Pacific Islander cousins, we're really our own subset. We don't have other subsets in our community, it's Native Hawaiian. And for our community, and I'm getting emotional because we didn't have the word trauma in our olelo, in our mo'olelo, in our stories. That's not a word that our community knew in our storytelling. And so when I hear mental health, when I hear all of those things, that's very opposite culturally to who we are. And so how do we integrate culture when really our culture isn't what is being seen? Everybody recognizes hula. They recognize all these wonderful things that Hawaii has, and that's not who we are. So, and I'm gonna say this not in disrespect, but as I sit around and I look around at people who are very familiar faces, I also sit and I think, how many times have I heard AAPI? There's NH. We talk about erasure, we talk about not being seen and heard. But today, this morning, for the last I don't know how many hours, I have counted numerous AAPI. I might as well not be here. My colleague Kamana Opono might not have been here. So I think I want to just put it out that when we advocate for ourselves, whatever community we are, that we really need to be intentional in what we're saying, because those words, those actions, that is what resonates. And so I'm just putting it out there that we need to be intentional. Just like how I will not speak for my AA counterparts or my Pacific Islander cousins, that's not my kuleana, that is not my space. But I can stand in allyship with them. I also think that's really important when we talk about integration of cultural practices, because I hear cultural competency. We all have heard that. But just because you go to a 45-minute class, you get a certificate, does not make you culturally competent. It makes you culturally aware, and I appreciate when people want to learn more about our culture, just like how we all want people to understand our community's uniqueness. Mahalo, absolutely. But I think we need to recognize that when we talk about practitioners and healers in our communities, that we need to make sure that they're authentic, that they are cultural practitioners practicing our traditional practices, whether it's language, whether it's healing arts, whether it's all of those things. I think Hawaii, we're really unique. We have an insurance carrier that has spent the last few years integrating and reimbursing on cultural practices. That's very unique. I don't see that anywhere else in the state, in the country, except Aloha Care. So I really want to shout them out. And I know our state's 1115 waiver, they are looking at including reimbursement tiers for cultural practices. But again, what is cultural practices? And that's a conversation you need to have with communities, because what others may see as cultural practices is not what our community sees as a cultural practice. So I think that's really important, and the normalizing of what it means to be cultural and to integrate culture in that. And so how do we normalize it? We use language. We have language as part of who we are. We talk about it. I heard about what language revitalization is, and I need to point out for Native Hawaiians, we're actually the opposite. So our community speaks English, but we have a growing number of Kanaka who olelo Hawaii. But do you know, and Hawaii is the only state that both English and Hawaiian are recognized state languages, but you cannot utilize your olelo in spaces. We actually had a court case a few years ago where a Kanaka wanted to have his court case heard in Hawaiian, and it was denied. So if we're fighting for language access, please recognize that there are communities who speak English, but we want to use our olelo, our mother tongue, as part of that. So for us, that's language revitalization. And I want to leave, because I'm out of time too, a quote by Queen Liliuokalani. And so if you guys haven't heard of her, look her up, Google her, use our smartphones for that. But she said after her arrest and our island was overthrown, our monarchy was overthrown, she said, "Never cease to act because you fear you may fail." So, mahalo.
Mahalo. Thank you so much, Sherry. And I think you add a critical voice. It's again, so many of us become invisible, and the NH community absolutely has. And it's just as we see, there is no such thing as an Asian American. To be able to say Native Hawaiians and Pacific Islanders are all one is equally unjust. And when you're talking about cultural practices, it really is understanding, and there is no one cultural way to do it. It really is going back to the communities. And there is just a real richness, I think, in what all the panels had to say. And if we can give each one of them a huge thank you for their wisdom. So I think with that, we're going to be going on to the next portion here. And each of the sessions are designed so that we not only hear from speakers who are from the communities. It's not just an article they read, it's something they understand and they've experienced from their hearts. But it's also really important that we now bring in the voices of all of you out there. And so we have the 3 questions here. So the 3 questions we'd like for you to respond to, and also if the panelists feel free to also include on this. But what does integrated care, physical and behavioral health, but I would also like to add, as you know, we were saying that it's not just that, it's also how we integrate different types of services look like for Asian American and Native Hawaiian and Pacific Islander populations. What are the trends you see in terms of both physical health and behavioral health outcomes among AA and NHPIs? What cultural considerations should providers of primary and behavioral health care need to consider when serving AA and NHPIs? What are effective outreach, engagement, and communication strategies for AA and NHPIs? And what are the barriers experienced by integrated care providers when serving AA and NHPIs? And what are some successful strategies and interventions? So if anybody would like to respond to any of those, Tana?
Thank you.
And then we'll come over here.
Wow, still good morning. Good morning, everyone. Good morning. Louder, please. Good morning. We got the energy back, right? Thank you. Good morning again. My name is Vatana Peng. I'm the Executive Director of the Camboon Family Community Center, a nonprofit based in Orange County, California. If you don't know where Orange County is home to the happiest place on earth, Disneyland. Yes. Oh, it's so powerful to hear from our panelists, and I'm so excited because I can relate to so many things that the panel have said. And I think it is very important to also talk about the integrations of physical and behavioral health, but also from a CBO perspective, it is also important to talk about another innovative way is the integrations of behavioral health and the social services. So because a lot about because we have learned that a lot of our community still struggling with poverty. A lot of humans still live in low income. When you disaggregate data among AA and HPI, we have seen a huge disparity. A lot of them come to us for food stamp application assistance. A lot of them come to us for Medi-Cal in California, or called Medicaid, or come for Medicare assistance, or come from for SNAP. And that is the opportunity for us to really build the trust with that community members, and how do we help our community health worker who provide those kind of application assistance to screen for mental health issue in that community. Because they trusted community health worker, they share about a story of the family. If you know, like I always tell research that if you do a research in the Camboon family, you expect them to complete a survey or interview in 30-minute time frame, no, gonna be an hour, because they're gonna share their life story. So it is very important. One of the things that I really want to share is so powerful to think about how you can build those kind of integration between social services and also the behavioral health. And one thing we have talked about today is the actionable step to go back. I encourage you to go back and talk to your county social services and how you can work together with them to build this kind of relationship and build this kind of screening. At least they said, oh, I have a zillion applications to submit, but at least you can refer them to CBO who does the work. That is one thing, actionable step. And the other thing that I want to share also is that about the lack of the bilingual, bicultural, because we talk about that as a mental health professional, because one of the ways that I talk to our community members that, why don't you send your children to social services like MSW school, and also talk to them, because the pay equity issue for the mental health professional. How long does it take for them? They have to finish MSW, MFT. How many hours do they have to collect? More than 3,000 hours, and how much they get paid. So we all have an opportunity here to advocate for our funders. Anyone here, funders from both local government, state and federal, and also private foundation, to think about, if we want to build a pipeline for people to go into mental health professional, we have to think about the pay equity in that as well. And thank you. And last but not least, what barriers? Because a lot of time we tend to forget about the power of our community practices. We tend to look more to evidence-based practices. CBO like us, we write a lot of grants to get funding, and every funder provide us with the evidence-based practices that you use to do this program. I said, what evidence-based practice? Because some community have been understudied, like the Cambodian, the Vietnamese, the Hmong community have been understudied. Even a population level study. How do we have that data? We have to uplift the community evidence-based practices, the community defined practices that we call EDB, right? Community defined practice. For example, in our Western culture, we would say, oh, let's do a support group. You would go to a nice room with painting on the wall, light dimming, sit down on a nice couch. That is not working in our community, especially in the Khmer community. What does it look like in our community for a support group for mental health? Over potluck ethnic lunch, where they bring their food, they talk about how they cook it, and bring a lot of memories, bring a lot of issues. Oh, I have issues with my kid going through this. That's how we identify those issues and make me feel comfortable in sharing their needs and their mental health issues. So if you have a chance, go back to your state and talk to the funders here too. Do not instruct us to write any evidence-based practices, but allow us a community to uplift community-defined practices. Thank you.
Thank you. And on that note, Batana,
DJ.
it was very briefly, and we're going to ask people to keep their comments a little bit briefer. We're trying to get a hold of everybody.
Hey,
You
DJ.
said a lot, but the one thing that I do want to, I think, sort of highlight is we talk about integrated care. Again, we tend to focus on physical health versus and mental health. You brought in another element. We really talk about a whole health, public health approach. And I think that's very important, but thank you very much. And you guys, I know you've got really good food there. We had another speaker over here, okay?
Hi.
Oh, yes, Sherry, with a comment.
I do want to also say that you brought up a great point. I think all of us who gets funding, we kind of use our money to buy food. And how many of us culturally, food is the sustenance to work with them and heal us. So it's quite counterintuitive to not be able to use our dollars to get refreshments that are cultural. So I think that's a bigger issue I want to put out there.
Thank you very much. We had some other speakers over here. Please state your name and
sorry, I'm having a little bit of vertigo, so it's a little bit difficult for me to
if you'd
stand.
like to sit, that's fine.
Caroline Van, I'm the founder and president of the Missouri Asian American Youth Foundation. I would like to thank everyone for being here today. I'm so grateful to learn and build and grow with all of you. We are trying to set up the first AA NHPI mental health fund in Missouri. We conducted an asset map. I'm fortunate to be a field instructor at the Brown School of Social Work, which is one of the top programs in the country. I also want to acknowledge today my program director, Dawan Gao, who is on OPT with us and who has 2 degrees in social work. I do not know how to do any of this. She is an international student. And so one on the pipeline, right, side, every year at the Brown School, we have 40 to 60 Asian and Asian American, Native Hawaiian, and Pacific Islander MSWs who want to work in Missouri or in culturally competent environments, and I'm trying to figure out how to keep them here. Dawan's OPT expires in early September. I have 2 students who are practicum students who are Chinese international students, and we have a desperate need for these language services. And so one, I want to ask today for the Biden administration to include social work. I know there are certain psychiatric subspecialties that are included in STEM OPT, but it would be so valuable, right? We have these people who are trained, and it's not just at the Brown School, it's at UMSL, it's at SLU, who could bridge some of these gaps. And we cannot keep them in the country, much less in St. Louis and Missouri, right? So that's one. 2 is, if anyone knows actually how to set up an AA NHPI mental health fund, I have, because I'm not a therapist, right? I go to see a therapist. I don't know how to do these things. I'd love to talk to practitioners. We are working in coalition with Black Healing Circles. 3, we are writing, my interns and I are writing a mental health equity bill that I already have a Democratic and a Republican co-sponsor for in the Missouri legislature, because this is how we all heal together. And what I say to our allies and our friends is, we all need mental health because we have to live in this state with its state-sponsored violence, frankly. And 4, I ask, as an organization that started under 3 years ago, it is so phenomenal that the federal government is giving out monies for all of these things, but there is no language access mandate. And so when we call 988 in Missouri, Dawan called in Mandarin, and when I called the state COVID hotline in Mandarin and pretended like I spoke no English, they told me, or actually they said, do you have the internet? Go online. And I said, 我不懂, right? And my grandmother is 102. She cannot be going on 26 different websites to register for a vaccine. And so Erica and Crystal and I were in this conversation, and I know, and so I understand, right, that in some places that there are not all 15 languages are being translated. I said, no, we have been translating for 1.5 years for free without ARPA funds for city, county, and state. So One, I ask that if any of you want social workers, we have so many just in St. Louis who want to stay. And then two, right, it is a lot of pressure to have to.
This is, I think, a very, very difficult topic, and I really appreciate and thank you for, expressing your thoughts. It's really, really important, and I don't want to shortcut this. We've got some other folks, and we're out of time, but there's going to be another panel. Language access is core. When people don't understand the power of language, it's not just a polite thing. It is literally life or death. So thank you very much. I do want to make sure we have time for a couple of others, and you can raise these concerns in the last panel on language access. Thank you very, very much for participating. Hello. Okay, we've got a speaker over here.
Hi, my name is Toru Nemoto, Public Health Institute, Oakland, California. I'm a community psychologist, and first of all, I'm really, our team, we came. We really appreciate SAMHSA's effort to invite us, and particularly Jessica and Wesley. Those are our student intern. And first of all, I think, I think everybody knows federal funding for AAPI specific mental health services and research too, they're really underfunded. And I always attend SAMHSA meeting, but we're the only one to address mental health. We are part of NIH, NCTSN, SAMHSA network, trauma network, but it's the only one. And previous, we got the community grant, and again, it was we are the only one to address mental health issues, what particularly trauma-informed care and prevention for Asian communities. And I think, Jessica and Wesley, they did excellent presentation. We're proud of them. And we have done this student internship more than 5 years, almost 6 years. And first, we are kind of public health institute, research institute, and I usually take a master's degree or PhD student come in. And institute itself a little bit skeptical to provide an internship. They are paid interns, we pay them, and that's a little bit hardship. And honestly, first, maybe they won't get the one line in a college application, but not. They are done great job. And they involved in community advisory board. We meet quarterly, and they did a great job. And they many Asian background student, high school students, they want to be part of our team. And that's the most important things we have been doing. I'd like to expand more. And the other things, I usually propose kind of out-of-box proposal system things. And you can see that in front of this building, Native American Museum, right? And I went there, I think, a few times. Whenever I go there, I feel better, I understand more. And why not? Asian American, Native Hawaiian, and Pacific Islander Museum. It's a, great impact, majority of people, not only US citizens, but people visit here, and not only Asian and Native Hawaiian, Pacific Islanders, feel better, but the other people, as a minority people feel better too. And maybe white supremacists may change if they visit in the museum. And why not, like Kamala Harris, Vice President, can advocate to make a museum. That's a one big project, but in this long time, I think make big influence on not only mental health, but all people's idea about America, I think.
Thank you very much. And I just want to really briefly say, for providing internship, I think it's really important that our young people who are our future have a place to be able to learn and use a community-based participatory approach to research as we're putting them in the field. I think we have time for one more.
We have
Yes.
time for one more
One more.
question, and it's going to come from over there.
Thank you.
Hi, my name is Joanne Yu. I'm from the Asian American Federation in New York City. I think what we're really talking about is resources. What I'm hearing from all of you. I want to talk about the issue of subcontracting. I think it's my Hmong sister who brought it up. Because this nonsense goes on all the time. And the groups that are using us as their subs, they get the money and they get all the numbers. And we don't get to claim that, and we don't get to claim that expertise. And so that's been my fight for a very long time, so I'm kind of pissed off right now. But here's what the feds can do and the states can do. You need to make these grants smaller, and you need to make the application easier, because there are groups that have limited staff, fundraising staff to write those applications, and there are perhaps clinics that only have immigrants who can't speak the sexy funder language, because now my New York City groups, we fund 5 mental health groups in New York City. They're asking us, can we finally go for a federal grant? And I'm thinking, okay, so now I have to hire a consultant to do that, right? But it's like, you've got to meet us where we are, and we're not even catching up. We are still lagging behind. And the one other thing I want to say is, I love these spaces because I get to hear what everybody's talking about, but we are commiserating together, because here's the other person that needs to be here. I'm a New Yorker, can you tell? What I'm angry about is, where are the hospitals in these conversations? Because I want to tell you what I'm hearing in New York, right? So for my Hmong sister, we were working with a Southeast Asian community in the Bronx. They actually had a pretty good mental health program. One year they decided, we don't have money, we're not going to do it anymore. So then the community is outraged and said, what about all the programs that you did in language? Don't worry, we're going to take care of it. You know who that one staff person was? The file clerk. And that's how they got to claim that number, and that is not right. So where is the call out for some of these places that use our staff and they have false numbers? 85% of the mental health practitioners in this country are white. We are not sending our elders or our children to these places. And so as we talk about all of this stuff, there are lots of partners. And of course, the big places are going to be complicit because it works for them. It doesn't work for us. And so this conversation needs to be expanded. And when we go back, we need to start to call people out. But the federal government and the grant people need to meet us halfway, because they've got to make the money accessible to us. Thank you.
Thank you. There's so many things there, and I think as we're wrapping up, it's not only the federal government, I think it's with all the different funders. There are so many issues there that we want to have time to unpack, but it is how we make resources available to our communities on every single of you talked about. And so again, thank you for all of your comments and putting in. I'm going to turn back over to Rochelle.
Thank you, Dr. Ida. Wonderful session, great conversation. I'll invite you to go back to your tables so that you can also participate in the thought exchange. All right, so we are gonna pull one up again. Thank you to this amazing panel. Thank you. Okay, so by now you have figured out the thought exchange. I invite you to pull out your phones and to take the QR code into your phone so that you can come onto our site. And the question here again is, what are the most impactful or important steps that we should take in the next year in regards to what we just talked about in terms of innovative, expanding access and integrating care? I invite you to be as specific as possible. Your first thoughts around session 1 were awesome. They were a little general, but so call out a specific agency, call out a particular funder, call out a very specific action that you think will help with integrating care and increasing access for our communities. So we're gonna play a little music. You have 2 to 3 minutes to share thoughts. I want everyone to share one thought, everyone. I wanna see these numbers of thoughts equal the number of participants. So everyone share at least one thought. 3 thoughts would be great, and why that action is important, and then we'll start rating. So please first do your thoughts. Okay, if you haven't already done so, please shift over to rating thoughts, and we'll get a couple of your ratings in. We'd like to get try to rate at least 10 thoughts if you can. That'll help us with the platform so you can start to see what do you think are the most important actions. Again, a 5 is you strongly agree with that as an action. Anything less important, you can rate lower. All right, we got to that 11 ratio, which is great. If you want to continue looking at other thoughts, that's fine. But let me just show you what's been pretty stable on top right now. Action by SAMHSA and policymakers for more NHPI language options on 988. Because hearing the feedback today was so powerful and needs to be addressed. The second one is around HHS needs to encourage states to allow more flexibility in Medicaid spending to provide culturally competent care. And why? Because mental health looks different for the AA and NHPI population. And now something that's popped up higher is make grants available for all, smaller and easier to write. Evidence-based is meaningless when so many communities are understudied and have no data. Why is this important? Because we need resources and community voice. All right, so thank you. I'm seeing more specificity. I think you're getting it as we go along with this day. By session 4, we're gonna have it, right? So you all continue to add your thoughts to this platform. You can see how it changes with time. And the beauty of this platform is that we get to hear from everyone. Each and one of you have important ideas and actions to share with this group. And so we want you to be sharing those thoughts and ideas. We want you to be hearing what your colleagues are thinking from the Pacific Islands to the East. So we want to hear the variety of voices and perspectives that are being shared. At the end of this day, not at the end of this day actually, but in a week or so, we will be able to provide you with a report of this data. We really believe that data should be transparent and accessible to everyone. So you will receive a link with your follow-up in a follow-up email that will give you access to every single one of these thoughts that people are sharing so that you can continue to use this to generate your own ideas as well. But we will be developing more actions based on your thoughts. So thank you for continuing to provide them and for rating them in the platform as well. So we are gonna be shifting pretty soon into lunch. And before we do that, first, let's have a round of applause for everyone. We are back on time. All right. So I have a few logistics, but before I go into logistics, because I know I'll lose you before then, I have a challenge for you. Part of what folks said in terms of this being a successful event was that you wanted to make connections. You want to build those connections and relationships because we cannot do this work together. So I challenge you to find somebody who you don't know, maybe somebody that was across the room that you saw stand up when I asked a particular role or what you were doing, and introduce yourself. Tell them the story behind your name. This is my favorite community builder in the world because you get to know about somebody really quick and you'll remember their name better. So I will show you how I do it. I was born in the Philippines. My dad named me. He liked the actress Raquel Welch. Do you guys remember Raquel Welch? Okay, some of you may not. Raquel Welch was his favorite actress. And he had there was a Shell oil commercial that was playing at the time with 3 beautiful dancing ladies. So he loved this Shell commercial too. Rochelle, okay, Rochelle. But in Tagalog, it's spelled R-A-C-H-E-L, so everyone called me Rachel. So when I came to the States, everyone called me Rachel. I hated the first day of school because I knew I would have to correct my teacher, and I was so shy, sometimes I'd go for a week without doing that. When I got when I got naturalized, I decided I would change the spelling of my name to maybe help with that. So I added an E to the end of my name to make it Rochelle, but no one gets that. So anyway, I'm still called Rachel all the time. All right, so you all will have the story of your name to talk to somebody new, ask them the story of their name or what their nickname is, okay? So have that be your conversation starter. We are gonna do lunch. Again, Crystal mentioned that we were grateful to have somebody donate box lunches for you, and those are gonna be in the East Wing. The East Wing is directly behind us, to the right, past the elevators, and then to the left. There are 2 options, chicken, tikka, or vegetable. So you get your choice. You are welcome to eat lunch in here, at these tables, there's some benches back there. If you decide to leave the building, you may not, but you may. Don't forget your red band, okay? I saw people like, look, do you have your red band? Make sure you have your red band. Please do not leave without your red wristband. We do have a great keynote speaker who will be here at 12:40. He's Richard Louie, MSNBC news anchor and author. So please come back so that you can see him speak at 12:40. And if you are a session 3 panelist, please come up here and meet me. We have your lunches, so you don't need to stand in line. Oh, can I get a lunch too? Okay. I just realized I don't think I have a lunch yet. All right, so thank you all. Enjoy your lunch. Please talk with somebody new and enjoy your break. Thank you.
Good afternoon, everyone. I hope you've been enjoying your lunch. It was really delicious. Please begin to take your seats. We are just a few minutes behind schedule, but our speaker is coming momentarily. Thank you. Can everyone please take their seats? Thank you. Before we start the second half of our program, I just wanted to mention that at the end of today's event, we will be having a no-host happy hour at Hamilton's Bar and Grill, which is on 233 2nd Street Northwest. We'll put that up on the screen at the end. But please, if you want to continue to network and spend some time with your colleagues, you can reconvene at Hamilton's Bar and Grill after the event is over. Thank you. sorry, yeah, just move the microphone. Okay. All right, hello everyone. I hope you had a great lunch. Please take your seats. My name is Vivian Chow. I'm with the WHIAANHPI office. I really have the great pleasure of introducing our keynote speaker for this mental health summit, Richard Lui. Richard is a best-selling author, filmmaker, accomplished journalist, and news anchor for MSNBC and NBC News. Richard's charity work includes serving as global ambassador for Plan International USA and is a board member on several nonprofit boards, such as the Angel Island Immigration Station Foundation. Of note, his most recent documentary, Unconditional, profiles 3 families at the intersection of mental health and caregiving as they turn the corner, showing the power of unconditional love. Let's please give a very warm welcome to Richard Lui. Thank you.
Good afternoon. All right. This is such an important gathering. I cannot thank WHIAANHPI for doing this. And when we get to gather as practitioners in different spaces, it is always some magic. Anybody experienced any magic yet? Yes, all right. Just on that table. That was 5's got magic. Anybody else got magic? All right. People coming as magic. All right. Well, you got 4 more hours, I think, to find the magic, and I cannot wait. I wanted to share a story that is related to the topic today about why and how we get to the topic of seeing and doing things around mental health. And it's a lot of it's in the cracks. And I want to share a story with you that may not seem off the top that there is a linkage here, but let's go for it. I work at MSNBC and NBC News right now. I worked at CNN before. And I remember when I first tried to get that job, it wasn't easy. I can remember the early moments before I actually took that position. And for any of you who have done this before, it is not fun. It was my first screen test. And that screen test, I had to fly from Singapore to Atlanta. And I was staying in the hotel. I remember looking out the window, and I saw that big CNN logo that, for those of you who are any Atlantans here, you know that sign might be going away if it's not already taken down. But when I first saw that neon draw out CNN, as somebody who looked like me and came from where I came from, and that I could be interviewing and being on that set the next day, I could not but call my dad to say, look at this. So I called my dad. I said, you're not going to believe this, but I am standing right now at a hotel window. I am looking out, and I see this blinking logo. And that the next day I would be sitting on set where close to 500 million people would watch every day across the world, because it was for CNN International. And I told my dad, and he just laughed at me. You know, the next day, because I was changing careers, and that's a whole other story, but it was quite an event just to stand there. And the next day, I walked into that sprawling building from the hotel, which is connected to it. I, had to go to makeup, and I watched as the 2 makeup artists were kind of experimenting with how to match my skin tone. And I'm pretty sure I saw one of them Googling best makeup hacks for Asian males. Yes, I see some of you have done that before, because it is exactly that funny. But surprisingly, if you've never done that, when you're bored at work, first of all, don't tell anybody, but try to search that. It does not bring up many results. Then they showed me the desk, and I sat down. And the producer turns to me and says, we're going to put some stories in the teleprompter and just start reading them, please. I want to go into the control room next, where I'll be following along with you. You got any questions, Richard? Internally, I was saying, can you stop me from sweating, please? Because I was sweating a lot. And out loud, I asked, do I read until I am told to stop? You know, is that the way I work with a teleprompter? Yes, she told me, and then began my screen test. Next, the director in my ear says, cue. And I had used a teleprompter for a year at that point. But this time, for reasons you understand, it felt new. A soundbite with video came up on the screen. I was thinking, that's a moment to rest. I can just, let that video go. The producer gets in my ear again and says, Richard, we're getting some breaking news out of Siberia. A plane has gone down. You're going to have to, and when this tape is done, start talking about this breaking news story. So, of course, I'm sweating even more now. And by the way, how am I supposed to deal with this? I mean, how many people were on board? I asked the director. What was the airline? Do we know why? All these questions. She hit the button and said in my ear, we don't know the airline. No cause yet. Now, after this sound is done on screen, you need to summarize. You have 45 seconds. We understand 100 people were on board this plane. 45 seconds, as all of you know sometimes when you're put in these situations, it feels like 45 days. And I was just like, okay. So I grabbed one of the script pages, and this is a trick if you ever want to do this and you're sweating. But I had the script pages, and I said, okay. And I started patting my face like this to get all of the sweat off. Try it. It really does work. So I patted my face. I jotted it down. She said, 20 seconds until you have to go. And by the way, I was also wondering, this is supposed to be a screen test. Why are they putting breaking news in the middle of a screen test? 10 seconds. So I shook my hand, and there's some exercises we're taught to do. Any singers in here, you do bumblebees? Bumblebee, 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 no? Okay, so that's what I was doing all these other exercises they tell us to do, breathing. Shook my fists out like this. The soundbite ends, and she says, cue, and I gotta go. And by the way, those bumblebees, I could have been mistaken for a crazy person with screaming out my favorite tuna, but I had to get all of that stress out. I turn to the camera, and I say, now to some breaking news just into CNN. We have a plane that went down in Siberia. 125 people were on board. We don't know the cause. We will get you the latest information when we do get it to our news desk. More details as we get them. All right. So I felt I got it done. So I thought I did pretty good on that screen test because I got through that, right? So a week later, I'm talking to my agent, and my agent goes, you didn't get it. You did not get the job. And I said, but I went through the screen test famously, I thought. I thought I really did a good job. And he said, well, what did you do? I told him about my, preparing, writing down the notes. I told him about, how resourceful I was, ecological, using the paper in front of me. I told him about the bumblebees, like I was prepping. And he said, hang on a second. That's it. They're not watching what you're doing on camera, Richard. They're watching what you're doing off camera. That's why you didn't get the job. So, as my life continued and I was working at CNN for some time, my father got diagnosed with Alzheimer's, and I had to make a choice. Would I leave this job that I had worked for so long, or would something else happen? I was at MSNBC at the time. And that's when I realized it would be the right choice to ask my boss at MSNBC if I could work less, but also knowing that if I asked to work less, I'm probably saying goodbye. I'm probably saying goodbye to a job that is 8 days a week, as I often say. Instead, Yvette Miley looks at me and goes, you know what, Richard? I'm taking care of my mom too in Florida. And I was like, if none of you are religious, I got religious then, because I could not believe this was all happening in one little room. And so began my journey for 7 years flying from New York to San Francisco, about 250,000 miles a year. And then I realized what we do off camera is what's most important. So as we talk about mental health, as we look at the journeys that we all take, I certainly, during those 7 years, have wondered about this work that I was doing off camera. People would often say, Richard, how are you? How are you doing? And I would say, I'd stop. I'd stop and think, how am I doing? Honestly, trying to take a stock of, what I'm going through. And then I'd answer. And after I finished the journey, my father passed a year ago, and as I was undertaking the project that Vivian, thank you, mentioned, and I hit done, after 7 years filming this, I realized that it wasn't just what I was saying at the time. It was probably 50% greater. That meant the cries were 50% bigger. That meant the laughs were 50% bigger. And that was okay, that I didn't get it right, that I was trying my darndest and listening and trying to answer to the best of my ability. So being okay is not okay. Being okay is what I mean to say. And we all know that. And when we do ask others, is what I say in often conversation side on the side, is when you ask how are you really asking how are you? Is that throwaway? When you ask how are you, really mean it. Really say how are you? How are you? How are you? And listen. Otherwise, just say hello. Hi. Great to see you. Who are you again? But great to see you. But let's make how are you really meaningful. This is part of our daily off-the-camera stuff that we do, that we can listen to other people, to see that mental health is not mental illness. As so often has been said, right? Mental health, as soon as we say it in media, it equals mental illness. And that is a challenge and a problem. As often is said by the practitioners in this room, mental health equals health, right? Mental health equals health. But how do we get to that point where it doesn't have all these affectations in media and in culture? And I think part of it is if we can make it accessible in different ways. You know, the last 4 or 5 years, got a little spare tire here. Anybody else got a little, put on a couple LBs, KGs? All right, you're shaking no, you do. That means you did. Yeah, I know. Well, I did. I got a little spare tire. But I also got one on my brain. And I got to work that off too. Got a little spare tire, right, running inside of this. I already have a big head, but that happened. And so when we are thinking about how to address it, when I'm trying to explain it to others to understand that it's not these polar extremes of screaming at the sky, that it's all of these shades in between that we need to embrace and love and help with, how do we get there? Because that's easy to say. And I think the spare tire is one way to tell it to other people. Because how do we deal with physical health when we got the spare tire? You shook your head that no, that means you do have a spare tire. But what, anybody, table 5, what do you do? Do you go work out? You walk? You paint. There you go. Very vigorously, right? Just like it, yeah. So, I mean, whatever we do to work off the LBs on the spare tire in our tummy is the same approach we should analogize for this. That we can have strength coaches, that we can go on exercise, we can have calisthenics, that it can be a strength. When I was talking with, I did a series of mental health seminars with a yoga group. I don't do yoga, but I was there, and the last person to speak in our first seminar was a 13-year-old, and she said, "Do you mind? I know we're out of time. Can I ask a question?" I said, "Sure, please, go ahead." And she says from the back of the room, "You know, we have these mental health days every month or two. How come it's always about it being as a problem or weakness? Why don't we talk about this as a strength, as a muscle?" That's right. And I thought she dropped the mic when she said that. 13 years old, and she brought home the very essence of how all of you as practitioners and policymakers, the difficulty you face, those who've gone through it, as many of you have in this room, how do we turn that around to say, no, we can be strong when it comes to mental health. It is possible, and we need to express that in the ways that we use the language that we do. And I know when you say the word mental health, just as I do when I say it on air, there's an immediate reaction. So our objective, I know, is to show that instead it can be something that we cherish. Our mental health, just like our physical health, that we can be strong and that we can be ready for those moments. I wasn't ready when my dad went through Alzheimer's. Am I ready now? I'm a little bit more prepared as I care for my mom in my mental health as I go through that journey. So the muscle set underneath the spare tire is better, and I'm glad that it is. And the underlining reason why I started with that story is much of that happens, much of that work that we all do is not what other people see. It is not what we do into a camera. It is often what we do with our loved ones, and it is off camera. Thank you.
Thank you so much, Richard. We're very pleased now to have a slight change in our program. We'll have a fireside chat moderated by our own executive director from WHIAANHPI, Crystal Kai, with the talking about federal and local approaches to advancing equity and mental well-being for AA and NHPI communities. So let's please welcome our fireside chat speakers to the stage.
Well, thank you so much, Richard, for sharing your just inspiring personal journey, but also, serving as our keynote today. That was a really, really powerful statement about how, we must treat our mental health in the same way that we would with our physical health, and really address the stigma and the barriers that so many in our communities face. We are now over halfway through our AA and NHPI Mental Health Summit. I know it's been a jam-packed day. I hope you all were able to get some lunch. And I'm excited to be moderating our next session, which is a fireside chat with 3 phenomenal leaders, all women, may I add, who will be discussing federal and local approaches to advancing equity and mental well-being for Asian American, Native Hawaiian, and Pacific Islander communities. So I know we're a little pressed on time. You have everyone's bios, but I'm going to briefly introduce at least their names and titles, and then we'll go straight into our questions. So first, we have Assistant Secretary January Contreras, who was appointed by President Biden and confirmed by the U.S. Senate to lead the U.S. Department of Health and Human Services Administration for Children and Families, which is the United States' largest human services administration. So we'll be hearing from her shortly. We are also honored to have with us Catherine Neese, who serves as the Deputy Assistant Secretary in the Office of Special Education and Rehabilitative Services at the U.S. Department of Education. And last but not least, we have Marian Suji, who is the Deputy Director of Behavioral Health at the Hawaii State Department of Health. And we're going to be hearing from all 3 of these leaders on the work that they are doing within their respective agencies to advance mental health services for our diverse communities. So I'm going to start with Assistant Secretary Contreras and Deputy Assistant Secretary Neese. This question is for both of you. In recent years, we have seen a drastic uptick in violence targeting Asian American communities. And a lot of this, as we know, was tied to misinformation and disinformation surrounding the COVID-19 pandemic. Can you talk a little bit more about your respective agencies' roles in preventing and addressing racially targeted bullying and violence? And I'll start with Assistant Secretary Contreras.
Thank you for that. So the Administration for Children and Families, or ACF as we're called, we are the human services part of HHS. When you look at HHS, we have everything from Head Start, child care funding, refugee resettlement, child welfare, and many, many other parts of the safety net of our country. So our role is, in partnership with agencies across the federal government and across HHS. In this space, I think partially what we've seen from HHS is leadership, and includes yours. but leadership to start to build a culture within this agency, or build on a culture, because there's really great people here at HHS, and carry that message outward in terms of embracing one another and protecting one another, and making sure that we are doing our best to create safe spaces, both mentally and physically, in all the work that we do at ACF. At ACF, we house a couple of programs that are very unique in that we have funding specifically to address family violence and domestic violence, and to support survivors, to support prevention, and to support families and their children in this space. And what you've seen with bipartisan support and the leadership of this administration is really unprecedented amounts of investment into culturally specific services. And I know there are people in this room who are helping to distribute those funds into local communities. So for example, through ACF's Office of Family Violence Prevention and Services, we recently awarded $1 million in our funds to serve the Native Hawaiian Resource Center on domestic violence. $1 million in grant funding just recently for a cooperative agreement to monsoon Asians and Pacific Islanders in solidarity. Again, these are specific funds that I'm just so proud of, because it seems hard to imagine that maybe even 10 years ago, we would have had this bipartisan support to acknowledge that, in fact, if we're just giving money to the organizations that are used to getting the money, we are leaving a lot of people behind. And so recognizing that in order to create equity in this space, in order to create safety in every community, that we're going to make sure that we are specifically targeting organizations that serve communities who are so often left behind. And this is building on a $13.2 million investment in the Asian Pacific Institute on Gender-Based Violence, which turned around. That's a coalition and awarded money to 41 organizations in local communities. And those are going to be where you live, you know, in your own backyard. And so I'm very proud of this administration's commitment and boldness on this issue to say this is what it takes to build safety. We also in ACF have the Office of Trafficking in Persons, which is, you know, different than what we're talking about, but also it's part of what's creating safety, and it's part of what's building education in local communities. It's a part of what's trying to create safe communities. And there, again, a very specific focus on especially Native Hawaiian communities, recognizing that there are some challenges there that have been brought to us about needs for support. But across the board, you know, we're trying to really bring our folks together to problem solve together, and that's with the interagency overall as well.
Great, thank you, Assistant Secretary Contreras. Deputy Assistant Secretary Neese, if you could share some of the resources that your office oversees at the Department of Education.
Sure, and thank you for having me today. And it's one of the great things for me to be a part of this administration is the really weedy and important work that we're doing across agencies. So Assistant Secretary Contreras' office and my office work very closely on a number of things, as we do in many other elements of HHS. So it's an honor to be here, so thank you. I think one of the things that we do in collaboration with the Substance Abuse Mental Health Services Administration is we jointly fund a Stop Bullying website called stopbullying.gov that has tremendous resources for teens and children who are being bullied, but for parents and educators and community members. And I think that's one thing. I mean, people always look to, if they see a problem and they hope someone has a solution, and they're just a mountain of great resources there. Another thing that the Department of Education does is enforce the federal civil rights laws when it comes to public school students. So whether there is harassment or discrimination based on gender or race or ethnicity or disability, our Office for Civil Rights will, if you file a complaint with them, will investigate that complaint. One of the things we're seeing across the country now from various sources is policies that may be creating a hostile learning environment. And OCR is working with a school district in Georgia where they are banning books and doing things, and the parents of kids from non-white backgrounds, quite frankly, are complaining that this is creating a hostile environment for their children. And so OCR is investigating that. And I think it's really important that we want school to be a place where everyone feels safe and secure. And the CDC put out some really troubling data earlier this year about the lack of connectedness and how students are feeling sad and hopeless, and how profound that is, which leads to all sorts of other not good things, and certainly influences how children are able to be successful academically if they are really depressed or anxious or fearful because something horrible is happening at home and there's nobody at school to help them navigate it. That's a problem. Children are not going to be academically able to be successful. And that's why, as part of the Bipartisan Safer Communities Act that the President signed last summer, we have in the neighborhood of $2 billion that are going to schools to help them create safe and supportive learning. Part of those funds are going to increase the supply of mental health professionals who can work in school. And while we need more, this is a sizable investment that I think we're really proud of and looking forward to seeing that make a difference in rural and urban communities across the country.
Great, thank you so much. And I want to thank you both for recognizing, I think, two of the populations who we have also represented here are Native Hawaiian Pacific Islander communities, as well as our youth, who I think oftentimes feel overlooked or underserved in some of these, these spaces and the conversation. So I really appreciate the work and also the resources that are being brought to bear to serve those in addition to other communities. And actually that's a perfect segue into now we are gonna talk a little bit about some of the services available at the state and local level. And we have with us Deputy Director Suji from the state of Hawaii. And actually just 2 weeks ago, our commission and our White House initiative were out in Hawaii to host our inaugural, not inaugural, but our commission meeting as well as a listening session. And part of the reason our commissioners chose the state of Hawaii is because of the significant AA and NHPI population there. About over half of the state's population is AA and NHPI, and really, reflects that diversity of, and also the unique challenges that the communities face. And so I wanted to see Deputy Director Suji, if you could talk a little bit more about what are some of the challenges that you see in the state when it comes to AA and NHPI communities, and their experience accessing behavioral health services, and what is the Hawaii State Department of Health doing to address these issues?
Thanks, Crystal. So I would say that the very first thing that you have to do in order to move the needle is elect a governor who is a doctor, because then you've got top leadership who really gets it and is very supportive of all of your initiatives. And I think that one of the things that's really been recognized in this administration is it's not just behavioral health. It's not just health. We've got to look at all the other partners that we've got, whether it's in IT infrastructure, labor, Department of Education. We have health and human services split up, but we all need to really work together to improve the mental health of all people of Hawaii. With that said, we have been embarking on a number of different initiatives. I think probably the biggest one is our Office of Wellness and Resilience. And that was a new office that was set up legislatively actually last year, and arose out of a task force addressing trauma-informed response. And it really is a gubernatorial level office that is addressing and making aware the trauma, the historical trauma of basically almost our entire state, and addressing that as we move forward. and also providing the kind of education and input that's required for different programs. At the Department of Health, we're looking at, this is an issue for everybody. We are based on a payer-informed system. It should be a patient-informed system. And so we are looking at how do we switch things over so that we are looking at doing the right thing for the patient. We all know that continuity of care is probably one of the most determining factors. And so how do we shift that system to look at the patient rather than who's covering the bills? We're working with our Medicaid folks, and as Sherry pointed out earlier, we probably have one of the only waivers that addresses the importance of cultural practices and making sure that there's reimbursement for that. We're looking at expanding telehealth, providing iPads, providing data plans so that folks that are in the rural communities that can't necessarily get to our clinics, get to health centers, still have access. And this is particularly important for the kids. I think that we were actually doing a lot of telehealth with kids and adolescents prior to the pandemic, and really found that because they're so comfortable on devices that it was a really good way for them to warm up to our healthcare providers. And we're also very much emphasizing the importance of cultural relevance in all of our RFPs. All of our providers, our community partners, really need to make sure that they are providing culturally relevant and also practices, and also providing the workforce that can identify with our populations. And lastly, the workforce. We're all struggling with workforce, just overall in terms of healthcare, but we're really looking at peer mentors as a way to enhance our workforce. We've been using peer mentors with adults, but one of the things that we're really excited about is working on a certification program for adolescents in the schools so that we've got peer mentors at that level.
Great, thank you so much, Deputy Director Suji. I'm going to go next to Assistant Secretary Contreras again, and you were able to explain a lot of the services that are provided through the department. I think when people think of HHS, they automatically think of health, but do not realize the human services component you mentioned and how integral that is actually to advancing health equity. And so wanted to see, just given how diverse the Asian American, Native Hawaiian, and Pacific Islander community is, this has come up multiple times today, the need for culturally competent care, the need for language access, given that about a third of this population is limited English proficient. And there are so many different populations. We have our youth, we have our seniors, there are we have also, refugee communities, immigrant communities, but also our indigenous Native Hawaiian and Pacific Islanders. So are there specific resources that maybe you haven't brought up yet that you would like to share that ACF, is either championing or even more broadly throughout the department that you think would be helpful for our audience to be aware of?
Yeah, I'd start with the leadership of Secretary Becerra, and I know Crystal knows this well, but he often shares his story about growing up and having to translate documents and having to be the interpreter at medical appointments with his family. And he came in and has not stopped that drumbeat, that language access is equity, language access is health equity. We're not doing our job without language access being a real, true thing in this country. And so he has put out a call to action to us. So there's a couple things that you can find on the website if you wanted to. We have a report from our HHS Office of Civil Rights because there is a process. If you see things happening that shouldn't be, if there are providers out there that aren't meeting the mark, complaints can be filed and enforcement actions can be taken. Now, we recognize we have a lot of work to do to build up the process and systems that we need, but it is something that is actively being worked on here. At ACF in particular, when I got here in my position, one of the first things I did was create a new fund for translation services, because I started to hear, oh, but that's very expensive. And that's not an option, right? We need to understand that is not an option. We are a large $62 billion agency. That's just ACF. We put out grant money. We provide services for people, sometimes in their most vulnerable positions. And so it's a cultural process as well for us internally and for our team to understand that this is an obligation, that we don't meet our mission without actually creating language access. So we did at ACF, oh, thank you. At ACF, we, like the entire department, from the call to action from President Biden and Secretary Becerra, have prioritized mental health. So glad that you're having this gathering, you're in this space, and including ACF as a part of this. It has become a priority for us, and we recently, the main thing we're trying to attach it, because we didn't get a lot of funding, although HHS has in this space unprecedented amounts in schools and elsewhere. At ACF, though, we're building those supports into the systems that already exist. And so you should see that. That should be your reality. And if you don't, all of you are here for a reason. You were chosen and invited for your leadership, the roles that you play in your community and in this country. And I ask you, hold us accountable, right? Give us that feedback. Let us know when you see gaps that just aren't acceptable. But we'll keep doing that work. We just built a behavioral health page from ACF. You'll look on the top of it, and it has a translation into multiple languages. And that's the way all of our tools should be. And we're working, there's a language access initiative across the department under the leadership of Secretary Becerra. And so we all are being asked to go dust off those language access plans. They are not to sit on a shelf. And to delve in with our teams so that we're not just at the top embracing this, but our staff is understanding what the responsibilities are and giving us ideas about how do we really institutionalize that. So thank you.
Thank you. I know we are, and yes, let's give another round of applause. It's really phenomenal work that's being done at ACF under the Assistant Secretary's leadership, and then also, as she mentioned, also just department-wide through Secretary Becerra. I next want to go to our Deputy Assistant Secretary, Nice, and talk a little bit more about the mental health support in schools. I think one thing we hear often from students is just, again, about the lack of culturally competent health or behavioral health services and providers in schools themselves. So can you talk a little bit more about the work you're doing at the Department of Education and any programs you may have or initiatives to address that pipeline issue?
So earlier this year, Secretary Cardona, who also believes in multilingualism to the core of his being and really celebrating multilingualism as a skill that we want every student to participate in, that just having one language is not as good as having two languages. So that's something that's super important to him. He initiated something called Raise the Bar, Lead the World. And we put a lot of money into education as a result of the pandemic, which has been great and absolutely essential. But he wants to see real outcomes, as do we all. And so in our Raise the Bar, Lead the World initiative, there are two that I want to point out to you. One is that we are investing in every student's mental health and well-being. And when I say invest, we're really investing, and it's been exciting work, and our policy goals are really in three areas. One is to increase the skill and knowledge of people who are currently in schools, who can help provide mental health services. The other is to increase the number of mental health professionals in schools, and the latter one we're doing in partnership with institutions of higher education, and about half of them are with minority serving institutions. So we feel really good about that, recognizing the cultural competence. It's not enough to know how a brain works, but you need to understand the context of a student and their family and their culture and their community in order to truly help that student navigate the world. The other piece that we are doing is trying to advance policies to make those services and providers sustainable. And through the Medicaid program, which serves about 55% of all children in school, trying to make it easier for schools to appropriately access Medicaid reimbursement for these services. We really want these things to be available to students for the long run, and trying to put in those institutional policies so that can happen is something that we're very important. We're very much working to do in partnership with our colleagues at the Centers for Medicare and Medicaid Services. So it's an exciting time to see the partnership between health and education, really wanting to make this these services and supports truly available to our students and their families.
Great, thank you so much. And next I'll go to Deputy Director Suji. And this will be actually our final question. I know we're running a little behind on time. So last year, the U.S. Department of Health and Human Services awarded $700,000 to the Hawaii State Department of Health to develop our nation's first ever Asian American, Native Hawaiian, and Pacific Islander Center of Excellence on Behavioral Health. So can you please share a little bit more about that initiative and the resources and work that the center is providing?
Sure. So shout out to SAMHSA for putting this out and awarding it to us. We were really proud and pleased to have been awarded this. This is a center that it's a virtual center, and it really is our center. While we were given the award, we have partners in this. Papaola Lokahi is one of our partners, along with San Jose State. And I just want to give a shout out to both John Oliver, who's sitting back there, who is our PI on the project, and Sherry Daniels from Papaola Lokahi, because they have really been doing the heavy work on this. So ask them the questions, the detailed questions. But we were able to launch our website with some webinars back in May, and I encourage everybody to please visit our website. It is AANHPI-ohana.org, and this is a resource. It's a clearinghouse for information, for resources, for reference materials, for training information, and we really want everybody to own it. To kind of use the food analogy, we're hosting the potluck, but we're asking all of you to come and bring a dish. Bring your best dish. Bring your best practices, your best research. Bring your resources, because this is how we're going to improve our collective lot. We need everybody's input. It can't just be 3 organizations, and it's not just 3 organizations. This is a work in progress, and we're looking to improve it. The more dishes we have at the table, the better it'll be. So we do have a couple of webinars up so far. We've got a framework, or at least the beginnings of a framework for some best practices. And we're also looking at developing these regional steering committees, because we do recognize that there are regional differences as well. What's happening on the Northeast is very different than what's happening in Hawaii or in California. So we have regional advisory committees to inform our steering committee for the Center of Excellence. I encourage all of you to get involved. Reach out to folks that you think should be involved. The more, the better. This truly is our site.
Great. I love that. I love the imagery of a potluck and everyone being able to bring something to the table. So I know we could have easily gone on for another 20 minutes with our incredible panelists. Unfortunately, we have to bring the session to a close, but I hope that the audience, for all of you tuning in virtually as well as here in person with us, were able to get at least a glimpse of some of the incredible work happening across the federal government here within HHS, as well as the Department of Education, and as well as at the state level. But again, with the Center of Excellence, it's not just a Hawaii-specific resource. It is meant to be nationwide. So again, I hope that you will be able to learn more about these resources. We'll also be sure to share links to some of the resources that were mentioned earlier today. So thank you again to our incredible panelists. Let's give them a round of applause.
All right, thank you everybody, and thank you to our panelists again. I'm gonna go ahead and we're gonna do a little chair switching up here, but while you're in your chairs, let's do a little like after lunch stretch, because I know how it gets to be after you eat lunch. First of all, how many of you all know about, if you have called 988 or know somebody who has called 988, stand up. Okay, so let's just take note of the number of people who know someone or who has called 988 or has, great, thank you. Everyone else stand up with them. All right, everyone else stand up now. Okay, let's do a little spinal twist with our neck. Take your right hand and put it over the left side of your head and pull it over. Switch hands. Okay, everyone do a little twist to your right. And a twist to your left. Take your hands and clasp them behind you. Do a good stretch. Session 3 panelists can come on up. Okay, Trina, come on up. All right, you all can sit down. I hope you had a nice little stretch there. All right, and I'd like to welcome our Session 3 panelists, and our facilitator today is Trina Dutta with SAMHSA, so I'm going to pass it over to her, and we'll take it away. Okay. Do you have a mic?
Can you hear me? Great. Okay, good afternoon, everyone. It's really great to see everybody here today. As Rochelle mentioned, my name is Trina Dutta. I'm a senior advisor at SAMHSA, and really excited that SAMHSA has been able to partner with WHIAANHPI for today's amazing event. Just want to give credit to Lark Huang. I'm one of the Lark Huang fan club members. I've known her for 15 years. There's a bunch of us here. So I just want to give Lark credit because we brought her out of retirement to come back, and then rewarded her by planning a day-long amazing event like this. So many thanks to Lark for pulling this together with our WHIAANHPI colleagues. So today, this panel is hopefully going to be a really exciting opportunity to talk a little bit about innovation. And I think we've already heard today many invocations of 988, which has been a really big SAMHSA undertaking over the past +1 year, and then also around our CCBHC program. And I think that what we really want to try to do today is to think about when these innovations and these sort of like big new programs are moving out into the atmosphere that we're all working in, how can our community-based organizations, in particular the organizations that many of you represent, really engage with these opportunities and with these innovations in support of the communities that you serve. So we have an opportunity to have some of our federal leads on our 988 and CCBHC program today to talk a bit about those programs, but also to hear from some of our community partners around ways that they have been working or engaging with some of these systems, or ways that they think that we as at the federal level could do better to do more engagement with our community-based organizations. So I'm going to go through and have each person introduce themselves and provide a sort of 5-minute orientation. I've been asked to be keep people really on time, so apologies if I don't want to be rude, but I think we're really trying to get through so that we have time for the rest of our sessions today. So I'm going to start with Pate Suyomoto, if you don't mind. We have 5 minutes to introduce yourself and talk a little bit about the work that you do.
Ready, set, go. Okay. All right. Thank you for inviting me here. I'm going to tell you just a little bit more about myself. I identify as a third-generation Sansei, mixed heritage Japanese American, and my pronouns are she, her, and they. I earned my PhD from the University of Pennsylvania and did my research on anti-racist education and issues of race and racism. I'm the training director for the National Asian American Pacific Islander Mental Health Association, or NHPI, and the director of NHPI, which is the National Asian American Pacific Islander Empowerment Network, which is a network of NHPIs with lived experience related to mental health concerns. I'm also the Associate Director for Equity for the Mass Coalition for Suicide Prevention, or the MCSP, and I'm one of the authors of Widening the Lens, Exploring the Role of Social Justice in Suicide Prevention, a Racial Equity Toolkit. And I'm a person with lived experience. I have spoken and written about being a suicide attempt survivor and my struggles with complex PTSD and major depression. And I think that 988 and CC BHCs are wonderful concepts and much better alternatives for the lived experience community than 911 and the emergency room. In Massachusetts, before 988, there wasn't a connection between mental health emergency services like mobile crisis and the crisis calls. Now there's more coordination. And CCBHCs are, I think, a great idea and could have a huge impact if implemented widely because they could have connections to local communities, they could train for cultural relevance and cultural humility. There are ways that they can be much more culturally responsive, I think, than ERs, certainly. We need to have alternatives to ERs. I have personally been in an ER for a mental health crisis. My daughter has, my mother has, and also I have friends. None of those experiences were good, none of them. They were all, we were treated very, very poorly. And so, I mean, my hope is, and I've never been to a CCBHC myself, is that it would be a better experience. I have concern about availability. I looked on Massachusetts' website to see what was going on with the community behavioral health centers, and a lot of them are open 8 to 8. There's a couple that are open 24 hours, but they're in Boston. You know, I mean, like, what if you're in someplace else, right? So I'm worried about that, because crisis, in my experience, doesn't happen 8 to 8. In terms of 988, early on, my daughter called 988, waited 45 minutes, and then hung up. So, you know, response time, I know it was early on, and we're still trying to get it out and everything, but I just feel like it's really important. And then there's a historical distrust among communities of color, concern about confidentiality and police involvement. And with both 988 and CCBHCs, there's concern about language access and the use of interpreters. I know from talking to 988 call center folks that are supervising calls that those call answerers are not trained in using the use of interpreters, at least in this center that I was talking to. We need to focus on how communities understand 988. I mean, in the general population, it's not really well known, and in the NHPI population, it's probably even less known. In part because we need stigma education, right? Because unless we can talk about it, no one's going to want to hear about 988, right? No one's going to want to even know about 988. And we need to have cultural humility and implicit bias training in both these contexts. And I really believe that the community-based innovation and interventions need to come from the community. You know, that they shouldn't be coming necessarily from government agencies necessarily, but maybe in partnership with communities. And we need to make sure that, you know, that, I guess the question is, why do we need to fit into the models of the dominant culture rather than really assessing and meeting the needs of our communities from our communities? So I feel like, you know, we really need to pay attention to that, and that's what NHPI has done for years. So just a little plug. Thank you.
Thank you so much, Pata. And I think one of the things we really heard is we're thinking about, at least for these two models and then the larger behavioral health system, around how do we sort of lean into flexibility to really support the needs of the different communities, recognize that one model does not fit all or many or even a few, and so you have to have sort of unique approaches, and in particular, given the communities that we're talking about today. So up next, I'm going to invite Beverly Coleman to introduce herself. And actually, do you mind grabbing John's?
We'll make sure this, okay, there we go. And I apologize, I put notes, so I'll be looking up and down because I want to make sure I'm on point with the 5 minutes we have. Half a day, everyone. Hello, my name is Beverly Marie Chargaloff Coleman. I am the one who has come all the way from the other side of the world in a different time zone. I am from Guam. Shout out to James Areola. He's my island brother from the Northern Mariana Islands, so we know about that flight. I'm sorry to say I'm not from California, but I was born there, so there's that. And so I represent a nonprofit organization, West Care Pacific Islands. We are part of a national nonprofit organization, West Care, and so we are all over the United States. I am the clinical program director for our youth trauma treatment program in Guam, and so we provide mental health services to the youth who are 11 to 17 in our island community, but also in our military community. In case some of you guys don't know, America loves us because we are a strategic location. And so we do have the Navy, the Air Force, and recently we do have the Marines there. So we are a resource for both of those communities. I will say that if we are not one of the few, we may be the only nonprofit organization that provides youth mental health services at no cost to the families. So I really like the conversation that's going on about Medicaid and that kind of coverage, because other than that, there's only really our state mental health agency, which is Guam Behavioral Health and Wellness Center, or the school-based behavioral health programs. Otherwise, families have the option to go through a private provider. So we are that added resource, and I really want to thank SAMHSA for awarding us the NCTSI grant, because without that, we wouldn't be able to do what we do, and we are so limited. And so looking at innovations like 988 and how it can reach AA and NHPI communities, more specifically in Guam, one major approach that has worked for us, and a little bit about our infrastructure, is we are very isolated, we are very remote, we can't exactly go to the next county, we can't go to the next state when we are lacking resources. So we can't work exclusively of our government agencies. So we operate on a very collaborative approach and a very in partnership. But that also speaks to our culture, as it does for the AA and NHPI communities. That's really what we thrive off of. And so that's how we work, and that's how we make these resources accessible to our community in Guam. So we do have to partner with these agencies. We have to work with each other because there's nobody else to look to. And so we operate and are most effective when we work together with our community. And so when Guam Behavioral did this rollout for 988, I feel it only strengthened our partnership. West Care Pacific Islands acted as a bridge between the families and our mental health agency to increase the comfort level and likelihood that families would access 988. Because as mentioned before, if they don't know about it, they're not gonna do it. You can do all the awareness, you can do all the websites, you can do all the ads, but unless it's word of mouth, or unless you go into these communities and say, hey, this is what's gonna work for you, this will help you, and I will walk you through it and do a warm handoff, it's not even an option really for them to look at. And so when we have clients in our offices who are going through crisis, it's allowed us as providers to call 988 and have them actually talk to somebody on the other side. Many families don't have great experiences going to their mental health agency, and some of them don't want to go. But we are not a crisis response program, and so our only program, the only agency we can refer to is Guam Behavioral Health and Wellness Center. And so we have to make them go. And so how we do that is we act as that linkage. And that has definitely worked. And I think knowing that we have 988 just to call up and have them talk to the families, that's really where the work starts, you have to talk to them and get them to go there, and not just say, hey, we got these great services. Come to us if you need it, or if you're in crisis, or if you're struggling with mental health, call 988. They need you to sit and talk to them and make it comfortable and make them feel safe to do that. I'm sorry, and my phone just locked. 1 second. It eases the anxiety of getting the help they need. This wouldn't be as smooth, though, if we didn't already have that connection and partnership with these agencies and other organizations in our community. So Inafat Malik, or Creating Harmony, is really done through this collective effort. And it's been an advantage of being such a small network. So I think because we're a small island, it's easier for us to be like, hey, let's call, James over at this place. Let's call Mary over at this program because I know they do this. And so because we have that partnership, it really helps to reach out and have it be more accessible. I think the next steps with the introductions of new or additional resources is more about raising that awareness amongst our smaller island communities. Our Pacific Island, yes, it's very general, but there are many of us, and we are not all the same as Pacific Islanders. And so I think reaching out and understanding who we're serving is really important. So we just have to know who we're serving, and I want to thank you guys so much for allowing me to share, and I look forward to further discussion in today's session. So thank you, and si Juas Maasi.
Thank you so much, Beverly. So I think two themes I heard come just out of your brief 5 minutes was sort of the power of partnerships that you've been able to leverage, and having those partnerships in place allowed you to then take even more advantage of things like 988 or other sort of opportunities or programs coming on board. So I think that and I think you're talking about lateral partnerships, but that also is implicated if we're thinking about federal partnerships with community organizations, et cetera. So I think that concept of partnerships broadly is really important. And then you also talked a little bit about, and I don't know if this is the right link, but like trusted gatekeepers, and how there are people who are trusted in a community, and it's only through those people that you're going to see sort of behavior change or uptake of different sort of systems of care. So I think those are two really important things to think about as we continue through our conversation today. Okay, I'm going to turn it over to John Palmieri now.
Thank you. So I'm John Palmieri. I'm the Deputy Director for the 988 and Behavioral Health Crisis Coordinating Office at SAMHSA. And I want to acknowledge Guam. They've done an amazing job implementing 988. They've been fantastic partners, so thank you for that. And so I just wanted to make a few remarks thinking about the 1-year anniversary, which we've all been reflecting on with respect to 988, which all of you know transitioned in July of 2022. And 3 words basically come to me when I think about this transition, and so I'm just going to comment a little bit on those 3 words. Not that they're the only 3 words, but they're 3 that I think resonate for me at this moment in time. And one is opportunity. So 988 truly represents an opportunity to change the way we view behavioral health crisis care in this country. And it has lifted up the dialogue in a way that for many of us who've been in this field for a long time have never, ever seen. And it's also resulted in unprecedented resources and investment in a system of care that for a long time has been under-resourced, has been fragmented, and where people have suffered in silence, really, because they haven't received the services and haven't had the voice to be able to identify their needs. And so for me, this opportunity is a calling, is a responsibility for us at the federal level to lean into that opportunity to the degree that we can and maximize the partnerships to be able to deliver for people in this country who haven't had that voice or who haven't had the resources. So I'm very excited about that. I also just want to point out the second word, which is equity. So we know that even though there are these great opportunities, there's great investment, more people are getting connected to care, response times are going down, which is a good thing. They're not perfect, but we're moving in the right direction. But that's not working the same for everybody. It's not working equitably for everybody. Not everybody, even people in this room, not everybody knows about 988. And even when people do know about 988, not everybody's willing to use 988 because of that mistrust or because of stigma or because of concern what's going to happen when they call. And so there's a tremendous amount of work for us to be doing with partners around stigma, around awareness building, and around building trust in a brand that ultimately we want to be seen as a service for everybody, so that people see that this is a service for them as well. It's not just for a certain segment of the population, it's for everybody. And so that's critically important. And some of the ways that we are doing that currently is around some of our communications research. We're engaged with a number of partners to do some qualitative and quantitative focus groups, surveys, looking at populations that we know have been historically harmed or excluded from the conversation, who are facing inequities in suicide rates or inequities in access, to really understand from them what's going to make a difference in terms of the messaging, what's going to drive them to help-seeking behavior, what's going to help sort of break down some of the stigma and the barriers to care that they're experiencing, whether that's through trusted messengers, influencers, other communication channels, and so forth, to be able to then shape the messaging strategy so that people do start to feel like this 988 is a service that they can access and where they'll receive good care. And then the third piece is around experience, to make sure that everybody who engages with 988 has a personalized, trauma-informed, high-quality, culturally specific, culturally responsive experience with the trained crisis counselor. And that's a work in progress, obviously. And so we recognize that there's a tremendous amount of work to be done there, but we want to be able to expand the notion of what's accessible, what access is. We have done a lot of work, obviously, in expanding Spanish language access through call, chat, and text. We've expanded LGBTQI+ access. We are expanding access for people who are deaf and hard of hearing through American Sign Language, but we know that there are lots of people who speak other languages in this country. And while there are interpreter services that exist through the Lifeline, we want to make sure that that service is a high-quality experience and that people ultimately are connected locally and served by people who represent the population that they're serving. And so that part is critically important. It's been a huge strategy for us from the beginning with respect to 988 implementation is really trying to emphasize the local aspect of the service, because we think ultimately that people are going to be better served not by the federal government, but by their local communities, by community-based organizations, by faith leaders, and so forth. And so it's our priority to connect people to those partners for an optimal experience.
Can you hear me? Okay. Thanks so much, John. And so I think you made my facilitating job easy because you already boiled it down to those three core ideas. And when we open it up for kind of dialogue in the room, I think it'll be really helpful to have people share a little bit about what are ways that SAMHSA and the federal government can engage with communities and community-based organizations around those concepts of opportunity and really maximizing this kind of once-in-a-lifetime investment that we've seen. Equity and what you talked about around stigma and awareness and really that crucial piece around trust and building trust. And then the personalized experience, a really high quality experience that we want every person to have when they call 988. So thank you for that. So I'm going to move on to David DeVorney.
Hello? Oh, great. Thanks, Trina. I appreciate it. And thank you to everybody here. It's really amazing. I'm looking and people are still paying attention and looking at the stage in spite of hearing speakers for now several hours and right after lunch. So I feel like you all deserve some thanks for that. And I'm also really thankful to have the opportunity to talk a little bit about the Certified Community Behavioral Health Clinic program. My name is David DeVorney. I'm the director of the Division of Community Behavioral Health at SAMHSA in the Center for Mental Health Services. We house the CCBHC, or Certified Community Behavioral Health Clinic Initiative for SAMHSA, and I'm the lead for CCBHCs. We also house our integration portfolio, so the portfolio focused on the integration of primary and behavioral health care, our suicide prevention portfolio, as well as our portfolio of programs focused on adults with serious mental illness in the community. But today I'm here to talk about CCBHCs. I also want to thank, we had someone from a CCBHC talk with us earlier, Laura, I'm going to try to pronounce this correctly, Schwartzendruber. Thank you so much for your presentation earlier at the 11 o'clock panel and talking about the good work you're doing in Tarrant County. So thank you. 60 years ago, almost exactly 60 years ago, in 1963 in October, President Kennedy signed the last piece of legislation he would ever sign, which was the Mental Health Act. And that piece of legislation provided for the construction of 1,500 mental health centers across the country. And it really was one of the most salient signals of a change in our national policy, from a policy where we cared for people mostly in institutions to the idea that we could care for people in the community in an integrated fashion. And for the people who work on these issues and who work in this room, you know, that's a dream that has never been realized. We've struggled with a fragmented system for the last 60 years, and that's in spite of, I think, often the heroic efforts of people, people trying to seek care, people trying to deliver the best services they can in their communities, and then also, you know, state-level policymakers, people working at the local level to try and build systems. But the fact is that we have a fragmented financing and administrative system for behavioral health services in the United States. And that leads to fragmented services. And so I'm very proud to be able to work on the Certified Community Behavioral Health Clinic Initiative because I do think it represents one of our best chances to solve these fundamental problems with our system. So CCBHCs are designed to bring together a comprehensive array of services into one place and to create provider systems that are accountable for providing everything a person needs when they walk through that door. And importantly, CCBHCs have to meet a set of federal standards. Those federal standards outline that people have to receive a comprehensive range of services, including care for mental health and substance use, including care across the lifespan. And importantly, CCBHCs have to do that based on a local needs assessment. That's the first thing a CCBHC has to do in order to start becoming a CCBHC, is to complete a needs assessment. And that's really important for our conversations today, because that needs assessment needs to take into account not only the geographic distribution of where people need services, but also who is being served, including what communities they come from, whether that's from the NHPI communities or from other communities, and that those services need to be tailored to their needs. Importantly, the standards for CCBHCs also provide for increased access to services, including the requirement that CCBHCs serve anybody who comes through their door, regardless of their ability to pay or place of residence. CCBHCs can charge on a sliding scale, but if you can't afford services, that's not a reason for a CCBHC to turn you away. Importantly, I think also to note that applies to people who are underinsured as well, which is a huge problem in our communities. And so I want to highlight a couple of important parts of the CCBHC criteria. They have to have staffing and training that's focused on providing culturally responsive services. They have to provide access to services, including access to people in crisis. And I think an important aspect is, yes, they may have business hours when they're open, but they have to provide a mobile crisis response within 3 hours, 24/7, 365 days a year to meet people in crisis where they are in the community. They have to provide translation and interpretation services, and they also have to provide materials from the CCBHC in the languages of the communities they serve. They have to provide care coordination, including care coordination with a range of community organizations, including those that might serve specific populations inside those communities. CCBHCs are also responsible for providing a comprehensive range of services, including coordination with primary care, providing outpatient substance use and mental health services, providing intensive services with people with complex or more serious needs. And they also have to have quality improvement plans in place, including quality improvement plans that specifically focus on health disparities inside their communities. So I think you can see that this is a really important range of services that can be provided in the now more than 500 CCBHCs across the country. And I think they represent really our best opportunity to meet the goal that we've all had for 60 years, which is to build a system that really serves everybody. Thanks, everybody.
So thank you, David, and thanks for that sort of history lesson and reminder where a lot of the work that, like you said, that we all do every day sort of emanated from so long ago, and that we're still sort of chasing that dream of a truly community-based integrated behavioral health system. So again, kind of similar with John, it'll be really interesting to engage with individuals in the room to think a little bit more about what CCBHCs could mean or has meant or hasn't meant to you and your communities, and how we at the federal level can do more around serving the needs of the communities that you all serve. So our final panelist today, I'm going to turn it over to Nina Luck, who's going to speak more about her work with CCBHCs.
Hi, 大家好, ni hao, and half a day. That was 3 language, 2 different Chinese dialect. It's great to be here, and I did that is also to show the complexity when it comes to serving the Asian population. I myself came from Guam, born and raised in Guam, but now reside in California for the last 20 years. When coming to serving the Asian population, it has always been my dream to be able to do so, to bring information to the Asian population. But I believe we're in a different stage now. I'm coming representing from Chinatown Service Center. We're an FQHC, but most importantly, CCBHC. We were recognized back in May 2020 during the pandemic. So it was really a challenge where we really had to pivot how we've been providing behavioral health service. When this opportunity came about, it was, to me, I saw it as when did this started? How come I didn't know about it? We've been providing most of these core service, part of the requirement for the longest time. And now that we're recognized, I really appreciate SAMHSA and this opportunity for us to be able to provide these behavioral health service to the Asian community. Mainly, we've been serving the East Asian population. And we're able to expand to bring on more service provider, expand our intensive case management service, our psychiatric care, and most importantly, resources to the community, translated in different language, and being able to provide events and situation to disseminate these resources. It's also how we were able to respond to the unfortunate event in January 21st, the Monterey Park shooting, one of the largest, worst tragedy in LA County. Since that day, we also worked along with many Asian organizations, which many of you are also here today. Marin from PAGS and Manju, AAPI Equity Alliance, and Deborah from Tsuji. So I'm also pointing that out because alliance and working together with other Asian organizations is really important when it comes to serving the Asian population. Despite wherever geographic location you're in, working with familiar faces, that's how our client comes through our door. When I come in here, walking in here, seeing all your familiar faces, we might not know each other, but because we're all from the same ethnicity, that's how it brings us together, and that's how it helps us to communicate and wanting to talk to each other. And it's the same vice versa when it comes to serving our patient. When they're able to relate to us culturally and language, being able to provide these to be able to relate, it's a lesson, it's a less of a barrier for them to access behavioral health. Of course, with the pandemic, mental health has been more aware. More Asians are now aware. I feel like we moved the needle a little bit. It's not as much as making Asian population being aware of mental health, but then increasing access and being receptive to access. How do you help the Asian population to be more receptive to receiving mental health service now? And that's where creativity has always been part of the job as we provide service to this population. EBP, what other EBP are there? We tailor all these EBP that are being researched, but not so much being focused on the tested or researched on our population. So we always use those model and make creativities out of it. Of course, there's also being more, how can we be more effective with the evidence-based practice and treatment that are out there right now, but also creativities of working with the youth population. We're working on providing parent-child relationship workshop, I should say, going out to different schools and being able to have workshop sessions where the parent and the child could help to relate to each other. One of the example would be that I really like to use, we switch role. We have the child be the parent and the parent be blindfolded as they work on building a house using tools such as index card and pipeline or straws. Why the parents' eyes are blindfolded is it's a representation of how children's minds are pure. They're learning through the process, but the child is now the parent navigating, helping. My clock is chiming. But pretty much it's practicing. One of the goal, I think, the key point here is learning by doing, helping the community learn by doing, bringing workshop such as journaling, art, or terrarium, helping them practice to realize these are connected to mental health, so that they're able to practice it due to the workforce. So that's the only way, like workshop and activity, bringing everyone together, that's the only way to really provide more awareness and being receptive to mental health service. 5 minutes went by faster than I expected.
It always does. It's amazing that way. Thank you so much, Nina. So a couple of the things I'll just highlight from what you talked about was, again, I think we're hearing a little bit of a theme is sort of the power of partnerships and collaborating with other organizations in your community towards the end benefit of serving sort of the NHPI individuals that you're serving. And then one thing you said at the very top, which I've heard sort of in some of the other sessions today, is that how come we didn't know about this opportunity before? And I think that happens a lot with particularly federal resources that they're out there, they're floating around, and different organizations don't even know that those funding opportunities exist. And then once they exist, then getting them is a whole other hurdle. But even recognizing or knowing that these sorts of things are out there, I think is really important for, particularly for our community-based organization. I know the National Network to Eliminate Disparities has been, over the past 15 years, really trying to create a better connection between an information flow, I should say. So I think we have a couple questions. Okay, the clicker has been lost. So I think we're gonna open it up now while we're getting a backup clicker set up. Folks, we really wanna have an opportunity to engage and hear a little bit about some of your thoughts and reactions around particularly thinking about how CBOs can take advantage of innovations, two of which we've talked about today. I do ask that you keep your comments brief so that we can get through as many people as possible and get a real diversity of ideas out today, and then we'll be moving into the fancy exercise with our cell phones. So did we? Oh, okay. Look at Pata. Thank you. So if technology fails, we always have paper and pencil. So the three questions that, and again, people can respond or move outside of these three questions, but just to remind folks, to address specific mental health and crisis response needs, what innovations are AA, NH, and PI communities using? What is needed for existing crisis services in order to effectively reach these communities in ways that both close access and gaps in equity? And then the third element that we're hoping to talk about is what capacity building is necessary to support a person or a community in crisis. So the questions are still not on the board, but we'll, if folks can start putting their hands up, and we have some mic runners who will start moving around. Okay, we have a person. And if you don't mind just introducing yourself quickly and then sharing your comment or question.
Hi, everyone. Can you hear me? Yes. Hi, my name is Hong Liu. I'm Executive Director of the Midwest Asian Health Association from Chicago. We are located in South Chinatown of Chicago, and the Midwest Asian Health Association, we say MAHA, is the only mental health licensed clinic in South Chinatown, south side of Chicago. And we are also the only substance abuse clinical licensed for substance abuse treatment in Chinatown Asian community, also for gambling addiction program. So I have two points that I like to present. Regarding innovative strategy, everybody knows that the stigma regarding mental health treatment is really a big issue. So we try to develop a different model to attract the people to get our services. One of the big challenges is that people don't want to come to the mental health clinic to get service, because when they see there's a mental health sign, and then they feel that they don't want to be the mental health patients. So the way we do is that we develop a program, stress release massage free event. So then we get people not come to the mental health clinic, but we use a different name, say come for a free stress release and massage event. And then people come, and then we identify patients through the process, and we give people stress release skill and massage. And then during the process, we discuss, we have a mental health counselor there to ask some questions to identify their issues and then provide counseling there. And they are willing to come back, because they come back not as a mental health patient, but as a patient come for some stress release. So that's what we get some patients to our mental health clinic. That's one of the strategy. Regarding the capacity building, one of the big challenge is the shortage of bilingual mental health counselor. And because of the, we are serving patients, a lot of them don't speak English, so we have to hire Chinese-speaking mental health counselors, but a lot of them are international students, and after they graduate, they have 1 year OPT. But after 1 year OPT, they have to go through the lottery process to get H1 visa application. And every year we sponsor those students, but a lot of them fail to get lottery, and we have to let them go. So I feel that if SAMHSA administration can really advocate for the special exemption for mental health counselors, especially bilingual mental health counselors from international students to stay here to serve the population, because that's we are losing every year, losing those well-trained, well-qualified mental health counselors who can serve our population because they speak the language, but they have to leave the country because of the visa issue. So if the administration can have some exemption for the lottery requirement, and or even extend their OPT for 2 or 3 years, that will really help with the workforce development for bilingual mental health professional. So that will be a huge help for our community-based clinic to solve the shortage of bilingual mental health counselors. Thank you.
Can I?
So we heard about sort of innovations around addressing stigma and using, I think, stress release massage. I think that would appeal to many people and get them into a mental health clinic. So, and then I think we also heard a little bit about the issue with the international students earlier today. A guest spoke about that and the kind of overall challenges around having bilingual providers. So thank you for that. Do we have another? Oh, go ahead, please. And if you don't mind introducing yourself.
Hello. Hawaiian and Tiro, my name is James Ariola. I'm from the Commonwealth of the Northern Marianas Islands, but I represent the Pacific Behavioral Health Collaborating Council, which is made up of the Pacific Island group that there's not many of us here, from American Samoa, from Guam, the CNMI, from the Federated States of Micronesia, from the Republic of the Marshall Islands, and the Republic of Palau. And I just wanted to share that as we're talking about embracing this, it's hard for us to speak alone. Usually we do it as a group. So I thank you for hearing, but I know there's not, in the interest of time, I just wanted to throw so that it's on the record on behalf of our people on the Pacific that the embracing new solutions is something that we're very interested in the islands, because for many years we thought we had to help our people understand that if it's coming from the States, it's better. If it's coming from somewhere else, it's better. But we now know that just as much as the United States has to offer us, we can offer the United States beautiful and innovative ways of life, of knowing of everything, mental health. And like even with the 988, we took this, what a wonderful opportunity. Great. But when we get to the table to talk about the conversation was how can we make this more applicable to you? The questions are, Where are you? Who are you? Are you in the United States? You know, these kind of things. And so I'm so happy on behalf of our islands to see that there's a lot of opportunity to grow mental health in nice and innovative ways. The issue is, as you know, in the Pacific, we're part of the United States, not because the United States is interested in our wellness and our mental health, but because of our defense strategic place, how we're strategically located. And because of this is one of the greatest impacts that impacts our substance use and mental health issues throughout the Pacific. And so I like to say that as we look at the unique embracing new solutions that we have with our faith communities, with our culture, our traditional healers, with our state systems that are growing in different ways, get to know a little bit more about our islands. And as we continue to learn about what's happening in your communities as well, we can support each other so that we can create more culturally sustainable ways of indigenous ways of knowing and learning that we know work that can be brought to create a health in our communities for our people and for our families. Thank you.
So much. So as we're getting ready for our next question, I just want to lift up, I think one of the things you talked about really eloquently is that it's not the federal government coming with all the solutions, and it's really it is incumbent upon us to look at what are sort of innovations that are happening in communities and how do we lift those up and spread those out. And I think again that was one of the sort of base things around creating the national network to eliminate disparities, is that there are these sort of pockets of excellence of work that's happening, and how do we sort of connect those pockets with each other and then up to the federal government as well. So I think maybe we have time for one more question, Rochelle. Oh, two more questions. Okay, great. Please go ahead, and if you don't mind introducing yourself.
Sure. Is this on? Okay. And I'll try to be brief for the next person. My name is Kelsey Okamura. I'm with the Baker Center for Children and Families. We're part of the Harvard Medical Network. I'm an implementation researcher. So a lot of my work is based in Hawaii. So I got to travel here with a lot of our partners. And so I wanted to make a quick plug, especially as we think about innovation for the growing field of implementation science and how community organizations can partner with researchers and make meaningful relationships and build community programs together. One such effort that our Baker Center works on is building kind of organizational capacity through being kind of a leading purveyor in different types of treatments. We're recognizing on the ground that we need a lot of cultural adaptations for different populations, and so we're using some of our existing funds in order to make those adaptations and hopefully testing that in the future. The other thing that gets us really excited in the dissemination and implementation science field, and I serve as the leader of our ABCT, which is the Association for Behavioral and Cognitive Therapies Special Interest Group. We're an interdisciplinary team of 400 members, and we're really looking at equitable methods. And this is really kind of acknowledging the power that sometimes researchers have in developing and implementing things in the community, and trying to best address contexts and voices and elevating and harnessing voices throughout the co-design process. One such effort that's related to work that we've been doing in rural Hawaii around building culturally grounded prevention curriculum, it's called Ho'onopono, is to understand from various implementers kind of their perspectives on how the intervention is working for them. We often recognize that we all have good intentions of getting innovations into the community, but it really hinges on the person actually delivering the intervention and the organization and the ecology supporting that person. And so, some of the things that we're learning is that there's disparities in terms of, how implementers are viewing particular innovations, whereas leadership is seeing it as something really exciting, and the teachers that we're asking to develop and implement the curriculum are saying it's overly burdensome. And so it's really important, and what I really liked from one of our recent papers, one of the teachers mentioned that this method that we use, in implementation science allows space for voice and all of our voices. So we get to hear from a number of different people that we wouldn't necessarily hear from. And related to that, just wanted to make a quick shout out to our implementation research division team. We're comprised of all kind of ethnic minority and indigenous scholars, and that's another area that we're really passionate about is, building community capacity on the ground to do this work moving forward. Thanks.
Time for one more question, but again, we heard some themes about how can we do organizational capacity building and then sort of turning the inherent equity issues associated with like randomized control trials on its head a little bit to think about more equitable methods for evidence-based building. Does someone have a mic? I'm sorry.
Yes, sorry.
Oh, I'm sorry. Go
Yes,
ahead, please.
hi.
Yes.
My name is Mia Ives Rubley. I work for the Center for American Progress. I'm the director for the Disability Justice Initiative. We have been keeping an eye on the 988 program because we understand that its intention was to try and redivert a lot of the calls from 911 and particularly with the interactions with individuals with mental health disabilities and the police were often resulting in deadly interactions. Unfortunately, some of the outcomes that have come through 988 is that we've seen a significant uptick in individuals who are being involuntarily committed. We've seen about 81,000 individuals being involuntarily committed and are very concerned because that can actually deter people from wanting to actually seek help and seek treatment because it can cause trauma in itself. And we've found that through research that at times involuntary commitment can cause more trauma and harm than actual improvement of symptomology. So our concern is that individuals are being involuntarily committed at a too high rate. And then secondly, is that individuals, particularly in specific regions of the country, don't have enough access to community health care, and thus the calls are just being rediverted to 911 again, which sort of takes away from the whole point of the program. And I think it's really important and essential that we fully fund not only the 988 program to ensure that we have a true separation from 911 calls and 988 calls, and that people are informed if the 988 call center is connected with police, because particularly for Black and brown individuals and darker community members within our own community, having police called on them is not going to be the best avenue to ensuring that these individuals stay safe and get the treatment that they want and deserve. So I think it's really, I understand wanting to praise the 988 program, but there are significant concerns from the mental health community about the connection with policing, connection with 911 centers, particularly in communities that are low resourced, and then lastly is an involuntary commitment. Even though there's outlines to say when people should be involuntarily committed, oftentimes those are actually based on ableist, racist ideology that can actually harm our community even more. Thank you.
Thank you for that. So I think we're going straight into our next, the problem-solving session. You got it.
I just dropped my phone. All right. Thank you so much to our panelists. Really appreciate your perspectives and the resources that you shared with us today, and to Trina Dutta for her facilitation. Thank you. All right, so you all know the drill. There were some good ideas shared in terms of ways that we can make innovative programs available to our community. invite you to again share your thoughts. Please be as specific as you can around your thoughts and ideas for how to make this a little bit more accessible for our communities. While you're sharing your thoughts, I do have one announcement. So Commissioner, who just spoke, is missing her Washington, D.C. driver's license, and security said that they gave it to someone at registration by mistake. So if you all could look in your wallets, check to see if you have a Washington, D.C. license in there that is not yours. That would be very helpful. And if you do, you can come bring it to me. Thank you. We'll play some music for you while you're answering thoughts on the thought exchange. All right, I want to see more thoughts. We got 18. Come on, everyone. At least one thought from each one of you or multiple would be great. Want to make sure that we're collecting your actions and ideas related to innovative care. All right, folks, we're going to move on to rating. Thank you for sharing. We got 32 thoughts. And if you could now go into the rating portion, look at the other thoughts and ideas that folks have shared and rate on a scale of 1 to 5. which one would be most important? Rate those as a 5, and things that are less important, rate a little bit lower. All right, thank you everyone. I know we're getting towards the end of the day. I asked if we could have some dance music, but we can't. So anyway, we might need to dance to our own tune later on. All right, thank you for rating the top thoughts that are in this particular session. You can see up on the screen. So we have increased funding to support the continued training and employment of bilingual mental health professionals. And why? Because it's not enough to get NHPI communities to show up for services. We need a sustainable system of culturally competent community health workers. The next idea is to have more funding for language-specific 988 lines. So if 988 responders are not linguistically competent or culturally informed, biases may result in more inflicted trauma and involuntary commitment. So again, thank you for sharing your thoughts around what we need to be doing to make sure that the kinds of programs we're offering are more responsive to the community. All right. I'm going to ask you all to stand up if you speak at least one language. You know, I'm just trying to make it very inclusive. Stand up or raise your hand if you speak more than one language. Huh, there's a couple sitting back there that don't speak one language. Uh-oh. All right, thank you for standing. All right, if you speak just one language, you may sit down. All right, if you speak 2 languages, you may sit down. If you speak 3 languages, you may sit down. Ooh, whoa, all right. There's a little contest going on here. If you speak 4 languages, you may sit down. Oh, wait, okay. So, the 4 language speakers, stand back up. What languages do you speak? Do we have a mic by them? Do we have a mic? Can you share what languages you speak? You can just speak loudly. All right, congratulations, Tenley. And then we have another gentleman back there who speaks 4 languages. All right, thank you. And we got 2 more people who stood up with the 4 language. All right, languages you speak. Oh no. All right, congratulations. All right, and finally, what languages do you speak? Oh. Sorry, you got one person up here going. Okay, go ahead, Sudarshan. All right. Thank you. I'm just always so impressed. And finally, please share. All right. Thank you so much. Thank you for sharing your amazing skills at learning a lot of languages. Oh, one more person, please share. Finnish. All right. That is unusual. Thank you for sharing. I'm going to invite our panelists up here. Okay, Russian. We got Russian. All right, panelist number 2, come on up and you can share your language. All right. This is a very knowledgeable room with very talented people. All right, I came to the States when I was a toddler and stopped talking Tagalog. So I do not know how to speak Tagalog, and I speak English only, sorry. All right, so I'm actually facilitating this session. I'm gonna move. Well, I'm so excited to be able to watch you all experience this next panel of speakers. I'm so excited. This is such an important topic, and we've already been hearing about it from multiple people during the day, how important it is to have our community be able to speak in the language of their heart. And so I'm so glad to be able to have these panelists up here with us today. And so first, I'm going to turn it over to Annie Chung, who is the CEO of the Self-Help for the Elderly based in San Francisco.
各位，我個名叫鍾月娟，我係香港長大、出世同埋長大。大約1976年呢，我就移民嚟到美國。1978年呢，我就開始喺安老自助處做佢哋嘅社工，跟住咧就做職業訓練啦，同埋可負擔房屋。喺1981年呢，我就成為安老自助處嘅行政主任。各位，我睇一睇你哋，有啲多數好明白我頭先講乜，但係好多都可能唔知道我係咪未來呢10分鐘都係喺度講呢一個廣東話嚇，咁我不如請我一個朋友 Rebecca Kwan 嚟幫我手翻譯，好嘛 ？Rebecca， 你同我翻譯好唔好啊？
It seems to me all of you are a little bit confused, so Annie is going to invite me to help, and I'm going to translate from now on.
多謝你 ，Rebecca。好啦，有阿 Rebecca 幫手咧，咁我可以再講一講。咁我依家咧就想講俾大家聽關於安老自助處嘅。
So now I have the help from Rebecca, and I'm going to introduce myself again. First of all, I'm going to tell you a little bit about the self-help for elderly.
安老自助處咧係喺1966年開始嘅。當時咧，白宮咧就有一個聯邦嘅計劃，就係預備將所有喺美國好窮困嘅人咧，係將呢個窮困去取消嘅。咁係一個好緊要嘅聯邦計劃，所以1966年咧，安老自助處就開始咗啦。
Self-help started at 1966. That was a part of federal government initiative program to fight the poverty. So at that time, that is rather important programs.
咁我哋有啲乜嘢嘅服務咧？咁我哋初開始嘅時候咧，就係專係俾好多營養餐啲老人家嘅，因為安老自助處，所以我哋嘅服務嘅對象咧，冚唪唥都係長者。
So what kind of provisions that we can provide for people? What our service range widely, and mainly we are serving the seniors and helping them to have the senior meals.
但係咧，啲長者咧好 好多時咧都帶咗好多英文嘅信件俾我哋去翻譯。咁變咗整下咧，安老自在處就加咗好多唔同嘅服務啦，好似做社工同埋做呢個 case management 檔案嘅服務。
But then in many cases, the elderly come with a lot of the documents that in Chinese, and then we must be able to help them to translate those documents. And then so therefore we developed our service into helping them in social service and all other kind of services that they need.
咁有好多長者嚟到嘅時候咧係50幾歲，未到65歲嘅。咁佢哋做咗10年工，做餐館嘅工啦，但係咧就冇報到稅。咁佢做完呢10年工咧，去養老金度申請，嗰陣時申請呢個紅白藍卡啦，咁同埋話我可以退休啦，我有退休金啦咁。咁但係原來佢哋呢10年都冇報到稅，咁所以佢係一啲呢個幫助都攞唔到嘅。咁點咧？安老自在處就開始咗我哋個職業訓練嗰個服務啦。
So a lot of the senior came, and they have been working for a long time, such as in the restaurant, but they never been paid tax. And what are they going to do? So we have to provide the service to help them to how to fill out the forms and to claim the tax, and so that this kind of help was very essential for them.
So it's part of our mission 係我哋而家嘅宗旨，就係每一個長者都可以有一個去到佢哋65歲咧，可以申請呢個聯邦嘅保健啦，同埋可以領取佢嘅養老金嘅。咁跟住咧就有好多可負擔房屋嘅需要啦。咁所以陸續咧安老自在處都開始咗好多呢啲可負擔房屋嘅服務。
So after they work so long, and then they have to somehow getting the retirement Social Security, and that is very helpful for them. And on top of that, when they reach the age 65, and they needed to have housing help, and so we provide the help for them to help them to get the housing problem solved.
To sum up our all the work programs， 再講我哋點樣可以發展到做一個多元化嘅服務咧？咁我哋係要講到我要就嚟停啦嚇。咁我哋就係想多謝阿 Rebecca 同我哋翻譯嘅。
So, in essence, that we have to develop into multi-assets and aspects to help our poor seniors. And so today I'm sharing this much, and then Annie thank me to help interpret for you.
So thank you so much, Rebecca. Sure. So now I'm going to try to summarize what we intend to do here. So just imagine that your clients come to you for all sorts of services, right from nutrition to social services to employment, and they all come to you monolingual immigrant clients. So where you are, where you sit, whether you're government side or the community side, I think that when I thought back of my own history as Self-Help for the Elderly, most of the times we started the services because there's a need in our community. Based on self-determination, we have to meet the needs of whoever that come to us for help. Not because there's money, right, to start this specific program to address that need. We work with the community. We have interpreters program. We hire bilingual, bicultural staff. 99% of the self-help staff speak another language other than English. So you could directly really communicate, find out the issues, and then started the programs to meet the needs. Now, where language access is applied, San Francisco actually passed the Language Access Ordinance back in 2009 and amended it substantially in 2016. And now in San Francisco City and County, we provide 3 threshold language: English, Spanish, Cantonese, and Tagalog, Filipino language. And the very 4th one will be the Vietnamese. And our threshold is 10,000 LEPs in the community. So I hope that this language access ordinance will be discussed later by another speaker. will really help the community. I think that a lot, because if we are representing the AANPHI population, then there needs to be a very, very strong language component. And if your staff are also multicultural, they speak directly, not just the language, but understand the culture. And I think sometimes it makes a big difference. So in San Francisco, with this language access, we thought that maybe the services are very matured, and the tier 1 departments, which are the major departments like the police department, the district attorney's office, the health department, and HSA would all be pretty well equipped, right, with language access program. But that is not so. So every year, the mayor's office, civic engagement, did an audit of the LAO and find out there's still areas for improvement. I'm going to share with you an actual case so you understand how valuable or how important language access really is to our community. So there is this elderly that I think that he lived in the Tenderloin, and then one day he was just attacked. I think it was at the peak of the anti-Asian attacks. Now he's all kind of bloody and kind of disoriented, but he still made his way into one of the police stations in the neighborhood. But maybe it was late. There was no one at the station at that time that spoke his language. I think he speaks Mandarin. And what happened? So just an officer inside the glass, door, pointed to a phone on the wall, and keep pointing it, meaning that pick up the phone and get some language support online. Now, this poor senior is already afraid, right, hurt, and then wanted to talk to someone, particularly. He's brave enough to come to the police department to make a report. But because of the lack of a bilingual person in person at the police station, he couldn't handle any of those online interpretation. He slammed down the phone, and then he just left very, very frustrated and sad. Then later on, people say, you still need to make a report. And he shook his head and said, no, I don't want to do that anymore. So this is one example. Another example I'm going to share is a Half Moon Bay shooting, right? Similar to Nina, our previous speaker, at the Monterey Park. When Half Moon Bay shooting happened, 7 people died, and out of those 7 farm workers, 6 of them only speak Mandarin, and all the families are in China. There was really no one in the community that could cater to their needs. One is a Mexican, the rest are all Chinese. So Self-Help for the Elderly was brought in to do some emergency case management for these 6 victims. And I tell you, they were very, very traumatized. I think a lot of clinicians are here, and you know that when something happened like that, some had nightmares every night. We are now serving them for the past 6 months. But also, the pressing need is housing, food. Some quit from their job because they couldn't go back to the farms, and where do they go next? All of these come to mind, but in the community, like Half Moon Bay, which is about 30 miles outside of San Francisco, there's very, very little language and language support for Chinese monolingual. So we have to move them 3 times, from the farm to a hotel to an Airbnb, and now to some housing that the county is providing. But that's not enough, right? So just to share with you that all of the work that we do have to be in Mandarin and Cantonese to support these families. So with those 2 cases, I want to just end by saying stories like this happen every day in the work that we do every day. And what we need to do is to make a resolve to advocate for language access, cultural competence program. If you are government sector, go partner with a community-based organization who the community goes to already, and seek out, the partnership to serve our community better. So I'll stop there. Thank you very much.
Thank you, Annie. So I told you it would be a little different. I'm sure for a little bit, maybe those of you who do not speak Cantonese were wondering what was going on. And I think that is an experience that we want to highlight for you in terms of what it means for people who don't speak English as their first language experience on a daily basis. So thank you, Annie and Rebecca, for providing the interpretation. Okay, so next we're going to move on to Shaheen Sebastian, who is a program manager with the Patient Navigators program in Germantown, Maryland. We're also going to do something a little experiential here. We have about 10 minutes for us to experience what you want to share with us today.
So namaste everyone. Namaste in Hindi is I bow to the divinity in you. And when you say namaste back to me, you are saying I bow to the divinity in me. In Urdu, it is said, Assalamu alaikum, meaning, may peace be upon you. That is a greeting. In Russian, this is Здравствуйте, meaning, let you be healthy. Now, how do you translate hello? So our language is so rich with our culture. How do you translate? Who should translate? Who should interpret for you? Do you need, is there a need for medical interpreters in the US? Yes, there is a strong, because we are from everywhere, and we have languages of major diffusion, and we have languages of very little diffusion. But do these people need to be heard? Do they, should they also be getting the same level of service in a hospital when they arrive completely disoriented, frightened, scared? Should they also get the same right? Do they have a civil right? Yes, they do. There are many legal provisions from the US DHHS, from the Office of Minority Health. Everything rests also on the Civil Rights Act of 1964, Title VI. So that's just one introduction. I am Shaheen Sebastian. I have studied I'm a South Indian who was raised in North India. So I learned Hindi, but we spoke Malayalam at home. My dad also forced us to speak English at home because he said Hindi is not good enough. But I went to the Soviet Union to study. I saw the breakup of the USSR. I was very fluent in Russian. Came back. I was hired with the Russian embassy and the Ukrainian embassies. How ironic in today's world. And then when we arrived here, I saw an ad in the newspaper saying, do you have a knack for languages? And do you have good medical terminology? I said, yes, I do. And so I went and studied medical interpreting. Only in the USA did I realize what a rich superpower I had. I was multilingual and multicultural. And soon after I got finished studies, we moved to the Washington, D.C. area, and I was hired by the Patient Navigator program. I've been there for the last 16 years. I'm very, very proud of the work that we do. We have helped more than 4,500 patients who speak Mandarin, Korean, Vietnamese, Hindi, Urdu, Russian. Rebecca was part of my staff. And we have handled 82,000 calls. And we have done 27,000 medical interpretations. But medical interpretation, there is no standardization of the education. There's no standardization of training. You could be from anywhere, speaking any language, not having a clue about health or any medical terminology. You get a 40-hour intensive training and you can practice. It is a large, it rests on the medical interpreters and themselves only how much extra time they put towards learning specialized techniques, latest advances in medicine. If you want to be specialized in the adolescent and child section, or you want to be in the emergency room, it's all very specialized. And many people, even today, do not know what is the need of a medical interpreter. Is it cost beneficial to our service? What are the expectations from a medical interpreter? So just a word of caution here, you may all have interpreted for a family member, but it's unethical to have untrained people in the room. especially when you're using your children. And then there are power dynamics in the family. We have to be aware of all this. And it can lead to dangerous and medical errors, consequences, and/or lawsuits that have taken place. So not speaking the language of your healthcare team while dealing with an illness or a medical emergency can be alarming and completely disempowering. Miscommunication or incorrect information can lead to prolonged or worsened conditions, repeat visits to the emergency room, delay in recovery, and additional costs. Having a trained medical interpreter either in person, online, or on the phone gives voice, dignity, and self-determination regarding their healthcare to the patient and is critical to achieving overall good health outcomes. So now we are going to do a small demonstration of how to behave in a room where there is a medical interpreter. So we are going to have Annie be the provider and David the limited English speaking patient. We are breaking gender and racial stereotypes here. So this is, Rebecca will be the interpreter, and she's going to set the stage for the talk, the encounter.
Hi, doctor.
Oh, speak on the phone.
I have this. I don't speak. She doesn't need it. Oh, do you need it? No.
Only the interpreter has the voice right now.
For sure. Hi, doctor. This is patient David, and I am Rebecca, your interpreter, and I will be interpreting today for David. And please keep in mind, whatever you talk to David, all the issue will be confidential. And if things that you do not want to interpret, please do not say it.
Thank you, Rebecca. Ideally, the patient will be sitting here and the interpreter will be behind because there was not enough time to move around the chairs. And in case the patient needs privacy, the interpreter will be standing like this. While listening, you can hear voice travels, but they're giving privacy to the patient so that they can do it in a dignified manner. So there are different roles for a medical interpreter, not only being a conduit of expressing the meaning between the languages. If the interpreter sees that there is some miscommunication happenings, the interpreter steps in and clarifies the situation. If they see that there is some difference in cultural beliefs, clarifies on that. And if they see that there is discrimination happening, or there is some physical harm or some mental harm or even harm to dignity of the patient happening, they can step into the role of an advocate. This is not celebrated in hospitals. They do not want the interpreters to be advocates. They want you to get out of the hospital premises and do what advocacy you want over there. So the other thing is that medical interpreters have code of ethics and national standards of practice. Some of the code of ethics I would like to remind you are that the interpreter will be respectfully mindful of the cultural differences between the patients and the dominant culture. I will be impartial and won't allow my personal biases to affect the therapeutic process. I'll be a professional, I'll be on time, I'll be courteous, I'll be dressed appropriately, hopefully not in a color that I'm blending into, though we should blend into the environment. And I will maintain accuracy of the meaning, the tone, the register of the message, and I will invest time to be up to date in the latest methodologies, techniques relating to my specialty. So you saw that there was a triad. This triad is very important when the patient is an LEP patient. Without this, there won't be justice done. So I just wanted to talk about one case, 1 minute. There was a mental health situation with my patient. I had taken her to one of the largest vendors in Maryland, and the provider refused to speak with the patient if I was present in the room. She said, no, I don't like having anybody else but the patient in the room. And I was like, no, this can't be, this can't be. And I came out and I told her, no, this is a violation of your rights. I am going to complain. And in my syllabus, the only complaining office that I could complain to was the Office of the Civil Rights. So I wrote to them. There was a 1-year-long investigation, after which the vendor was forced to hire an LEP coordinator, give a cultural awareness training to its entire staff, have all those papers saying, if you speak a different language, point to your thing and we'll provide a free interpreter. Any entities that are receiving any federal fundings are obliged to bring a free interpreter for you. And they did that in 8 agencies in Maryland, and it was based on 1 complaint. Thank you.
Thank you so much. It's just amazing to hear about the stories, and thank you for the demonstration of appropriate ways and best strategies to engage with an interpreter. So we are now going to hear from another panelist. His name is Kota Takayama. He is with the community of the deaf and hard of hearing. Unfortunately, he could not be here today with us. He is in Japan, and so he recorded a video for us. So we are going to watch the first 3 minutes of the video, and then we're going to skip to the end to hear some of his recommendations. If you would like to watch the entire video, we will send a link to you afterwards. So we'll go ahead and queue up that video so that we can see his talk.
Good afternoon, everyone. My name is Koto Takayama, and this is my sign name. I really wish I could be there in person to have this presentation with you guys and have this discussion about the Asian Deaf American Hearing Behavioral Health Experience and their mental health services. But unfortunately, I was not able to. So a little bit about myself and who I am. So I'm a professor at Gallaudet University. That's a deaf and hard of hearing school where many students go to that are deaf and hard of hearing in Washington, D.C. So I was there as an undergrad, and I'm there for my master's and PhD program. And I've been working as a psychologist and clinical social worker in the deaf and hard of hearing community, working with children and adults. My specialties and trainings are trauma-informed, crisis management, health, and therapy. So my specific focuses are in disaster risk reduction. And in March 11th of 2011, Japan had an earthquake that was followed by a tsunami. And that's where I started leading and visiting and working in disaster reduction. And that's where my focus started becoming, how the deaf and hard of hearing were handling this and how to manage risk and reduce risk. So since the beginning of my PhD journey, I've also focused on mental health and how deaf people can improve their mental health and overall health. So my journey of who I am, as you can see, I am signing and I am not voicing. And I'm currently using ASL, and I am using an interpreter who is voicing for me. So how did my journey through life as a deaf person go? So I was born and raised in Japan, and both my parents were hearing, and I became deaf at the age of 3. I was mainstreamed because there was no deaf schools in my area. So I went to school with hearing children, and I grew up as a hard of hearing child, meaning I grew up lip reading and trying to speak. So at the age of 17, I met my first deaf person that was Japanese and realized what their sign language was. And I started realizing there was a deaf culture, and I really wanted to take that on. So that's when I basically started changing my identity to who I am now. I'm also a first-generation college grad student So all my family members typically finished high school, and then I was the first one to get my bachelor's and my master's degree. So now I identify as deaf as my first identity. But when I'm around my family, I become quote unquote hard of hearing. So it's more so much to show that intersectionality of I can be more than one thing. Just kind of how I go through my day process. There needs to be more research. So some practice recommendations that we have. So if you have any thoughts as well as my thoughts, maybe we can work together and kind of put these things into play. So many clinical psychologists, doctors, counselors don't have that experience of how to work with the deaf and hard of hearing population in general, to include even Asian people. You know, different languages, different cultures. And it could be tough for us, and maybe that makes things harder to diagnose. And even, like I said, culture is a huge difference for the deaf and hard of hearing, even inclusive of that, are deaf and hard of hearing Asian. So we found out that we need specialists that need to work, more professionals that need to work with the deaf and hard of hearing population, which do include Asian American. Maybe we need to build some partnerships with some of those agencies and have qualified interpreters. So again, qualified interpreters, and then those who work in the mental health field as well. So some future recommendations was outcome database in the behavioral health systems. It was hard to find some information. So some states might have a database of certain percentages, but there's no identifying information for those who are deaf and hard of hearing, and those with specific identifying factors to language, such as ASL, English, whatever language it's possible to be used. So maybe those are some outcomes that can be added on. Thank you for watching my presentation. I hope I started stirring some thoughts and giving you some recommendations to bring back to your states and possible programs that you can start building. And hopefully I identified for you the deaf and hard of hearing needs of Asian Americans and Asians all around. Thank you.
Thank you, Tenley. Thank you to Perry Chan for all the work that you did to work with Kota and get this video up and translated. So thank you. All right. I'm going to invite my panelists to kind of move back into your semicircle again.
This is very difficult with the sari.
Yes, it is difficult with a sari. Where did Annie go? Yeah, thank you. All right. So next we're going to hear from David Hyams, who is a supervisory policy advisor with the HHS Office of Civil Rights. And I just have to share that I was so excited when Shaheen shared her story about the experience that she had and what action she took, and that the Office of Civil Rights responded. So I'm so glad that you were able to share that, and we're looking forward to hearing from you, David.
Hello, good afternoon. We're almost there. Hang in there. My name is David Hyams. I've been with the Office for Civil Rights, which is just right upstairs on the 5th floor since 2017. I'm a supervisor in the office, and part of my portfolio is language access. We have regional offices all across the country, so wherever state you're from, there's probably an OCR office not too far away. Please visit our website for more information. There's tons of resources regarding language access, laws, and various helps that you could find on there, as well as a complaint portal, which works, by the way. Okay, so if you file a complaint based on perhaps alleged discrimination or something that doesn't seem quite right, our office will take a look at it and perhaps give you a call. I thought I'd share a little bit about not only what HHS is doing, but some stats that I just came across. You're probably familiar with this generally, but there's an article that just came out from KFF. It's a research article that was published on July 7th of this year. It's entitled Overview of Health Coverage and Care for Individuals with LEP, Limited English Proficiency. And I thought I'd just highlight a few of the things they note to underscore the importance of this area and to further underscore why we need to be having these conversations and continue to direct efforts in this direction. So they mentioned that over a fifth of individuals with LEP, or 22%, are Asian in the United States. And the top 5 languages spoken by people with LEP include Spanish at 63%, Chinese 7%, Vietnamese 3%, Arabic 2%, and Tagalog 2%. Or Tagalog, I said that wrong. Tagalog. There's which way? Tagalog. Okay, thank you. I speak English only. Also, while Hispanics make up the majority of people with LEP, Asian people have the highest share of individuals with LEP across racial and ethnic groups. Individuals with LEP are more likely to be uninsured than their English proficient counterparts. Individuals with LEP are more likely to have lower incomes and educational attainment levels. Just a couple more that were helpful. As of 2021, non-elderly individuals with LEP are more likely to be uninsured and more likely to be covered by Medicaid compared with English proficient individuals. And specifically in the healthcare space, which we've been discussing, beyond mere disparities in health coverage, people with LEP face other challenges and barriers to accessing high-quality health care. Studies have found that language barriers between providers and patients may result in decreased patient satisfaction with health care, lack of comprehension of healthcare information leading to increased adverse effects, reduced medication adherence, excessive ordering of medical tests by providers, higher rates of medical errors, and decreased primary care utilization. Patients with LEP have longer hospital stays and are at higher risk of surgical delays and readmissions. And they have, for Asian Americans specifically with LEP, language barriers are one of the most significant challenges to accessing care, particularly among older Asian Americans with LEP. So this is a great article. Look at it. It's up-to-date research with all kinds of cool graphics, so I commend it for your consideration. So this is an issue. What is your government, where are your tax dollars going to support addressing these issues? Title VI was mentioned earlier. Under Title VI, any recipient of federal financial aid who's providing programs and activities is obligated to not discriminating on the basis of national origin in the extension of those programs or activities. Courts have interpreted national origin to include limited English proficiency. So if you read Title VI and you don't see language, that's because it's not there. It's an interpretation of national origin. Now, various executive orders and guidances have further extrapolated where that's to be applied. In 2013, Health and Human Services issued a language access plan. It had not been updated in a decade. So this year, pursuant to an equity action plan, which we passed last April, as well as a memorandum from the Attorney General, we undertook updating that language access plan. So be on the lookout for discussions of an updated language access plan, hopefully by the end of the year. It is in draft mode and is being reviewed by the Department of Justice. Earlier this year, also pursuant to the Equity Action Plan, we issued an updated annual language access report reporting on progress that the department is making in addressing these various barriers to language access that exist, that we've detected. That's going to be an annual report that we provide to the secretary. Our first annual report was published, I believe, in May, and it has been translated into Spanish and simplified in traditional Chinese. You can find it on our website. So I have got a few more highlights. This administration has taken this issue very seriously, much more than previous administrations have. We reconstituted and reset up our Language Access Steering Committee back in October. As a matter of fact, just a few minutes ago, we had our quarterly meeting. The steering committee is comprised of representatives from 25 op divs and staff divs within the department. So we have various subcommittees that meet on a regular basis, and we're figuring out how to do this better as a department. So we have very engaged steering committee. It's a joy to meet with them, and some of you in the audience might actually have been a part of some of our working groups. We are also in the process of hiring a language access coordinator for the department. So this coordinator will oversee the centralization of language access efforts within HHS. So with 25 or 26 op divs and staff divs and 90,000 employees, things can get siloed, they can be redundant, we can be very inefficient, as you might imagine a federal bureaucracy could be. But we want to improve in that way, so the new language access coordinator, whom we're hoping to hire this year, will help to set up a centralized language access unit for the entire department. Also, we are updating our Section 1557 of the ACA, Affordable Care Act, this year. Hopefully we'll be publishing the final rule by year's end. There's extensive language access provisions. The NPRM, or the National Notice of Proposed Rulemaking, was published last August. You had a chance to comment. Some of you might have commented on it. Thank you if so. And we are hard at work making sure that the language access provisions in the rule actually address the issues that you might be facing on a daily basis. And the last thing I wanted to bring your attention to as far as resources go to our website, and we've posted various language access resources, but the Medicaid unwinding letter that we issued earlier in the year with CMS is on there, and it advises states regarding their obligations to continue to provide reasonable access to language access services, as well as effective communications under the Disability Act. On the last page of that letter, we have a list of best practices to be mindful of when seeking to provide language access. So hopefully that's helpful. The Department of Justice also has lep.gov that has a lot of resources on it as well as you're considering these issues. And our complaint portal, if you need to file, is ocrportal.hhs.gov, ocrportal.hhs.gov.
It works.
It works.
Thank you, David. Thank you. If we could give a round of applause to our panelists. Thank you so much for all that you shared and all the resources that you offered. So we're going to follow our same format and have a question and discussion with those of you in the audience. So our question this time is very simple. What is needed for effective language access in your communities? Oh my gosh, the hands all go up. All right, where are my run? Oh, there we go. We'll start here with Myron.
Hey, good afternoon, everyone. Myron Kwong from Pacific Asian Counseling Services. I know people keep on name dropping me. You know, many of us have been working on this for a few years, some for decades. And I think what we really need is effective local implementation and enforcement. Even now, 2023, through my current job, we have been helping a woman, a client's been with us for over a year, and during the July 4th holidays, as an Asian immigrant woman who was visiting her pediatrician, because she did not have an interpreter, DCFS got involved and her kid was grabbed at the hospital on July 4th. And again, even during her trying to attempt to retrieve her 1.5-year-old infant, still couldn't do it. She came back the next day with an interpreter, one of my colleagues, And they said, oh no, DCFS has detained your child. There's been, there's allegations of neglect and what have you. And so here we are now. I'm at the summit, yay. But it's been several weeks, and she is only seeing her child, 3 times a week if we're lucky. And I'm absolutely 100% sure, as a civil rights advocate, as the ED of PACS, that were language access truly enforced with doctors, with the DCFS people, with everyone, if they just said, you know what, we don't speak her language, she might be nodding her head a lot and seeming to understand what's happening, but she doesn't. And again, I know this is not special. It doesn't matter if you're Pacific Islander, if you're Native Hawaiian, if you are Spanish speaking, this happens all the time. And this is sort of what I cannot believe is still happening after all these years. So what we need is just real, true enforcement, real implementation, and real ways of ensuring that law enforcement, all these other players cannot do this to young families. Thank you.
Thank you for your comments. Sorry, I'm not seeing our, can we come over here to Nellie? Sorry, and then who else was, I just want to get a scan of the room. Okay, thank you.
Hi, thank you. Nellie Tran, I'm a professor of counseling and school psychology and ED of our training clinic. And I think this is such an important conversation, but I also feel like there's a missing voice here of students and those that I'm training who, and related to our first conversation when we started at the start of the day, it's racism and colonization that caused our people to lose their language and their culture. And so if we are to create equitable access to training and service provider training as well as for our clients, then we must give them the opportunity to reclaim, relearn their language and culture, and many of us have the ability to do that, but are so grossly underpaid in higher education, and the work is so much harder, and the clients come, but our students need in-language training by those of us who can speak the language, and we need culturally congruent care. And as I said earlier, the American Psychological Association has apologized for their training being racist, and it has not changed yet. So before we put people into places to offer the care, we need to go all the way back to the training. So I hope that we can get our students loan forgiveness, because after 20 years, I finally had my loans forgiven.
Woohoo, thank you. Okay, so we have a question back, or a comment back there, then we'll go over here to the left.
So I would really love to see language access mandate in all the federal funds that go out to states and municipalities. I talked to Grace. She said that they tried to get it in Congress, but that they were not able to. Secondly, I serve as a human relations commissioner for St. Louis County, and for the last 3 to 4 years, I've been trying to get us to have a language access coordinator, and then I was told in our most recent commission meeting that we haven't put the job description out yet. We might do it later this year. We might do it next year. I actually instigated with Anna Pern a nationwide OCR complaint with HHS because of the lack of language access across the country, and Priscilla Huang at Health Law filed it. So I agree. It needs to be enforced at the local and at the state levels. And then those of us who are doing the work, I co-chair an ethnic communities opioid response. We are working in coalition with Hispanic, Black, African immigrant, Afghani refugee, Bosnian, Muslim communities. We can't get funding for the work that we are doing. Our city officials have apologized to us because they know that we are doing the work, and I would love to get sub-granted by some of these white-led organizations in Missouri. There is no sub-granting. They don't even acknowledge that this is what's happening, and the opioid deaths, the map in St. Louis City alone, the overlap with our LEP population is very significant. So I would invite y'all, we're launching our coalition August 1st. We'll have an online portal. We're partnered with the Addiction Policy Forum because kind of frankly, no one in state cares. And we will be having providers and Dr. Mati and other folks speaking from the community because we will not be silent anymore.
Thank you for sharing. Okay, I think we were going to that back table over there. and then up to Sudarshan, and then we'll go over here. Sorry, I'm just trying to get different voices into the room.
Hi everyone, my name is Subhadeep and I'm representing SAFA, South Asians for America. And one thing that I wanted to bring up about language access, one of my ideas is something that I've been discussing with a few people in this room about, is there's not enough casual social skills groups for young people. And I think one way we could also incorporate language into that is maybe you have one for each of the languages. So if you're from, say, India or like different countries, you can make it like different I'm thinking you can make different social groups so people from their cultural community could find people that they can relate to, and then we could work on this work all together and relate. So that's just an idea to incorporate both needs. One, a need for young people to have a space to express themselves, and second, a space for people from other cultures to try to advocate together to get some of the changes that we've been discussing all day today.
Thank you for sharing that idea.
Hi everyone, my name is Sudarshan. I am a former refugee from Bhutan. I've lived in refugee camp for 17 years, moved to the United States. I work with my own community in Columbus, Ohio. And part of my work is helping fellow refugees, but also I work with SAMHSA as a steering committee member and so many other boards and nonprofit organizations. And when it comes to language, I think what components are, it's very important that we include language in terms of providing services. But also through SAMHSA, SAMHSA has given me horn whenever I need it. The point is that we have been advocating about language and culturally appropriate services. Throughout today's discussion, what we missed greatly was the cultural components in the service. And I wanted to give one quick example. What happens is the hospitals and other mental health service providers, they very easily get along with the language components within the class standard, what we call the language and culturally appropriate services that the federal government mandates the providers to do it. And so the way they do is they can hire someone who can speak the language of the client, and then they do the translations, which is great, which is needed. But where I see the missing link in terms of mental health is the fact that if you are not screening the client on their lived experience, and if you are using the same tool but asking someone to translate, in the first place you miss the client in terms of screening what their mental health needs are. So if I am a refugee and if my mental health screening question does not ask me what type of life I had in a refugee camp, what happened to my family members when I was persecuted, those experiences are excluded. They don't screen me. So all refugees are screened for RHS 15, and in RHS 15 it's very sound. They don't identify many refugees, but within 2 months, refugees started experiencing mental health experiences because they don't ask the right questions there. And the other portion is the cultural components into the practice. If the interventions are not designed based on the cultural experiences of the client, however you may try, it's not going to work. And so as providers, as funders, what we have to understand is cultural component needs to be incorporated into the interventions that we do. And if HSS provides funding to larger community or organization mental health agencies, they need to make sure that they tie in the community organization into the service providing aspect. So what happens, I wanted to give one example. In Central Ohio, at the midst of the mental health crisis, in Bhutanese community, if you search or do research, we have one of the highest mental health and suicide rate, unfortunately, in the whole nation. And because we have been advocating about providing services, what happened was one of the local agency was provided funding to provide mental health services to Nepali-speaking Bhutanese refugee. We were not consulted for 3 years. And that fund goes from SAMHSA, and goes to local ADAM board. And ADAM board is the provider. And ADAM board does not have to care because we are not a political entity at the local level. And so this politics dynamics in the service providing is cutting off smaller organizations. What happens if you look deep, because I have been in this lens for 80 years in advocating and trying to understand, is that within those agencies, even those are agencies like Adam Board, there are political dynamics. And these political dynamics are based on the voting population. And if you are a refugee, if you are an immigrant, if you are not that significant populations, your voice often goes unheard. And so how does institutions like SAMHSA and Adam Board make sure that these political dynamics do not play into the mental health of these communities who are suffering? And I wanted to leave you all as advocates, as policymakers, and as providers with one short story. I don't want to take a lot of time. There is an elderly lady. I wanted to change their demographic and other name that you don't want to identify. Now, in terms of language concordian, how do we provide appropriate even language services? So what happens is this elderly lady, this is a fact story, in one of the major hospitals, she had a surgery on a given day. And she is taken to surgery, and then the person who is invited to do interpretation, he comes through video, okay? And then they are asked to provide in a standard language. Now, this elderly lady had to go through a surgery. Now, the right word to translate surgery in Nepali, standard Nepali, is, if you speak Hindi or other South Asian languages, Salya Kriya. It means surgery. But this elderly lady is never educated. She had never heard this word Salya Kriya. But the word Kriya only means, those who are from India, raise your hand, it means funeral. So she is about to go into a surgery, and then the interpreter said that you are ready and you are about to go for your funeral. She got so anxious that she just wake up, like stand up from the whatever the place that they were pushing her into. And because they could not proceed with what happens, they had to call in another person and try to understand what happens. So where does we miss? These are the things that we really have to think about when we talk about language and culture. But oftentimes what happens is for Title VI, the bigger institute get away with just having someone speak the language or hire someone, let's say a therapist, who speaks Nepali, in my case. But you hand your own tool. You don't train them how to work with refugees. And you force them to adopt to their CBT.
Thank you, Sudarshan. I'm sorry to cut you off. But the story that you told was so powerful. I mean, I think you really highlighted why we need to make sure that appropriate language interpretation is available. So thank you for sharing that. There was a woman in an orange shirt that had raised her hand earlier, and I was going to go to you next.
Thank you. I'll try and be as brief as possible. So I just wanted to share a bit about what my organization, the Asian Mental Health Collective, has been doing around language access. So we, among a couple of other things, we have the largest directory of Asian American and also Asian Canadian therapists. And so currently we have providers able to serve 47 states. And our providers speak 23 languages, including ASL, which I checked just now. And I think this is key because, often we're providing teletherapy services, which are a lot more accessible, but it's meeting our clients at a point where, there's someone who looks like them and there's someone who kind of comes with their language background. Then beyond that, we're doing work to support therapists to make sure that Asian therapists are staying in the profession and that there's a pipeline of supporting emerging therapists to kind of establish their practice to, really make cultural and linguistic access like a cornerstone of what we're doing. And then beyond that, we do some work we have a therapy fund, so we're making sure that our people can afford therapy, that they can we pay for their therapy. And then also we have a host of community events. Please check us out.
Thank you for sharing that important resource. I'm going to go to the back of the room because I know it's harder to see you back there. So I want to make sure we have opportunity to hear from you as well.
Thank you so much. I missed the part where I was going to mention that I speak 3 languages, but that didn't count because I entered the room when it was 4. My name is Naveen Koneru, and I represent the Art of Living Foundation. I have a quick comment and a question. The goal of our foundation is to help create a stress-free, violence-free society, and as our founder very simply puts it, to bring about a smile on every face on the planet. That is what we do. So far, we have a network of over 5,000 volunteers across the country, and we have impacted 750,000. So offering myself as a resource, if that'll help for any one of us in the room to be able to partner. But my question is, just like how I made my pitch, and our esteemed panelists are sitting on the stage, I figure there's several of us in the room who want to have a pocket of sharing. And I've noticed the sharing is usually happening at the end of the session during the Q&A, while the panelists are sort of waiting for questions, but all of us are doing our pitches. I wonder if it'll be useful to actually have one session, probably exclusively to share who we are and what we do, so that questions to the panelists could be more relevant and directed towards the discussion itself.
Thank you for that suggestion. It is a challenging process here. We do want to hear from as many people as possible. Unfortunately, we are kind of getting to the end of our session, and I would love to hear, I think that suggestion is great, and we should have that for our second summit that we have next time. So SAMHSA, WHIAANHPI, we need to have another summit and change the structure a little bit up. So thank you, though, for that comment, and I appreciate that. I think there was another question. Sorry, I see you have a ton of it. Let me go back to somebody who I don't think we've heard from yet. Have we heard from you yet? Okay. All right. We're going to go over here to the right. If you could introduce yourself and then share your comment or question.
Hi, my name is Rachita Singh. I'm from the American Association of People with Disabilities. So I just wanted to build on what Mia has said and what Kota has said, and emphasize the intersectionality between the AANHPI community and the disability community. And I think one way we can do that with language access is not only promoting language access for the deaf and hard of hearing, but in like their services, but also when doing promotional material for mental health services, having plain language material as well. So that individuals with intellectual disabilities and such can also be able to access these mental health services. And also, if there's a way to encourage people with disabilities to be mental health providers as well, that is something I would really love, because as a person with a disability, when I was trying to find a therapist, it was really hard. I really wanted a disabled therapist to like connect with, and I couldn't find one, unfortunately. And so finding a disabled Asian therapist was just like not possible. So like having those kinds of services, being not only in different languages, but also in plain language and easy read would be amazing.
Thank you for sharing. Okay. Let's go over here. Again, the question is, what is needed for effective language access in your community?
Hi, everyone. My name is Vanessa Chan. I'm a physician, and I'm representing today the Federation of Chinese American and Chinese Canadian Medical Societies, as well as my local regional organization based out of Oakland, California, the Chinese American Physicians Society. And I see a lot of familiar and friendly faces. I just wanted to comment, since we were talking about medical interpretation, just to give another kind of perspective as a provider, as a physician, that even in my time since training, 20 some years ago, I've gone from having to go, even in the hospital in Oakland, right, heavy Asian population, having to find my friend who's a nurse who I know speaks Cantonese that can translate for me, because my Cantonese is limited to ordering dim sum. I know more Spanish, so I currently work for La Clínica de la Raza, another FQHC. We still have limitations, even though now I can roll into the hospital room a video interpretation thing that can get me, 100 different languages. They can't get me mom speakers. I have to, again, call the person in our office, the 2 people in all of La Clínica de la Raza that speak mom, that are maybe there till 5 o'clock. So if it's after hours, I deliver babies. Doesn't always happen before 5 o'clock. So just kind of to comment to the OCR that it's another pipeline issue, right? We need to train interpreters. We need to train them well to do medical interpretation. It's very hard. I know enough Cantonese, Mandarin, and Spanish to know when someone is not interpreting correctly, medically. And so I think, again, that's another pipeline issue, to train people, to get even physicians, but also just interpreters, medical interpreters that can do that effectively. The last thing I wanted to say is, for physicians, we now have a lot of ability to get, online, telephone interpreters easily in our larger clinics. Smaller private practices don't have that ability. Well, there's a cost. So private practice physicians, I hear that a lot. It can cost $200 an hour to get an interpreter. And we want to do it, but obviously a PCP, you're getting maybe $20 for that visit. So it makes it very hard. So that's my comments.
Thank you for sharing. Thank you for sharing. Okay, Vatana, I'm ending on you, and then we're going to go into our thought exchange.
Thank you so much. Appreciate it. I think after listening to everybody, it's so motivating to continue the work we do to advance language access. What is needed for effective language access to me here is language justice, right? What do I mean by language justice? One is building the people power. We are speaking on our community. Why don't we build the leadership and advocacy skill of our community members to speak for themselves, to advocate for language access? We have seen a lot of our elders who are not able to access the language line during COVID-19 for, just simply making an appointment, right? And we have seen that issue that some county, there are only 5 threshold languages. Your population doesn't make a cut. You have 9,000, you have to make a 10,000. Just 1,000 people different, people could not access that, right? We have to build, what we did, we organized those elders, train them leadership and advocacy skill, bring them to city council meeting, bring them to county board supervisor meeting. They have 3 minutes in front of them, they got nervous. We said, we got you behind your back, we got you, speak it. They need language. What county did? Eventually they contact back, no worry about threshold anymore. If your community need the language access, contact us. That's what we need, people power. We need to build the capacity, leadership skill of people impacted by the system themselves to advocate. With CBO, when the funding ends, we might go somewhere else, right? But the long-lasting impact is the capacity, leadership, and advocacy skill that lasts with the community. And last but not least, I really appreciate David about asking for the LEP plan, but the plan should not come just a report back to the Office of Right, that how many people they serve in different ethnicity. The important thing about the report is the cultural competency plan that allow people to have measurements and also the accountability. What I mean by measurement, people might just say, get the funding, I serve 200 Chinese, speaking community member, I serve 100 Cambodian speaking community member. But in reality, do they increase in terms of language access? Do they make a measurement? Do they put a goal of how many people they want to increase every single year around that? So measurement in that language access plan is so important, or we call cultural competency plan. Thank you.
Thank you, Vatana. Thank you so much. This is the challenge around language justice has been a theme. We've been hearing it from the very beginning, at the very beginning first session. And so it's a thread that is constantly kind of a challenge for our communities and also a strength. And so we want to get your last thoughts and ideas around what would be the most impactful or important strategy to explore in the next year. And again, this has come up so often. Perry was boasting that this was going to be the best panel. And so, one, I want to thank our panelists. Thank you again for the very experiential opportunity that you provided for us. So thank you again. I invite you to return to your seats so that you can participate in the thought exchange again. I expect to see a ton of ideas here because I know that you all have been talking about this, and this is so important to the NHPI community. So please take a moment to scan this code, offer your ideas, and please remember to put one idea, one thought per entry and why that is important. And we'll listen to some jazz music in the background. All right, thank you, thank you. We've got 40 thoughts in the thought exchange. If you want to move over to rating or finish up your last thought, please do. I want to make sure you see the thoughts of others. And again, remember, 5 for if you strongly agree with the action, and a lower star if not, you don't strongly agree. All right, I think we got a little stability here on the thought exchange. Thank you again for sharing your thoughts and ideas. We're close to the end, so stick with us here. So we have that funding for certified interpreter interpretation time must be covered. Medicaid currently does not cover this. The cost of support is nothing compared to the cost of inappropriate or lack of interpretation. Please have HHS, OCR, OMH, SAMHSA, and CMS jointly outline and crosswalk the reimbursement mechanisms for language services for the public. Way to be specific. Thank you. All right, I asked you for specific suggestions, and this is what we're getting, so this is great. Can we scroll down a few more, Corey? Okay. Language access is a right, not a privilege for healthcare. Denying language appropriate services to clients is just like denying disability services to a person who is disabled. All right. So please, again, continue to look at the thoughts that you are that have been entered by others in this room. We want you to benefit from the ideas of a diverse group that we have together. Please again note that we will be sharing these thoughts through a link with you so that you can see everyone's thoughts and you can continue to rate them, you can continue to add to them. So we want to hear more. And in fact, please send this with your networks. We want to hear from as many people as possible. We have 61 participants in this. I challenge you to send it out to at least 10 in your network or even more so that we can collectively get as many ideas that we can give back to WHIAANHPI and SAMHSA. So, we are at the end. Thank you all for sticking it out. Give yourselves a round of applause. We are going to get to hear from our two great leaders who are here with us today. We're going to hear again from Dr. Lark Wong. And so she'll go first, and then we'll hear from Crystal Kai afterwards. And then please stay. I have this poem that I want to read for you at the end of the day that I hope will give you a lot, will be a gift to you. So first we'll hear our closing remarks and recommendations. Thank you so much.
Okay, I'm just amazed that it is 4 o'clock and you all are still here. You know, it is over. So, the gentleman in the back who said he had some ideas about how we could redesign this. Yes, could you stand up? What was your name again? And you're from? Okay, so we're putting you on the planning group for the next follow-up meeting. Okay. Okay, well, we'll get you. In case it's been a long day, and in case you forgot who I was, sometimes at the end of the day I forget who I am. I'm Lark, and a lot of you got a lot of emails from me in the last couple of weeks. Before I do thank yous, I want to just kind of run down some of the things that I heard today. And as we hoped, you've given us an agenda to work on. Agenda not for us to work on alone, but with our other federal partners, with WHIAANHPI, with some of you. If you're willing to do it, we will certainly call you and ask if you want to be involved. We heard about the importance of partnerships and collaborations, and that's what we hope that this will also generate, not just with us. It's not just a dyadic this way, but we're hoping that you met other people that you would want to follow up with as well. So a couple of themes that jump out at me and through this day is that workforce issues are a primary issue here, and we need to think about, how do we get more bilingual, bicultural workforce, drawing from AA, NH, and PI populations to serve, particularly in those communities. We find that people who come from communities tend to serve in those communities. We don't export people in well into unknown communities. You heard a lot about pipelines and career pathways. It's interesting, we've been going to the term pathway as opposed to just pipeline, because some people don't like the terminology pipeline. And we'd like to hear from you, what are those pathways or what are those pipelines? we're having another meeting. We've been in process of planning for it specifically on workforce issues and behavioral health for underserved communities. So we want to know, what does that pipeline, what does that pathway look like from your perspective? We'd like you to help us build it, so we'll call on some of you who've said you're doing efforts around workforce to be part of that meeting, which we plan to have. Tanley, when are we having that? In October or November? But that is going to be also a the whole behavioral health workforce is really kind of in a crisis state. And it was really accelerated during COVID when we had a lot of people exiled out of the behavioral health careers. So in general, it's, people have said it's so bad it's like on life support. But if you then look at the workforce for underserved communities, it's even worse. So this is a big priority of Dr. Delphin Rittman, who you heard earlier, and of my office as well. So that's very consistent with what we have on our agenda to do. So we would like to partner with many of you as we think about, what can we do in terms of a workforce-related summit, and have really, where are our gaps, what are the strategies to build that pipeline. We heard a lot about children and adolescents issues. We did not have a session on that, but that kept popping up. And we know those that we're seeing suicide rates, suicide ideation rates among our population at higher levels than we've ever had. We know it's, as you heard, the primary cause of death for many of our young people. We are actually right now having, or earlier this week, had a policy academy with 6 or 7 states coming in to look at the issue of increased Black youth suicide. So it made me think, is this something we need to look at among the Asian American, Native Hawaiian, and Pacific Islander population of young people as well? So again, we'll look at those of you who are interested in that and see, is that a route that we should also consider? Interventions, there was a lot about interventions around clinical interventions and community interventions and organizational change type interventions. So we need to really better identify what they are. Some of you are doing incredible work, incredible innovative, creative innovations that really fit the cultures of the communities you're working with. We would like to know about those. When we put evidence-based practices in our notices of funding awards, notice of funding opportunities, we do have that thing about EBPs in there, but we also say, if there is an EBP that better suits this population you're serving, please present it and tell us the evidence you have on it. So we're not that rigid that you have to go draw from the evidence-based practices that have not necessarily been tested and trialed on our populations. And then we also see places where a combination of interventions are working as well. Maybe you need a more cultural intervention to engage, and then you can then go to CBT or something. But the idea of lifting up the community interventions and looking at what are those critical components is something that we're always listening for, always trying to do. That's in part what the NED was established for, to really learn what you all are doing in your CBOs, that we can elevate, that we can support in some way. And the whole idea is not just getting isolated episodes of these or isolated areas, but does it make sense to scale? And all the efficiencies that you get when you can start scaling things that you know work in certain communities. So that's another whole area that is work that we're doing and that we'd like to continue on, or support if you're doing it. How can we support you all doing that? It's not that we want to own or do all these things. We're very ready. We're actually very tired today too. So we're very ready to share. If you're doing something that you want to let us know about, and if there's some way we can partner or help resource it, please do let us know. That's what this meeting is all about, for us to really understand on a deeper level what's making a difference in the work that you're doing, and how can we get a multiplier effect on that by doing some kind of partnering. Emerging opportunities, the panel we had around 988 and CCBHCs, we didn't want to miss that boat. We often find that, and I've heard comments like, we don't get the money that you give to the states. It doesn't trickle down to us. We don't see that money. It doesn't come to our organizations. Well, we were trying to also give you a sense of what are the new delivery mechanisms coming out now, and that not only do you need to be at those tables, you need to help build those tables, and we need to know where you're getting stuck. And one of the things we've been trying to think about doing is how do states do their subcontracting and their procurements. As they get money, some of our money has to go out through states. If it were up to my office and some other leaders at SAMHSA, we would want it to go directly to communities. The money comes to us through Congress with certain restrictions attached to it. So we do want to know how can we get money to you, get funds to you for the innovative work you're doing if you're not getting funds as subrecipients or subcontractors or part of the procurement process in your states. So that's a big thing because that's a resource thing. So we need to have more discussions about that, and we're also going to start talking with more state leadership on how they're doing it and what are best practices around doing it, so that and when we've had conversations sometimes with state commissioners, they say yes, particularly with COVID, we realize we have a huge population of underserved people, and that was revealed by the COVID pandemic, but we don't know how to find them. We don't know how to reach them. So there's a lot of communication and a lot of connection that needs to be done there. Language access, you gave us some ideas, and I think the gentleman in the back is going to help plan the next meeting on this. So, and I do want to say that oftentimes people take language for granted, you know, and people would say to us, well, it's not a exciting topic, it's not a sexy topic, it's not the latest innovation, it's not the latest, you know, intervention of the month. But as you heard, there's a real science to doing it. There's a real systematic way to do it. And there's a real life, death, and quality and safety and health issues related to it. So I think, and now David just gave us his office number, so we can all go sit out in front of his office too and tell him, you know, we want this plan to look like this. But I think, you know, it's sometimes easier said than done. There's a lot of complaints, but there's also a limited amount of effort and resources that can go in follow-upping complaints, and whose complaints get investigated and followed through. There's a lot of complications around that, but I think an area that we really need to spend more time thinking about. And again, we thank Perry Chan for really not letting that get off the table in this meeting. So those are some of the things, and you've given us kind of a full agenda to think about, and we'll certainly take all your responses to the thought, what was it called again? The thought exchange, and I think it was like thought, huge mountains of thoughts, but we will look at that. I mean, we will look at the data on that, and as it helped guide us plan this meeting, it also will help give us an agenda for prioritizing what we want to bring to our Assistant Secretary in terms of where we want to put our efforts. And we really look forward to doing that with you here. Those of you who are interested, I should do Rochelle's thing, like stand if you want to keep playing with us, sit if you don't, you know. But anyway, those are just some of the things that I'm sure we have note takers all over the room, whether you realize it or not. You are being written down or recorded, not recorded, written down. We don't record in this federal building. So to close, I want to just give a couple of shout outs. It took a lot of time and effort to put this meeting together. And I do very much want to thank our partners at WHIAANHPI and Crystal and her staff. I want to thank Rochelle. Where is Rochelle? Rochelle, I think we need to applaud Rochelle. Somehow, Rochelle kept us on time. We were really thinking it was going to really be a crunch here. And she did it in a very gracious, respectful way, and we really, that's why we always have her come back. And we are at closing time, and she wants to do one more thing, so we're going to let her do that. I also really very much want to thank my staff, and I have my reading glasses on, so I can't find you. But I'm going to give them a shout out because they've just done tremendous. This has been on top of their regular scope of work. And Corey turned into a tech person. Corey's an incredible intern that we have now offered her a job. So Corey is going to be joining our staff as soon as she passes through security. So I hope you have. Okay, so she's going to be a full FTE fed. Okay. Perry, I don't know if Perry had to go and pick up his kids. Perry Chan and Victoria Chow, I think they may have left, but they've been just terrific staff as well. Julie Liu and Heather, Julie, and Heather might still be at the, oh, you're released from the registration desk. Thank you very much. Leah Jacobson, where is Leah? Leah, I appreciate every joke you cracked on every meeting we had, so thank you very much. Sunny Patel, where's Sunny? Sunny, are you in the room, Sunny? Thank you so much, and Sunny and Leah came on loan from us from the Center for Mental Health Services. So not only were they doing their regular work in their own center, they came and worked with us on this meeting as well. Thank you so much. Yellie's been quietly note-taking constantly. And then where's Tenley? Tenley, who makes sure I'm in the right place all the time. Thank you so much, Tenley. Did I miss anybody, Tenley? I think that's it, right? So anyway, thanks to all of you. And then, and don't forget, we all have cleanup assignment after this is over, okay? And most importantly to all of you, we are just really, you know, one of the descriptors of the movie I was mentioning when I started out this morning was heartfelt. Our really heartfelt thanks go out to you. You came, you participated, you gave us ideas, you gave us things we wanted to hear, things we didn't want to hear. You were appropriately antagonistic when you should be. You were appropriately respectful when we gave you lunch. You know, so we can't thank you enough. You represent the voices we really want to hear. We want to continue to work with you. We want you all to work in different clusters as well, and we'll be the players, you be the leaders, however you want to do it. We're in it for the long haul. But thank you so much for, on relatively short notice and getting your agendas like 3 days ago. Some people did email and say, where is this meeting that I committed to? We can't thank you enough. And we hope you'll continue to connect with us, and we would like that very much. We have a lot of work to do in a short period of time. We really think about what the Biden-Harris has given us is really the urgency of now, and so we want to get as much of this done and embedded before who knows how things change. So thank you very, very much, and I'm going to turn it over to Crystal now. Thank you.
Okay, well, thank you again, everyone. I just want to give a huge shout out to Lark. Let's give her another round of applause for her tremendous leadership. And, you know, again, we are so grateful to all of you. I am also surprised that the room is still packed. It's been a long day. I know some of us are operating off of very little sleep, but it's been really great to have all of you here with us today. Again, for those of you who are just tuning in, maybe virtually, I'm Crystal Ka'ai. I'm the Executive Director of the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders, or what we call WHIAANHPI. And, you know, when we, and I really want to thank again our commissioners, our President's Advisory Commission. This summit came as an idea, a recommendation from the commission to the president, and we were so grateful that shortly after the commission submitted their recommendation to the president, we did get the green light from both the White House as well as from HHS, and you heard from Secretary Becerra earlier this morning, but just, again, that strong commitment to making sure that we are really tackling the mental health crisis in our country, and in particular in our Asian American, Native Hawaiian, and Pacific Islander communities. To have that commitment coming from the very top, the highest levels of government, I think has been so tremendous and such a great opportunity for us to highlight so many long-standing challenges and barriers that have long existed, but were truly exacerbated over the past few years of the COVID-19 pandemic. And so really grateful again to all of you here today. Each and every one of you were invited, as has been reiterated multiple times throughout the program, because of the unique expertise, the communities that you represent, the roles that you hold, and again, we're so grateful to all of you for participating in this all-day, full-day event. I also want to thank, as I mentioned, Lark, but also her entire team. I'm glad she was able to share the list of names of so many people who worked on this summit for months and months to put this together. I also want to recognize from my team, from the White House Initiative team, Vivian Chow. Vivian, if you can stand up. Vivian was really the lead from our end, and Deanna Jang too. I'm not sure if Deanna is still in the room. I know some of our team is also out in the main lobby, but so again, these two have really been the points on our end for the White House Initiative, and have been working with Lark and her team day in and day out, as you heard, exchanging emails up to like 2 or 3 in the morning sometimes. And so there's a lot of effort that goes into putting together and curating an event like this, and we're just really grateful again to all of the staff. We also have a bunch of other White House Initiative staff and interns and detailees who are out in the main lobby, but they have again been putting in such tremendous hours and work to make this possible. So I really want to thank all of them and acknowledge them for their support. So, before we close, this is one of what we hope to be ongoing conversations and dialogue with all of you. I know that was really reiterated multiple times throughout today, but this is not, just like a one and done thing. Okay, we did the summit and we're never, going to communicate with anyone ever again. This is really meant to be the launching pad for us to be able to engage in more robust and to also deepen that dialogue, but also to work towards concrete solutions. That is really the end goal. It's not just that we're going to do a summit, you're going to hear from us, and then never hear from us again. We really want to make sure that we are working towards concrete, actionable solutions that we can implement within the course of this administration. So again, like I mentioned, we have the support of the president, we have the support of the secretary, we have the assistant secretary who you heard from earlier. Through WHIAANHPI, we have actually a federal interagency working group comprised of over 45 federal departments, agencies, and offices that really help us to coordinate our whole of government approach to advancing equity. We have our commission, again, our commissioners are so critical to ensuring that the president is advised on ways to advance equity for AA and NHPI communities. So again, the synergy of all of the momentum that we have is something we do not want to lose, and we are going to be relying on all of you to also hold us accountable. So I know that was also mentioned many times today by a number of our senior government officials, but please, if you are not hearing from us, if you do not think that we are doing something that should be done, let us know, because we really value your input, your feedback, and we cannot and should not do this work without you. So again, thank you so much to everyone here joining us. Mahalo nui loa. Thank you very much. We're really grateful to all of you.
Okay, so now the most important piece of information. Whoops, that was not it. There you go. Please join us. We are going to be at Hamilton Bar and Grill and invite you to continue to mingle, continue to create relationship. It's important for us to have some time to be together in space that maybe is not as formal as this, but let your hair loose a little and come and join us and continue to meet new people. So please do join us. So Crystal mentioned again to the virtual audience. So just want to give a big shout out to folks who are joining us virtually. This was a long day to be on virtually. I want to give a shout out to my dad. He was watching us for 3 hours. Yay, Dad! All right, so I have, as I mentioned earlier, a poem that I would like to read to you. But first I want to just acknowledge all the incredible work that you all do every day in your communities. And it is important for you to take care of yourselves also. And so I want to offer us this time to do a little refresh and get a little grounded before we go on with our day. So I'm going to invite you to sit in your chairs, plant both of your feet on the floor. Spend a little time quieting your breath and slowing down your breath, and breathing through your nose and out through your nose. And you're welcome to close your eyes as you listen to this poem that I'll read to you. Maybe think about taking a breath in for 4 or 5 seconds and a breath out for 4 or 5 seconds. And continue on that cadence as I read to you The Radical Gratitude Spell by Adrienne Marie Brown. You are a miracle walking. I greet you with wonder in a world which seeks to own your joy and your imagination. You have chosen to be free every day as a practice. I can never know the struggles you went through to get here, but I know you have swum upstream, and at times it has been lonely. I want you to know I honor the choices you made in solitude, and I honor the work you have done to belong. I honor your commitment to that which is larger than yourself and your journey to love the particular container of life that is you. You are enough. Your work is enough. You are needed. Your work is sacred. You are here, and I am grateful. Thank you, everyone.